Hello.
Yeah,
Over to
Dr.
you, Sir
Kamlesh, you
Bala
may
ma'am.
start. Yes.
Yes, ma'am. So, good afternoon, everyone, from those on to this side of the world, and good morning to those who are on the other side of the world. So, at the outset, I must thank the organizers for giving me this opportunity to be associated with this prestigious conference. And I congratulate the organizers for undertaking this very important theme for this conference, that is behavioral disorders and the substance use disorders, because this is taking the shape of a public health problem and going on exponential measures. So, once again, good morning to everyone. And now I would like to introduce our first speaker of the day of this conference, Dr. Yatan Pal Singh Balhara. So, Dr. Yatan Pal Singh Balhara, he is the professor of psychiatry at All India Institute of Medical Sciences, New Delhi, and he has several achievements and awards honors to his credit. He is the recipient of various prestigious fellowships and awards from the national and international organizations. He has a very long experience in running the dual diagnosis clinic and behavioral addiction clinic and serving as the Secretary General of the World Association on Dual Disorders. Dr. Yatan offers consultancy to WHO and UNOCDC. He is a global master trainer on drug demand reduction to the Colombo Plan and UNODC. He is a member of the various national international committees and expert groups on addictive disorder. So it is our honor that we have a very expert in the field who will be speaking on the topic of behavioral and substance disorder among the older adults versus the younger adults. Because this problem is becoming more and more unpredictable, and also the elder population is increasing. So I believe it is very pertinent that we take a stock of the factors which predispose or make these populations more susceptible to such disorders, and how we can cater these. So over to Dr. Yatanpal, please.
Thank you, ma'am. Thank you so much. So, if I can be allowed to share screen, yeah, I'm trying to do that now. So I hope my slides are visible now. So once again, a very warm good afternoon and maybe good morning for some of you who are joining from other parts of the world. So I begin by thanking the organizers for this opportunity to share my thoughts with this group on this a very important topic, as the chairperson has very rightly said. This is an issue of today. This is a challenge of modern times. And the way digital technology is part of our life these days, we can expect that this is going to stay with us as a challenge in the years to come as well. So I totally agree with the relevance and importance of this particular theme. So in the next, I believe I have around 20 minutes left. So in the next 20 minutes or so, I'll be focusing on this particular topic that has been assigned to me. And I'll be focusing from the age perspective, because that's the core theme of this year's conference. So my perspective will be not to tell you everything about addictive behaviors, but my focus will be specifically in context of older adults. And I'll try to kind of put together what literature and evidence tells us when we look at addictive behaviors in older adults as compared to young adults. Now, just to ensure that we all are on the same page, the word addictive behavior here means people who are engaging in compulsive behavior despite of having some negative or some harmful consequences. So for the purpose of this presentation, these are process addictions and not chemical addictions or substance use disorders as we call them. So I won't be focusing on that bit. I'll be talking specifically in context of addictive disorders and addictive behaviors. Now, to begin with, why is this question so important? I mean, behavioral addictions in itself is a topic worth discussing, but why is it so critical that we look at from the perspective of age? Why older adults versus young adults is such a critical question that we need to answer and discuss. Now, in medicine, if you look at health conditions or even medical diseases, age is a very important determinant of health as well as disease states. So what that means is when you look at populations across different age groups, for the same health condition as well as for the same disease conditions, age plays a very critical role. Think of any medical disease that comes to your mind and just try to look at it from the perspective of children having that condition vis-a-vis adolescents having the same condition, then adults and even elderly. You will find there are typical straightforward differences. Now, these differences can be in terms of prevalence. Some diseases are more common in children, some are more common among elderly. The nature of risk factors, they can vary. What predisposes children and adolescents to a particular disease may be very different from what predisposes adults to the same disease. The way these conditions they present, that is the clinical symptoms and signs, they can be different. And of course, the long-term course, prognosis and outcome, age plays a very critical role in deciding and defining all these aspects of each and every health condition that we cater to as part of our clinical work or teaching or even research work. Now, the same is true for age and addictions in general as well. And here by addiction, I mean all kind of addictions, including substance use disorders. So if you look at literature, you will find that typically prevalence of substance use disorders is higher among young adults as compared to elderly or older adults. Similarly, the nature of risk factors can be different. Among young people, they may start using substances out of experimentation or because they want to feel the high of it. While among older adults, there may be other issues like pain or sleep disturbances. And those can be the risk factors that predispose that age group for increased use as well as increased risk of addiction to substances. Clinical presentation, it varies. People who are elderly may be having more chances of having co-occurring physical health conditions because of their general decline in general well-being and health, decline in bodily reserves as compared to younger adults. The course may vary. Typically, young adults, they tend to have more relapsing and more waxing and waning course as compared to older adults. And there is some research that suggests that as people grow older, the outcome tends to improve in context of addictions. So in addiction field in general, age plays a very critical and important role. But is that true for behavioral addictions as well? So that's the question that I'm trying to address in this presentation today. Now, when we think of agents which lead to addictive behaviors, there are multiple, but since most often we discuss issues related to use of internet and digital technology, then in context of addictive behaviors, the picture is kind of unique. Unique in the sense that when you look at older adults, people who are older than 60 years or 65 years, as a cohort, these are the people who did not grow up with internet because during their teenagers, internet was not actually available to public the way it is as of today. The same is true for smartphones as well. Although they started to come to market in 1990s, but it was in 2000s when people started to actually use them at a larger scale. And if you look at many other things like social media, online gaming, online content, online video watching, those are the phenomena that started to grow in late 90s, and it was not until 2000s when people started to use them at a larger scale or in larger volume. So what it tells us that this cohort of people who are elder than 60 years as of today, they did not get exposed to these agents of these health conditions at least when they were not until they were in their late 20s or even 30s at times. So what it means is, it is likely that they will react differently to these from as compared to those people who are growing up with internet and devices even during their early childhood. So there is a logic, or there is a reason to believe that older adults will behave differently when it comes to technology and other addictive behaviors. Now, this leads to many contexts that we need to keep in mind. So what it means is, if you look at older adults and addictive behaviors, the age of first use of these devices or internet will be relatively late in life as compared to younger cohorts of people. At the same time, since they started late, the cumulative exposure in terms of years they have been exposed to digital technology and internet or smartphones, that would be much less as compared to younger adults. The way these devices and technology, they have become part of their daily routine, that will be very different. Since you have grown up with these devices and this technology, it is more likely to be integrated as part of your daily living. For example, for a teenager, a smartphone may be the first thing that comes to their mind if they have to connect with somebody. For somebody in their 60s, it may not be the first option that they have in their mind. They might think of some other alternatives. Similarly, people who are older adults, they are used to living life in a way, or at least they were used to living life in a way which was not centered around these digital devices and internet. So again, there are many logical reasons for us to consider, and that they should kind of make us think that yes, probably there should be a difference between younger adults and older adults when it comes to addictive behaviors. But is that the reality? Do things they pan out the way what our logic tells us? Now, uh, the data on this particular issue is of two kinds. There is one kind of data that is from the field of addictive behaviors, and that is the disease part of it or the pathology part of it. And then there is data which comes from general usage perspective. For example, this data that I'm showing you here, it's data of US adults about their ownership of these devices. Now, what I want you to please keep in mind is that when I'm talking about use of devices or even gaming or gambling, it does not automatically mean that I'm talking about a pathological state. This may be absolutely normal, absolutely healthy, but since this physiological or healthy pattern of use can predispose to a person to pathological use, I'm using some of the statistics from the general usage as well. So if you look at people who have their own device in terms of a phone, this data is from United States. It can vary for different countries, including ours, but I have just given it as a reference for us to kind of appreciate the variation that I'm talking about. So if you look at people who own a cell phone, right from ages 18 to 29 until 65 plus, more than 90% people in United States, they own their own cell phone. But if you look at the second row in this table, which talks about ownership of a smartphone, this figure varies significantly. Among younger age groups, the ownership of a smartphone, of the cell phone being a smartphone, is very high. Almost all the people who have a cell phone have it in a form of a smartphone. But when you look at people older than 65 years, this proportion goes down. So what it means is, probably those who are older adults, they are less likely to have access to smartphones and as a result, even internet. So does that mean they are not as often exposed to these agents as compared to younger adults? And that's a question that we will find an answer to very soon. This is again data from United States. Again, not pathological use. The word dependency here does not mean the dependency in terms of the diagnosis that we talk about. So here dependency means that among these age groups, uh, how how many or what proportion of respondents they depend on a smartphone use for their online activities. So what it means is, if they are dependent on smartphone, it means smartphone is their primary device to access internet. Low level of dependency does not mean that they don't use internet. It simply means they may be using it through different means, like a laptop or a desktop. So again, here there is a very unique picture. So in the cohort of ages 18 and 29, the proportion is the highest, and that has been traditionally the case for many years now. And one can imagine, yes, that should be true, because teenagers, they love to have their own devices, own phones. But what is interesting is that beyond that age of 29, dependency of individuals on smartphone as their primary devices is highest among those who are 65 years or older. So what it means is that people who are in their productive years in terms of being in a job, or who are responsible for making a living by working, they may not be using smartphone only as their main device. They may be having to use laptops or desktops or tablet, because it may be a need for their professional requirements. But once you cross that threshold of 65, since you no longer need those devices as part of their work, probably you start to use smartphone, or you need smartphone again much more often. So what that means is that at this age, the exposure to some of these apps, which are most often used on a smartphone as compared to a laptop or a desktop, that risk is going to increase. And that reflects in some of the data that is available to us. Now, this is a chart of people who use internet and who report that they have played at least one video game once using that device. And you can see, even among those who are 65 years and older, 55 years and older, it's not a small proportion. Majority of people, they acknowledge that they have played at least a game at least once. So even among elderly, some of the phenomena like gaming, which we typically associate with teenagers or younger adults, it's not that uncommon as we kind of assume. Again, I'm repeating that it does not mean that they have pathological use, but gaming as a behavior, as part of their life, exists even among those who are elderly. Now, that does not mean that there is uniformity across ages. We need to kind of keep that in mind. For example, this data that tells us that why people across different age groups, they access internet, the reasons are very different as compared to a teenager, for whom the most common reason is to connect with friends and family. It may not be the first reason. For example, at the age of 65 plus, finding information is a more common reason. So despite of people who are older adults using internet quite a lot, the purpose or the reason behind their usage may not be similar as young adults or even teenagers. In addition, what is different in this age group is that the amount of time that they spend using internet is also not similar as compared to younger ages. But at the same time, it's not very small as well. For example, if you look at people in the age group of 65 plus, they are spending more than 4 hours on an average among females, and around 4 hours among males. This is less than the younger ages, but it's still a substantial part of their daily time that they are spending using internet. The same is reflecting in the behavior in terms of the preference of using social media platforms. So among younger ages, Instagram is the most popular one. But if you look at the older age groups, WhatsApp is the most commonly used social media platform. So the point I'm trying to make is that within that larger group of addictive behaviors, or behaviors that could potentially be addictive, the preferences, the duration of exposure, it tends to vary among older adults as compared to younger populations. And the same also reflects in terms of the preference. For example, I mentioned a large proportion of older adults may be playing games, but the kind of games that they play is different. For example, in this particular study, in those who were older, the most preferred game, first, second, and third, were puzzle-based games. While as come in the younger groups, the type of game that they play most often, it is different. So the nature of games that they play can vary between these two age groups. The same is true that why they play games, why they start playing games. So in younger people, it's typically a friend who kind of is already playing, and this friend leads them to play this game again. But in the older age groups, it's not somebody that is known to them as a friend. It's a person besides and beyond their family and friends who invites them to participate in these games. So the influencers or the influences on their gaming behavior, it also varies at that age. Also, what is interesting is this is data from United Kingdom. It shows that among older age groups as compared to younger age groups, the proportion of players who play online games, it goes down. So many times older age group people, they play offline games. They are using the devices, but it may not be an online game that they are playing. So that proportion is also different in that age group. Now, what we need to keep in mind is, if you look at the data from the problem related literature or disorder related literature, the literature is rather limited. Most of the literature is about gambling. So this is a study that compiled the evidence on gambling disorder prevalence across different age groups. And you can see the findings, they vary across different studies. So I've highlighted some of the studies that are highlighted using a red arrow. You can see that prevalence of gambling may be higher among older adults or at least similar as compared to young adults. While in some other countries, the prevalence among older adults may be lower. So there is no uniform pattern in terms of prevalence. In some settings, in some countries, for certain conditions, the prevalence may be higher among older adults as compared to younger populations. Uh, Although there is some change that is noticeable, for example, this particular study, they tried to explore the proportion of people who tend to spend more than what they think they should have while they were playing games and they were making in-game purchases. The proportion goes down as you grow older. So there is a possibility that despite of people in this age group playing games more often, they may be more sensible in terms of the way they are spending their money, and they may not be making decisions that they think they should not be making. So age may be playing a role there as well. There are studies that have tried to explore what is the mediating mechanism, why this variation happens in older ages. And I'll cite a couple of examples only. So this is one study that explored smartphone addiction among older people, and they recruited participants 45 years and older. And they found out that smartphone addiction is determined through a host of intermediary pathways, including cognitive decline, which we know happens as people grow older. Uh, Family relationship conflicts, another concern that is important and that determines smartphone use among older elderly people. Feeling of alienation. They don't feel part of the group or the society that they belong to. And of course, using the devices or smartphone may give them this feeling of having the power to kind of control what's happening in their life. So you can see that the determinants or the intermediary factors are also very different in this age group as compared to younger cohorts. And it has been seen in multiple contexts. It has been seen not only from the pathology perspective, but there is a lot of literature that talks about benefits of using smartphones and internet among elderly. And it has been seen that for a large proportion of these people, smartphones may be a way or a mechanism to engage socially, for them to feel that they are still relevant in their groups. It may be a leisure activity. It may be a means for them to connect with their friends. And in all these contexts, it has been seen that those older adults who use internet, they are likely to have better mental health outcomes as compared to those who are not doing it. And there is other literature as well that has highlighted this. For example, this study where simple use of a social media app called WeChat, those older adults who were posting messages, they reported having better mental health as compared to those who did not do so. But the problem is that this is a phenomena that is still focused primarily from younger age groups perspective. We have recently done a systematic review and meta-analysis, and we could not find even a single study that included participants more than 50 years of age. So this was about treatment for different addictive behaviors: gaming, gambling, screen time, pornography, buying, shopping, OTT watching. Not a single randomized control trial or a non-randomized control trial that has recruited participants older than 50 years. So that's the limitation in terms of evidence that we have. There is limited research. The research is restricted to only a couple of countries in terms of this age group. There are no longitudinal follow-up studies. And of course, we have no data on what is the evidence-based interventions for this age group. So we are left with using our common knowledge or understanding of addictive behaviors in general, and then we tend to extrapolate it to this age group. So I'll stop here, and I'll be more than happy to take questions if there are any. Thank you so much.
Thank you, Dr. Yathan. Actually, yes. In the chat box, I don't really see so far any questions. In case anybody has, please, you can either speak up or you can post your questions here.
Please post your questions in chat box. We will read it.
So, what I'm getting from the presentation, first of all, you made it very, very simple to understand. So, what I'm getting is that we have very diverse kind of reasons when it comes to the accessing of the internet and indulging in this addictive behavior or disorder. And the other one is the influencers. We have the influencers both sides of this group, but only thing, the influencers are different here. But then how do we really say ki whether if it is pathological or not pathological? Because your last couple of slides are highlighting that it could rather be beneficial for the elderlies rather than being harmful. So is it something, and when we say that, is it something to be okayed, and is it something that we encourage rather than discourage? I know that for those people who are feeling lonely, this might be a good measure to engage themselves. But then how do we draw the line, and where do we draw the line?
Thank you, ma'am. A very, very important observation made by you. So that's one of the messages that I want to get across, that many times, especially in context of addictive behaviors, our reflex approach is that this is something that is bad. A technology is going to hurt us, and we should avoid using it. So what is important is that we need to look at it from the perspective of the context. So when you look at people who are beyond a particular age, you need to see what are the other responsibilities in their life, what are the challenges that they are having in their life, and where does technology fit in. For example, if there is a person who is not ambulatory because of age-related decline in muscle power and strength, not able to walk around, maybe doesn't have anybody to take them somewhere, for that person, a social media app can be a blessing because it helps that person to connect with others. But at the same time, we have to keep in mind that there is evidence that says that if people don't engage in cognitively stimulating behaviors, it can lead to certain adverse outcomes, including relatively poor memory. So if they are using that social media account only to scroll through videos and messages that have been forwarded to them, and they are just passively using it as a leisure activity or a pastime, then it can lead to pathological outcomes. So it's a very difficult question to answer that, okay, this is okay and this is not. My understanding is that we have to see it in the context of an individual person. We have to see whether technology is facilitating their life or whether it is distracting them from something better that they can do. So if there is an alternate beyond devices, they should choose that. But if they don't have an option, this can be a solution to some of the issues like loneliness, being alienated, feeling left out. So it can be used both as a beneficial tool as well as a potential threat to their mental well-being.
Thank you so much for answering that. And I believe that we still have to go a long way. We don't really have much of the data in this regard because this is the population that is upcoming of the age using the internet and gaming behavior, gaming technologies. So maybe we could call it like the morphine of the palliative care, where we have to be using it, but allow this with caution. So thank you so much once again, Dr. Yatan Pal Singh. It was really, really very interesting and very simplified because this is a very complex kind of subject, but you made it so simple that I'm sure that everybody is happy and they are going with some key takeaways. So
Thank you.
thank you once again.
Read out. There is a question in the chat box. Kamlesh, can you hear me?
Yes.
Yeah, ma'am, there is a one question in the chat box.
Okay, okay. I will check. Okay.
You
So
have stated that in one of the studies, they have found that the older adult found to be more mentally healthier than other age group. Is it a method of engaging oneself into the cognitive perspectives or social?
Yeah.
This is the question.
Yeah, thank you for this question. See, uh, what this study was about, it was about asking those older adults who were using social media in terms of connecting with people. Now, what they were comparing is as compared to those who felt lonely or who felt alienated because there were no people around them to kind of interact with or communicate with. They found that people who used a social media platform as compared to those who did not, they reported better well-being. Now, social media in this context can be seen as something that helped these people connect with the world around them. But if the levels of subjective feeling of loneliness, they were not high, then social media use did not give them any advantage in terms of their mental well-being. So what it means is that if you are an elderly and if you have people who are living around you and you feel connected to them, remain connected that way. Don't shift to a social media saying that it will lead to better health. But if you are not living around with people and you find it difficult to connect with them, then using this platform can be a solution. So you have to see the context of the person. Uh, so these studies, they have these limitations, so the results have to be looked from that perspective. What is the baseline from which we are comparing? So if you're already feeling lonely, then yes, this will improve your mental well-being. But if you're not feeling lonely, it will not add to your mental well-being.
I have a
Thank you so
question,
much, sir.
Dr. Yatan.
Thank you for the
May I
answer.
ask, Dr. Kamlesh, may I ask a question?
yes, ma'am, please go ahead.
How we will plan the treatment strategy, keeping this age issue in mind?
Ma'am, so in terms of management, these days we are using pharmacological as well as non-pharmacological interventions. So for pharmacological, we have to follow whatever we do typically, like the risk of side effects may be more, we start with a lower dose. So that is rather simple, I would say. In context of non-pharmacological interventions, we have to ensure that our interventions and our approaches are age appropriate. So what is happening is typically most of the people, they work with adolescents and young adults in addictive behavior context. So the reasons are very different. A reason an adolescent plays a game and an elderly plays a game are very different. So when you approach them it from a therapeutic perspective, that has to be kept in mind. Second, uh, typically when we work with a patient who has a problem, we give them solutions and we give them something to look forward to. So for an adolescent and a young adult, it may be a career that is at stake. It may be an exam that is coming up, which they will not do well if they are not devoting time there rather than playing games. But when you're talking about somebody who has retired, living a life where there's no other activity or responsibility left, so those purposes have to be different. So that is another difference that we need to keep in mind. Third, we also have to keep in mind that when we suggest alternatives, so for adolescents, we typically suggest that, okay, get out of the house and go in the playground, do some activity that is physically engaging. But people who are older adults, they may not be in the physical health that permits them to engage in those activities that way. So those solutions again have to be different. So these are some general age-related changes that we need to keep into mind while we are planning their therapy. Also, we need to keep in mind is that there is another area that I did not talk about because I did not have time, that for many people who are older adults, internet is a source of information or misinformation, the way they kind of utilize it. So we have to look at it from that perspective as well. So the solution actually is not in terms of taking the device away or restricting the internet use. It's more about aligning the use in a way which does not lead to a problem or a pathology. So that's the broad approach that I think we can take while we are working with this population.
Also, what about the assignments being given by teachers in such a way that they will have to use internet?
So that's a good thing. Most of the elder adults won't be in school, so we can not use this as a reason for them to engage with the online behavior. But I agree that's the demarcation that we need to have. So typically, at least I don't go by that approach that don't use technology. So internet is here, it's going to stay, smartphones are here and they're going to stay. So the focus has to be how to live with them rather than how to stay with them, stay away from them.
What is
So
the
that
opinion on the blocking of certain sites, and what is your opinion on, creating special Google and Moodle and other things for children and block other things? What is your opinion on that?
Ma'am, there are countries that are trying to do that, like Australia has banned social media at less than maybe 16 years of age. The problem with that approach is technology is easy to be bypassed. So simply blocking something does not prevent access. We know there are so many platforms that are blocked in our country, but we get people who are able to access them. So I don't think at a larger scale that will bring in a change, but yes, at an individual level, it can happen. So if you are talking about a household where parents are able to ensure that the child will not have access, it might work. But then what happens at times is we have seen that children, they try to find way around that ban or restriction. So the parents can ban it on their phone, their laptop, but they cannot do it on their friends' laptops and phones. And then they try to find a way to kind of reach that place, be there, find excuses to do that. So it may not be very simple in my opinion, but yes, countries are trying it. Let's see how it pans out.
In fact, I think that is the another question that we have in queue: how to deal with children who are addicted to online gaming.
Oh, I thought I'll be
Very
spared this one because we are talking about older people. See, I can't give you a one-line answer to this. So I'll give you what we do at AIMS. We run a clinic called Behavioral Addictions Clinic. So the first step for this is we need to acknowledge that yes, it is a health condition. It is a mental health condition. It needs assessment. It needs to be diagnosed, and then we need to plan a very structured intervention. At AIMS, we use both medications as well as non-pharmacological interventions. It has to be an ongoing process that lasts for a few weeks. Parents have to play a very critical role because, unlike many other mental health conditions, they have to be a part and parcel of the daily routine of the child. Uh, there are many things that we do in terms of behavioral modification, planning of the day, scheduling activities, working with them when they tell us that okay, their friends are doing it, what should I tell them? Or if I feel like doing it, there is nothing else for me to do, so we have to give them answers to those questions. So it's a mix of multiple therapies, eclectic approach, motivational interviewing, cognitive therapy, behavioral modifications approach, and of course at times we use medications as well. So it's a very structured approach that we need to take.
Thank you. Thank you, Dr. Yatan.
Thank you.
Our last question here was from one of the delegates who is actually undertaking a study among the college students regarding digital well-being, and he or she wants to know that how to generate awareness among this population about the digital well-being.
See, one thing is that we need to talk about it. So let me give you a very practical example here. So I have been talking about behavioral addiction since 2016 now, but this is the first time I have ever been invited to talk about behavioral addictions in older adults. So this is the kind of focus this condition gets, because the focus is so much on young people, adolescents and children, we tend to forget older adults. So one is we need to prioritize this. It's not a situation or a phenomena that is restricted to a particular age group. We have to talk about all age groups. We need to start that conversation. And in events like this, I think we should have sessions on this. Plus, we need to focus from the research perspective as well. We need to do studies. We need to generate data, which guides us that what is it that we need to do specifically for that age group so that we can give them age appropriate answers for their problems.
Thank you. Thank you, Dr. Yatan, once again.
Thank you.
So I believe that would be it for this session. Over to the organizers.
Thank you, Dr. Yatan. I myself, being a senior now, sometimes wonder, we tend to use our phones so much, and we don't even realize we are using the phone, and not looking outside at nature, etc. So is that something in looking at brain disease model of addiction, or is it something else? Our next thematic session is actually on this. It is the brain disease model of addiction, is it harmful? Let's look at it, and it gives me great pleasure to introduce our chair for today, Dr. Siddharth-CARE, who is additional professor, Department of Psychiatry and NDDTC at AIIMS, New Delhi. Okay, with more than 13 years of experience after MD in psychiatry. The co-chair is Mr. Atul Sharma, who is an assistant professor in the Institute of Nursing Education and Research at AIIMS, Bathinda. So I ask both of them to take the lead now with this particular session in introducing our speaker.
Thank you very much. If I may begin, Mr. Atul, is that all right?
Yeah. Yes, sir. Definitely.
Yeah, so it's a great privilege today to hear on a very important topic by Dr. Lee Hogarth from Exeter University, and he will be talking on a very provocative issue of whether the brain disease model being harmful or not, right? And he has quite an established career with an H index of 43, more than 5,000 citations. He has been guide to several PhD students, and he has a lot of grants as well. With this, rich experience as well as a lot of academic credentials, it is quite quite a privilege for us to hear him on this topic. Over to Mr. Atul as well for his introductory remarks. Thank you.
We are really happy to have with us Dr. Lee Hogarth, who is an extraordinary person in the field of psychiatry, and he has in his credential many things. So we would like to see what about the brain disease model of the addiction, which is a very helpful model which to reduce the stigma, support access to the treatment, and explain the biological changes which involved in the addiction. So I request organizers to please share his video.
Hello everyone, I'm Lee Hogarth from the University of Exeter, and I'm going to give a talk on what's wrong with the brain disease model of addiction. So here you have Koob and Volkow, 2010, describing addiction as due to various neural processes with a complex thesis about where the damage or fault lies in the brain, which gives rise to addiction. Now that may seem like a perfectly sensible form of scientific discourse, but the question I'm going to address here is whether describing addiction as biologically determined and de-emphasizing social inequities, whether that actually in fact harms substance users. So in this slide, I want to give more detail on what the brain disease model of addiction actually is. So I've summarized it with James Liu in this recent paper, where we summarize the BDMA as placing explanatory weight on drug-induced brain changes at risk endophenotypes, i.e. biological risk factors, and the emergence of intellectual frontal dysfunction and the formation of compulsive drug-seeking behavior, which is automatic, thoughtless, unintentional, and relatively uncontrollable. Now that summary is our words, and where it's not verbatim from the main players who have been proposing the brain disease model, Nora Volkow and George Koob. So I just summarise describe one of their abstracts of this particular paper here, where they describe what the brain disease model of addiction is. And you can see it's a whole range of concepts embedded within the brain disease model. So they state, we review findings on the desensitization of reward circuits, which dampens the ability to feel pleasure and motivation to pursue everyday activities. They look at the increasing strength of conditioned responses and stress reactivity, so sensitivity to stress, which results in craving for drugs, alcohol and drugs, and negative emotions when these cravings are not sated. They talk about the weakening of brain regions involved in executive function, decision-making impairments, inhibitory control, impairments and inability to self-regulate, which leads to relapse. They also review social environmental factors and in developmental stages and genetics and how that plays a role in addiction. And they conclude neuroscience continues to support the brain disease model of addiction. So they do say something about social determinants of addiction, but it's fairly minimalist compared to the range of other constructs they use to explain addiction, which are all to do with individual dysfunction. Many scientists and medics have offered critiques of the brain disease model, and this is one of my favourite from Robert Kendall, who was Chief Medical Officer from 91 to 96 and was in fact a medic. From quite a few years ago, 1979, so you can see the critiques of the brain disease model have been long lasting. And this is quotes from his paper, which I think is still relevant 40 years later. So he says, for the past 20 years, the disease concept has been everyone's official dogma, with medical organisations, alcoholics themselves, and well-meaning people speaking on their behalf, all urging governments and employers to accept and act on its implications, the disease concept. So much of our research is based on the assumption that there is some crucial difference, i.e. some biological difference or psychological difference, either in the psychological makeup or the way in which they metabolize ethanol between those destined to become alcoholics and the rest of us. So he believes, Robert believes, there is no realistic prospect of any of the caring professions, individually or corporately, being able to cope effectively with the disability and suffering caused by alcohol abuse in the foreseeable future, even if the human and material resources available to them were being greatly increased. So this is a heroic statement, because as the chief medical officer, he stood to gain funding for the treatment of alcohol if he'd have argued that that medical science was able to deal with it. But he eschewed that funding and instead said, indeed, it's a political problem. So he concludes, until we stop regarding alcoholism as a disease and therefore as a problem to be dealt with by the medical profession and accept it as essentially a political problem for everyone and for our legislators in particular, we shall never tackle the problem effectively. So his prediction for the period up until now was that addiction wouldn't get solved by the biomedical approach. And indeed, we still have an addiction problem, so perhaps his prediction was correct. So contemporary critics of the brain disease model have argued that not only has it been ineffective in solving the addiction problem, but it's actually has social justice harms embedded within it. One of the high-profile critics is Carl Hart, and this is his paper from 2017. The title is "Viewing Addiction as a Brain Disease Promotes Social Injustice." And he states, "We are nowhere near being able to distinguish the brains of addicted persons from those of non-addicted individuals. Despite this, the diseased brain perspective has outsized influence on research funding and direction, as well as on how drug use and addiction are viewed in society. Notably, there has never been such an ambitious effort focused on psychosocial determinants or consequences, for example, employment status, racial discrimination, neighbourhood characteristics and policing of drug use and addiction. There is neither need nor interest in understanding the role of socioeconomic factors in maintaining drug use." Now, this may be slightly overstated. People do research on social risk factors for addiction and recovery. The question really is the amount of funding and the amount of effort that gets put into social structural determinants as opposed to biological determinants. So the question for me as an experimental psychologist is what study designs I can use to test whether the brain disease model of addiction is harmful. And the methodology I've been using is the framing experiment, where you describe something in one way in one group and in a different way in another group, and you test to see whether those descriptions influence the participants' expectations or beliefs about that thing. So Haslam and Cavalli have, in their mixed blessing model, have summarized framing studies where mental health conditions, broadly, so depression and anxiety, have been described as being biologically determined versus a control vignette. So they could either say mental health is socially determined, or they might not say anything at all. So, for example, the key condition description would be of depression as being, like, for example, genetically determined, to see what effect that has on people's expectations. And the summary of the findings of these framing studies is that biological framing of mental health conditions implies that the mental health condition is uncontrollable. So biogenic explanations make you think that the mental health condition is uncontrollable, and it's essentialist, i.e. it's due to individual constitution. It's, the essence of the individual is where the fault lies. And this construction has the benefit of reducing personal blame. If you think the disease or the condition is uncontrollable, then it's not your fault that you got that condition, and reduced blame is arguably a benefit. But it also has these harms. It increases prognostic pessimism. So if you think it's the disorder or the condition arises from something faulty with the essence of the individual, then their chances of being able to solve that is fairly low, or lower than otherwise. And so people who suffer from the conditions believe that they're less likely to recover, and observers of people with those conditions think that they're less likely to recover. But also you get these stigma effects, which is where if you think the person's disorder arises from their individual essence, then you wish for more social distance, and you also perceive them as more dangerous. So it's a mixed blessings model, because you've got the biogenic framing, diminishes blame, but it also has harms of prognostic pessimism and social distance and dangerousness. So most of the framing studies that have been done have been on mental health conditions rather than addiction per se. But there's a hot debate at the moment as to whether the brain disease model of addiction is in fact harmful. And a lot of this work is summarized in this book, Evaluating the Brain Disease Model of Addiction, edited by Nick Heather. And obviously Nick Heather and Stanton Peele, they believe that the brain disease model is harmful. And so Heather says, while this biology-based definition of addiction aims to alleviate the moral judgment, discrimination, and stigma associated with drug use, evidence suggests the brain disease model has only furthered stigma associated with addiction, leaving addicts increasingly vulnerable to exclusion and marginalization. Similarly, Stanton Pill says, change in addictive behavior is usually self-initiated. Convincing people that they are not able to control the behavior is counterproductive. The dominant model of addiction, viewing people as passive victims, fuels addiction. So he thinks the brain disease model actually promotes the continuation of addiction, which would be very bad. So Nora Volkoff and George Cooper, in response to this, they're defending the brain disease model of addiction. They're saying, why is it so controversial? They argue the mere framework of the brain disease model has benefits in treatment, as it significantly diminishes stigma attached with addiction and gives hope for recovery to those fighting addiction. So they think the brain disease model will in fact be beneficial. So which is it? So James Layu and myself set out to test whether the brain disease model of addiction is harmful in his PhD, and these are the first two studies from his thesis. And in the first, he recruited hazardous student drinkers, and in the second, he recruited weekly student drinkers. And we split them into receiving either brain disease framing statements or value-based choice framing statements. And these were direct quotes from scientific publications. And so here's 2 of the 12 disease framing statements. And the first is, upon prolonged alcohol exposure, the behavior of an individual can gradually switch from controlled to compulsive. And the second was, the brain disease model holds that brain changes associated with repeated drug use impair autonomy and restrict addicted person's ability to freely refrain from drug use. And here's 2 of the 12 value-based choice framing statements. Patient traits and initiative are far more important than treatment type or intensity for recovery. Change in addiction behavior is usually self-initiated and self-propelled. So the disease statements are fairly pessimistic and to do with the brain. Value-based choice framing statements are more social and are slightly more optimistic. So here are the data from the 2 studies. How it's represented is like this. The outcome measures that we collected after the framing manipulation are listed here, and the 0 line indicates that there was no difference between the choice frame and the disease frame. Now, if the outcome measure is on this side of the 0 line, it indicates that that outcome was benefited by the choice frame and harmed by the disease frame, whereas data that's on this side of the 0 line indicates that the outcome measure was benefited by the disease frame and harmed by the choice frame. And what you can see is in experiment 1, most of the measures didn't show any significant difference. There was no change in alcohol choice, so there's no desire in alcohol wasn't changed by the disease versus the social frame. Alcohol craving wasn't changed by the disease or social frame. And self-efficacy of control over drinking, the belief that you could control drinking, wasn't changed. But what was changed was readiness to change drinking behavior in study 1. So people in this study, if they were exposed to the choice frame, they scored more readiness to change. So here's a couple of example items. So sometimes I think I will cut down my unwanted drinking behavior in this case, and I will change my drinking behavior in this study. So they were more willing to change their drinking behavior following the choice frame than the disease frame. In the second study, we changed it to readiness to change unwanted habits. So it wasn't just drinking, it was all addictive behaviors. And again, we got the same result. There was no significant difference in control cognition over unwanted habits. It was marginal. And there was no difference in general self-regulation. But the choice, people who received the choice frames were more willing to cut down their unwanted habits and change their unwanted habits. than were the group who had the disease frame. So that was a replication that readiness to change was harmed by the disease frames. So this was the final study of James's PhD, and it was more substantive, and we knew what we were doing a bit better by that point. So he recruited 1,200 UK-based weekly alcohol drinkers, and they were stratified into 3 severity levels by the Alcohol Use Disorders Inventory. So we recruited low-risk drinkers, they hardly ever drink. We recruited hazardous drinkers who drink quite a lot, but not to the clinical level of diagnosis. And we recruited dependent drinkers according to the audit thresholds, the standard World Health Organization thresholds for defining low risk, hazardous and dependent. And we exposed half of each group to a video, which one group got neutral frames, which was about UK geography, just explaining different aspects of UK geography. And there were 2 addiction frames. The choice frame of addiction had Professor Mark Lewis saying, so here's one example, so addiction is a choice to a degree, but it's a choice that is constrained by deep learning, associations and strong emotions. So it's suggesting it's a choice, and personal circumstances can change and that people will recover. So it's more optimistic, more social. The compulsion or the disease frame was Nora Volkoff saying, more pessimistically, describing some brain changes and saying they cannot stop taking the drug even though they may want to. And one of the core concepts of the brain disease model of addiction is that behavior is compulsive and that it's hard to control once it's established. So it's more to do with the brain, more pessimistic. And we compared their expectations about recovery following this manipulation. So following the video framing manipulation, we asked participants this particular question that we focus on here. It's how confident are you that you could reduce your substance use, which includes alcohol, smoking, vaping, and illicit drugs, or gambling if you tried. So it's confidence in the ability to control their addictive behavior, broadly speaking. And you can see this is the confidence measure here. And there were 4 responses. They could say not applicable, in which case we didn't include them in the analysis. They could say they had no confidence at all in their ability to reduce their addictive behavior. They had some confidence, or they were very confident that they could reduce their addictive behavior. And you can see this is the proportion of participants that made each response in these 3 low, some, and strong confidence positions on the scale. And you can see for the low risk drinkers, around about 50% of them either have strong confidence or some confidence that they could reduce their addictive behavior, and very few of them think they have no confidence. By contrast, in hazardous drinkers, they have some confidence, but there's fewer of them have strong confidence that they could reduce their addictive behavior. And similarly, in dependent drinkers, very few of them have strong confidence that they could reduce their addictive behavior. Some of them have, around about 50-60% of them have some confidence, but quite a high proportion of them have no confidence. So that means that validates this confidence measure as being clinically useful, because as dependence severity goes up, the confidence in the ability to control their drinking behavior or their addictive behavior goes down. But the key question is whether the compulsion, choice, and the neutral video modified confidence in the ability to reduce addictive behavior. And in the low-risk drinkers, there was a significant interaction overall. In the low-risk drinkers, there was no significant difference between the framing groups in terms of their confidence. But in hazardous drinkers and dependent drinkers, there were significant changes in confidence as a result of the framing videos. What you can see here is in the hazardous drinkers, in the choice video, there's a rightward shift in the distribution of their responses, such that following the choice video, there's more strong confidence that they can reduce their addictive behaviour and less low confidence than the compulsion video, whereas the compulsion video has a rightward shift where there's more low confidence and less strong confidence in the ability to reduce addictive behaviour. And the same pattern was also replicated in the dependent drinkers. Following the compulsion video, there's a leftward shift in the distribution such that there's more low confidence and less stronger confidence than in the choice video, where the distribution is towards more confidence in the ability to reduce addictive behaviour than no confidence. So again, that shows a harm of the brain disease frame on confidence to reduce addictive behaviour. So James's last study recruited drinkers online, but Daniel Casey, who was my DCLIN student, he wanted to test whether substance users who were engaged with treatment services for substance use would also be harmed by the brain disease model of addiction. So what he did is he interviewed 34 UK-based substance users who are engaged with the charity Way Through, who provide the drug and alcohol services, the recovery services in our area. And these participants, these 34 participants, had a long substance use and therapeutic history. So you can see they were 41 years old on average. They were mostly, well, they were all white, because that's how Devon is. They were in treatment for different substances, so 32% were in for alcohol, polysubstance was 32%, heroin was 23%, and other drugs was 11%. Their length of current treatment was about 2 years. The number of previous engagements with support services. So for some, 17% of them, this was their first treatment, but for the remainder, they had 1, 2, 3, or 4 previous sessions or engagements with services. The sum of days in the last 4 weeks where they'd used substances was about half, so they'd used substances about half of previous days. So they were still, most of them were still using, or the number of past substances used in the past 4 weeks were, so half of them hadn't used at all in the past 4 weeks, or slightly less than half, but the remainder had used either 1, 2, or 3 different substances in the last 4 weeks. There was not many days of employment, some days of employment, but a quarter of them were homeless or had housing problems, and about 50% of them had been received medication for addiction in the past. So as you can see, a fairly severe treatment-engaged substance use sample. So Dan manipulated the framing material in the following way. He asked participants to imagine the brain disease and social stress models of addiction being discussed in 2 hypothetical therapist-led support groups, and then participants rated their therapeutic expectations arising from each group. So what we're asking participants to do was imagine that the biological view of addiction or the social view of addiction was being articulated in a clinical setting, in clinical discourse, to see what impact it had on participants' expectations concerning their therapeutic outcomes or their recovery arising from each group. Now, the biological view of addiction was explained as involving vulnerable genes, automatic drug use, and brain changes being important for drug use. The social view of addiction was explained as involving social stresses, strong desire, and the use of drugs as a coping mechanism as the cause of addiction. So in the biological view, the cause was ascribed to the constitution of the individual, and in the social view, the cause of addiction was ascribed to the external world, leading to a coping response. So the results of Dan's study are shown in this figure. So compared to when a brain disease discourse was articulated in the hypothetical support group, articulation of the social stress discourse in the hypothetical group led participants to expect that they were more likely to recover from their drug use, i.e. more likely to quit or remain abstinent. They thought that they would have more therapeutic alliance with the practitioner within that clinical support group, and more therapeutic alliance with the peers within that group. Interestingly, when the brain disease discourse was predominant, the participants thought they would have less self-blame. So that was the benefit of the brain disease model, was the reduction in self-blame for addiction. In addition, participants generally agreed with the social stress theory of addiction more than the brain disease theory of addiction. Numerically, these weren't statistically significant, but numerically, participants thought they put more effort into the therapeutic process if this discourse was around stress and social stress. And they also thought that they would have better adaptive coping skills arising from a clinical group that discussed social stress theories. There was no difference in negative self-perception between the group with brain disease discourse versus social stress discourse. So this is what we've seen in the talk. We covered some theoretical and social justice critiques of the brain disease model of addiction, explaining why focusing on biological causes and de-emphasizing social causes of addiction might perpetuate social injustice for marginalized groups. And more specifically, we covered a series of framing experiments where substance-using participants were presented with framing material which described addiction as a compulsive brain disease versus value-based choice. And we found that these framing studies suggest that describing addiction as compulsive brain disease harmed dimensions of substance users' recovery capital, listed below, and produced only one benefit on self-blame. So the harms of brain disease discourse were reduced readiness to change, we saw that in 2 studies, reduced confidence to reduce addictive behaviour, we saw that in 1 substantive online study, and in the clinical study we saw reduction in therapeutic alliance, reductions in expected recovery in the brain disease conditions, and there was generally less agreement with the brain disease theory. The one benefit was that the brain disease theory led people to think they were less to blame for their addiction. So the question for clinicians who are working with substance users is how to construct a clinical discourse which does provide a biopsychosocial explanation for addiction, but which manages to maximize the benefits for clients and avoid the harms. And that's a difficult call, how to exactly construct the narrative to thread that needle. And I'll end by saying that at Exeter University, we run a Masters in Clinical Psychology headed up by Matt Owens, where we teach a lot of this material in how to construct forms of clinical discourse to maximize therapeutic outcomes. Thank you.
So thank you very much for this interesting proposition as well as exposition about the brain disease model and the critique and where can it be harmful. Dr. Lee, if you are around, can you answer one question that has propped up? Is the disease model of alcoholism compatible with evidence that alcohol harm is strongly patterned by social inequality, or does it obscure the political conditions that produce high-risk environments? A little longish question.
He's been traveling and he told me that
Yeah. All right.
plans are done, he will join in. Although he has registered for Zoom, but I'm sorry I can't see him in the focus right now. So maybe we can stipulate on your question, Dr. Siddharth.
Yeah, I think this is an interesting question that has been raised by one of the participants. And for the final comments to Atul, please. Thank you.
Dr. Siddharth, in India, it's very difficult to imagine this type of comparison.
Yeah, absolutely. So in India, as of now, the brain disease model has not taken hold in people's mind and the public imagination. So the critique holds true. In fact, most of our patients will subscribe to the view that addiction and their alcohol use has been shaped by their experiences, has a lot of social components, has a lot of moral component also, and not particularly that the brain disease model is is something that is they are looking for as an explanation. Though many people would be agreeing that okay, it is a disease, but nonetheless, many people initially come with the conceptualization that a lot of social issues are there, psychological, pain sometimes propels alcohol and other substance use disorder. So yes, this discussion is very timely, so that we do not go towards the other extreme of taking brain disease model as the absolute truth. No? The other view also holds true. Thank you, Dr. Sandhya.
Also belief of the patient. You see what patient believes. So your treatment also has to be adjoined with what patient believes. So patient's beliefs are also to be taken into consideration if you want good outcome of your treatment.
Absolutely.
It's not only the symptoms and the dependence and the withdrawal, but it is what he believes.
Absolutely. The point is absolutely.
Totally sociological model. So you have to understand what the patient believes.
Absolutely.
And then only recovery will take place. So the recovery will take place with multiple factors. The way risk is there with multiple factors to become dependent, same way you have to consider all factors for recovery also.
Absolutely, absolutely, and these were shown by the experiments, the smaller experiments that had been described in the presentation. So that actually brings in evidence to prove the thing that you.
He is in my another international group, so I told him to come here and present because his work is totally controversial, and nobody can imagine this much work is going on in this area.
Right. Thank you, Dr. Sandhya.
Thank you, Dr. Sarkar. Atul, please take over.
Thank you, Dr. Sandhya Gupta ma'am and Dr. Siddharth. Actually, that the topic was the brain disease model is a unique topic, which is I think it was the first time it is been in the some of the conference like this international virtual conference. So I think I would like to add like brain disease model of addiction also says that the addiction happens because of the brain changes, especially in the area of the control, reward, motivation, and decision making. Like we can say that, or we can learn with this, like with the examples like reduces the blame. Like example, one person who addicted to the alcohol, instead of thinking like Ravi or the person whoever it is, whether Ram or Ravi is a bad person, the people should start thinking like he is sick and he need the treatment. So this reduces the shame and the encourages the person to be in a help seeking attitude, so he'll be towards the help seeking way. So this way the brain disease model of the addiction works. In another example, some insurance companies, if they start agreeing to pay about the addiction, and they start like they recognize that this is a problem, this is a medical condition, so in that way, in that context also, like the brain disease model of addiction, it is going to be helpful in India as well. Thank you, Dr. Sandhya Gupta ma'am, and thank you, Dr. Siddharth.
Okay, I think you can wind up now, Dr. Atul, Dr. Lee's session.
Ma'am,
Yeah.
there is a hand raised by Tia Selna AO. She has
Kindly write in chat box.
Please write your question in the chat box.
Because we don't have the speaker today present, that's why I'm saying we cannot answer this question. As the
So
not present at present.
as we had a speaker, Dr. Lee Hogarth, who is a PhD from the Cambridge and working as a professor, associate professor at the University of Exeter in United Kingdom. Sir, we are really happy to have you, and we are really happy to had your video with us. And unfortunately, due to some unavoidable circumstances, you are not here. But whenever you are here in the conference, we really appreciate your terms, and then we will put up the question answers. Over to next plenary session, Edwina ma'am.
Yeah, I'll share my slide.
Yeah, yes.
So we have got the next plenary session on overcoming challenges in drug demand reduction, initiatives of UNFPA, UNDP, USAID, UNODC, and USAID Colombo Plan. Also on coping strategies and relapse prevention, age appropriate approaches for management of SUD. For this plenary session, we have got our chair, Dr. Ravindra Rao, who is a professor at All India Institute of Medical Sciences, New Delhi, and has been his area of interest and specialization is on community-based treatment for substance use disorder, also consultation liaison addiction psychiatry. Moreover, he has earned many awards on for the young psychiatrist, that is Tilak Venkova Rao Orientation Award. He has been a member of the Technical Resource Group for People Who Inject Drugs, constituted by National AIDS Control Program, Ministry of Health and Family Welfare. Also, he has been editor and e-news leader of Addiction Psychiatric Society of India. He has got 20 research projects in his hand and journal publications of more than 64. We have got a co-chair with us, Dr. Shrija I, who is a professor at College of Nursing, Anantapuri Hospital and Research Institute, Chakai, Trivandrum. Her achievements, awards, and honors. She has completed her BSc Nursing from AIMS, MSc Nursing from Psychiatric Nursing, AIMS New Delhi, and PhD from National Consortium for PhD Nursing, and has got 18 years of experience in teaching PG and UG. She has been a guide to many of the PhD students from INC, and her area of interest is geropsychiatric, community psychiatric, child and adolescent psychiatric, and addiction psychiatry. Welcome both of you, ma'am and sir. And we have got our speakers. Over to you, our chair, to lead the
Dr.
session.
Rao, please join.
I request Dr. Ravindra Rao, sir.
Dr. Soumya,
Yes, ma'am.
Ravindra Rao has not yet joined. And can you please make co-host Pushpa as co-host?
Sure, ma'am.
Dr. Rao is just joining. He has not yet joined. Pushpa, can you make her Pushpa Uran as co-host?
Yeah, made it.
Yes, please see if Dr. Rao has joined.
Yes,
Not yet.
Not yet.
He said he's joining. Let me see.
Co-chair Dr. Shrija.
Just join, ma'am. Ravindra,
Yes,
sir.
join, ma'am.
Soumya, could you please read his CV, Dr. Rao's?
Sure,
Just
sure.
you have already read it. Just show it.
I welcome Dr. Ravindra Rao, sir, the professor at All India Institute of Medical Science, New Delhi. Sir has won the Tilak Venkova Rao Oration Award from as a young psychiatric. He has been a member of the Technical Resource Group for People Who Inject Drugs, constituted by National AIDS Control Organization, Ministry of Health and Family Welfare. He has also been an editor and e-news leader of Addiction Psychiatric Society of India. And he has got 64 journal publications, more than 5 books, and chapter and monographs is more than 27. He has got 20 projects in his hand. I welcome you, sir.
Thank you. And I would like to thank the organizers for having invited me as a chair. for this plenary session, an important session. And we have got two esteemed speakers with us, and both of them with huge experience of working in the area of substance use disorder. So I'm sure all of us are very eager to learn what they have to present. So I would invite the organizers introduce the speakers and let the speakers start the session, please.
So you have to introduce the speaker.
Acha, I have to introduce? Oh, that's really
Yeah.
good. So I have the pleasure of introducing the first speaker, who also happens to be my dear friend, Mr. Adib. And Mr. Adib is a global trainer and educator. He has been active in the scene of helping people who use drugs in Maldives and has been instrumental in not only providing services to people who use drugs, but also in pushing for the right kind of policies and programs for Maldives, but also for other countries. And he has a number of achievements that you can read in front of you. He's a member of NADAC, National Association for Alcoholism and Drug Abuse Counselors. He's member of World Federation Against Drugs. He also has won Phoenix Award for outstanding contribution to the drug demand reduction field. So he has a lot of experience, and I'm sure we would be benefited very much by his presentation. So should we first hear from? Okay, we should also introduce the second speaker. So the second speaker is Mr. Francis. Once again, a very well-known name in the field of substance use disorder. He's a project director and chief trainer at MOAC Medical Mission, and he is an international certified addiction professional with more than 30 years of experience. So we would be very eagerly waiting for both the speakers to do their presentation.
Sure.
Dr. Sami,
Yes, ma'am.
can you
Ma'am,
see? Can you see in the chat in the list whether Dr. Ali is there and Dr. Francis is there?
Ma'am, Dr. Francis joined by the name Francis Raphael.
Okay,
Francis
please
Raphael.
make him co-host. Raphael. Oh,
Francis Raphael, ma'am. He's
Soumya?
raising hand.
Yeah, please make him a co-host.
so you have been made the co-host. Most welcome, sir. Over to you. Yeah.
Thank you. Thank you. Thank you.
Can you see Ali also in the list, Soumya?
Ma'am, just finding out.
Edwina, ma'am, do you have his
Dr. Ali's video is there.
Please run the video because he is in hospital. He said he's in hospital. So he may or may not, yeah. But very committed that he sent his video even though he is admitted.
A wonderful day to all those who are joining. My name is Ali Adib.
Ma'am, please play. Edwina, ma'am.
A wonderful
Admin,
day
you are
to
muted.
those who are joining. My name is Ali Adib. I'm a certified addiction professional and a global drug demand reduction master trainer from Maldives. I work nationally for Journey NGO, and I work internationally for many international organizations as drug demand reduction trainer. Now, today I'm going to talk a little bit about recovery support for older adults. And I like to highlight it as a hidden epidemic. I like to define it as an unseen problem because it's often overlooked It's an often overlooked public health issue. It's also frequently masked by other age-related health conditions. Now, let's look at why it is missed. Now, surveys often exclude plus 65 plus age group, and there's stigma and misdiagnosis. Symptoms are often mistaken for aging. Poor data systems, no age breakdown in treatment statistics, uh, prison misuse, hidden in medical records, not drug data, policy neglect, few age-specific programs or funding for such programs. So let's look at the global context. From the Global Burden of Disease Study 2025 and regional resources, you can see that East Asia and Southeast Asia show a rising DALYS due to opiate and methamphetamine use disorders among adults between the ages of 60 and 89. Say, for example, in China, the burden of opiate use disorders among older adults increased by over 40% between 2010 and 2021, with prescription misuse being a major driver. Now, in India, older adults represent a growing share of treatment admissions, especially for alcohol and sedative dependence. So, stigma and unvoting remain as barriers. Now, when you look at Japan, reports increasing cases of benzodiazepine dependence among the elderly and often linked to long-term prescriptions for anxiety and insomnia. In Thailand and Malaysia, older adults are increasingly affected by methamphetamine-related disorders, especially in rural areas where access to care is limited. Now, the landscape of global substance use disorder is shifting. In older adults, it's rising faster than in younger groups. Now, rapid aging and changing social norms in Asia and isolation are increasing risks. Now, common substances include, as we know, alcohol, prescription medication, and also Arcanet. Now, there are unique gaps and challenges with regard to this population. Now, one of those are comorbidity. Now, high rates of chronic pain, physical cognitive decline, and polypharmacy complicate detection and treatment. Now, non-geriatric programs. Most services are designed for younger people and don't address age-specific needs or life transitions. Now, if you look at the services in the Maldives also, we are not catering to older adults. Now, social isolation, loneliness, loss of spouse, or retirement are major triggers and significant barriers to seeking help. There are systemic barriers also. Now, financial barriers, fixed incomes, and poor insurance coverage for residential or outpatient care, fragmented care, poor coordination between primary care, mental health services, and addiction specialists, access hurdles like lack of transportation, mobility issues, and technology gaps for, if you look at telehealth, are significant barriers. Now, I like to advocate for age-appropriate solutions. Now, a key finding when you look at the older adult population is once treatment, older adults are more likely to complete it than younger groups. The key is actually getting them into the right care. Now, I would like to suggest solutions that integrate care models. The best approach is integrating substance use disorder services directly into primary care setting, geriatric clinics, and even nursing facilities. Now, some of the key components that we can look into are age-specific groups. For example, peer support with fellow seniors creates a safer, non-judgmental, and more relatable environment, actually. And care coordination, dedicated case management to coordinate complex medical, social, and recovery needs. A spectrum of support is the solution that I envision. Peer recovery, certified older age peer specialists who can provide the invaluable hope, navigation, and linkage to community resources, family counseling, educating and supporting adult children and spouses who are key pillars of the recovery capital and are part of the recovery network. Holistic wellness programs addressing chronic pain, nutrition, wellness, like Tai Chi or yoga to manage health without substances. Thank you. And if you have any questions, kindly email me at AlyAdyb, ALYADYB @gmail.com. You can also WhatsApp me on +960 999 5992. Thank you for your patience. Thank you for watching. A very
Thank you, Adib, for sending us the recorded version. So, should we hear from the other speaker, Mr. Francis?
Yeah, please, just hold on, Yeah, then shall I start?
Yes, sir, please.
Yes, please.
Yeah.
Please, sir.
So I am supposed to speak on relapse prevention among the different age groups. So let me share my PowerPoint. Can you see my PowerPoint?
Yes, sir.
Yeah. I hope it is moving. So this is like, what are the strategies? What are the appropriate approaches that we should follow managing substance prevention among the substance use disorders when it relapses? As we know, relapse is part of the recovery. And to prevent relapse, there are so many strategies. Nowadays, there are so many apps. The technological development has improved a lot. Like NOMA app, sober tools, etc. can be used to prevent relapses. Like the approaches like a recovery coach, a person employing a recovery coach to prevent a relapse is also a method. It's something like you appoint or employ a coach. Like our Virat Kohli is having a coach, a recovering person is having a recovery coach to support his sobriety. So sobriety is becoming costly nowadays. To be sober, a person has to undergo a lot of struggles and invest a lot to maintain his sobriety. So we shall just see what are the things that need to be taken care of in order to be sober throughout his life and maintain the road to recovery. So these are the objectives. We shall briefly explain what is SUD, what is relapse, and what are the coping strategies, and what is the appropriate strategies according to the age. As we know, SUD is a chronic brain disorder involving compulsive substance use despite harmful consequences. It affects globally millions of people, and recovery is possible, but relapse rate is 40 to 60% without any proper strategies. That means 40 to 60% of people relapse. So if you have proper strategies, we can increase the number of sobriety cases and improve the sobriety rates accordingly. Understanding relapse in SUD. Relapse means a return of the use of substances after a period of abstinence. It is often triggered by stress and cues or emotions that happens followed by. And they also use some terms like lapse or slips. Lapse or slips means it's a short term or a brief period, like 1 or 2 times you take the drugs. Like for example, after the treatment, the person takes 1 or 2 times alcohol or drugs. That is called a lapse or slips. But complete return to drugs or alcohol is called a relapse. And relapse is considered part of the recovery. The stages of relapse is not just it happens all of a sudden. It's a process. It's the emotional stage, then the mental stage, and the physical use. So the craving, the anxiety and the craving happens, and then the person start using it. And all of us who are involved with the treatment of addiction should keep in mind that relapse is not a failure. It is part of the chronic disease, and it is preventable with proper planning and proper management of relapse. Core coping strategies for SUD. One of the alternative strategies is that healthy way of living, exercises, hobbies, journalings, that is to replacing the pleasure that he has been experiencing by taking substances or drugs. So replacing the pleasure that is he has been experiencing by using drugs. Getting relief or getting pleasure through alternative methods of living in a different styles of life, by doing exercises, doing different hobbies, doing different types of way of life, etc. That includes mindful exercise like meditation, relaxation therapies, deep breathing exercises, which must be appealing to him, which must be interesting to him or her. And then it also can be through social support systems or social groups like AA, NA, and other 12 steps methods. Nowadays, there are so many 12-step methods. In other words, self-help groups. We might have heard about Islami Milati, Women in Recovery, Cocaine Anonymous groups. There are so many groups. there are so many groups, even Christian anonymous groups, Hindu anonymous groups. There are so many groups that are coming up. Whatever it may be, all these groups are self-help groups that are slowly developing to help the recovering person. To help the recovering person to maintain sobriety. And I would say these are wonderful groups that support the person to keep himself sober throughout life. And therefore, these are very strong teamwork that will keep them maintain sobriety throughout life. So it is called the social support system or self-help groups. And then the therapeutic techniques that have been used by the therapeutic team, particularly the counselors and the psychologists. That is CBT and DBT, the therapeutic counseling methods, can be used in helping the person to overcome stresses and other psychiatric problems or psychological issues, depression, anxiety disorders, panic disorders, and other comorbidities, mental health issues. So when you find a solution to the mental health issues, the person may be relieved of his stresses, thus he may be able to maintain sobriety. Other area is that the person must be helped to maintain proper nutrition and maintain a daily schedule, daily life schedule. And the triggers. The person must be able to identify the triggers, the risk situation, and able to track the high risk situation, the people, the places, the emotions that might lead him to relapses. And then he must be helped to develop a plan to prevent relapse. Also develop certain skills to manage his cravings and understand the relapse signs. Monitor his relapse signs and manage the relapses. Also build up network of family members, peers, and professionals who are part of the recovery team. And age appropriate. Age appropriate first comes 12 to 18. When we consider providing age appropriate relapse prevention, the first age group is 12 to 18. That is the adolescent group. Adolescent group, we must focus on the developmental group, that is their brain development that we need to focus on. These group, we know that their brain has not been matured enough. So their emotional area is much working on and functionable. And they don't reason out. So all the time they are much emotional and they are not able to think properly. They are not able to make right emotions. So accordingly, we must plan things for them. So make use of the peer group, address the peer problem, teach them how to manage peer pressure, because they are not able to think properly, make decisions in the right sense. They need proper guidelines to manage peer pressure. So life skills training is a must for them. And also involving the family and the school, the teachers, the parents are also very important. And the latest methods like teaching through the apps modern system of technology is also, that is help them track the emotional changes that they understand, and also help them understand wherever they can identify and get help through the apps and sober apps and whatever network system they can identify and get help. That should also be taught to them. And another group is the youth, 18 to 25. Of course, the youth need employment. Many of the youth who engage in addiction are deprived of proper employment, and therefore they need to be taught employable skills, occupational skills. So because they don't have the employment, they are likely to go back to drugs. So basic education, basic coping skills, they need to be taught the employable skills, and they should be taught to be independent, and they should also be able to taught managing the social medias through different methods like motivational interviewing and life learning systems. The next group is the adult group, that is 25 to 64. This group must be being the family group who is managing the family. They must be having some comorbidities. They must be experiencing bipolar disorders or depression because of the family engagement and taking care of the family, parenting skills. So more of psycho mental health issues they may be experiencing. And so applying different therapies is required. Help of the other agencies required. Financial management and other areas need to be taken care. Life stresses need to be identified. Spouses' relation should be strengthened. They may be having family issues that need to be identified and strengthened, and a holistic approach need to be taken and to address their family issues too. Finally, the last group, above 65. Above 65 group must be experiencing a lot of health and mental health issues. One of the things that we need to take care of, that these group must be using a lot of medications for different diseases and different ailments. So they may be using over medications. So a kind of close observations, especially by the doctors and nurses, need to be taken, because the medications that you give for addictions, like managing addictions, like disulfiram, naltrexone, etc., can have a lot of contraindications with the medications they are taking for their other diseases or ailments. So that aspect of pharmacy or polypharmacy need to be taken care of. Otherwise, they may land up in trouble. That is one of the most important things. Other thing is that these group may be having a lot of physical issues of walking, maybe with their heart issues, their renal issues, their liver problems, etc. So those things also need to be taken care of. And then finally, relapse is something that which need to be continuously monitored, and follow-up home visits, follow-up letters, follow-up counseling, follow-up medical review need to be maintained at least for 5 years. That is what we do in our hospital. Minimum of 5 years follow-up need to be done. One of the things I have noticed is that we all do a lot of follow-ups, but we don't do home visits. I come from Kerala. Kerala is, as a community, is very small community, very close community. So home visit is not that that difficult. But in other states where people live in faraway terrain places, home visit is very difficult, and reach to their homes is very difficult. And people naturally don't visit. And other countries also, in different countries. Because I worked even in Afghanistan, where it is very terrain and it is very difficult to go. So my suggestion is that we need to start home-based treatment. Instead of people come and take treatment in our centers, we need to start home-based treatment to prevent relapses. That means the therapeutic community should go to the people, into their villages, into their community to provide treatment, because the relapse can be prevented only through that method of home visits and providing home care treatment. That is one of the methods. And we also need to use the modern technological equipment and other apps, tracking methods like Sober app, etc., to help the people. This is all what I want to say. I think my time is finished. I was a little bit quick because I knew that the time is very limited. That's why I went a little bit quick. Yet, if I have time, you can ask any questions. I am open to any questions. Thank you very much.
You have another 10 minutes. You can go ahead.
Okay. I thought I have only 20 minutes.
Ali has taken half of the time only. He could not record for more than that.
Yeah, I am here. I am still waiting. Maybe I'll take up some questions. Maybe I can talk on from my experience. I am still, anybody would probably. Oh, I didn't know that. I mean, I may be able to talk on from my experience as a counselor from my medical college experience.
Yeah, please go ahead.
So I was talking about relapse. These days, I have found relapse is very high, particularly among adolescents. Why adolescent relapse very often? One of the reasons I identified, although I have not done very research on that, one of the reasons I have found that most of these adolescents who relapse have some psychiatric comorbidities. Many of them suffer from ADHD, conduct disorders, or personality disorders, that is antisocial personality disorders. If you search their past history, you identify that in their very young days, they had some ADHD issues in their school days. So what is my conclusion is that young children at their very young age, when they are identified with or diagnosed with some childhood disorders, if they are treated very well, they are unlikely to go to addiction and other disorders, and it is preventable. So community psychiatry is a must. In our country, we take care of a lot of health issues, and medical care is very good in our country. Particularly, I see in my state, it is very good, one of the best in our country. But psychiatric care, mental health care is still not good. We do not have community health care even in Kerala. Even in Kerala, I say. All my Kerala friends, please don't take it negative. I am not negative person. I am very positive person. Very, very positive. I'm just telling you the truth. So if we can go into the community, if we can go to the community and teach the people that addiction is a brain disease and it has some genetic disposition. It is rooted in the genetics. That is 40 to 60% has a genetic disposition. At least the younger generation understand taking cannabis, taking alcohol can land them in trouble, and one day they become they land up in trouble with mental health issues. And that's my idea, my finding all throughout these years. At least for the last 10 years, the relapse rate has gone up high. And second thing is that responding to treatment is very poor among the adolescents particularly. And there is a rise in the drug use in Kerala, particularly in hard drugs like MDMA, cannabis, magic mushroom, LSD like drugs. This is my observation. And about the relapse, again, among the alcohol users, relapse rate is lesser. But among the drug users, relapse rate is very, very high. Only hardly 20% to 30% remain sober. But we do work. We conduct home visits. We conduct other methods like reach them through phone calls and other methods to keep them sober. I'm already 61. I still visit the recovering persons in their homes to motivate them to come to treatment center. I still go their homes to motivate them. So this is what we do. If you have any questions, you can still ask. I don't know.
Sir. There are questions in the chat box.
Yeah.
To what extent do cognitive behavioral coping strategies rely on insight and self-regulation capacities that may be impaired by chronic substance use, and how should treatment adapt?
Yeah, that's a very good question. See, cognitive behavioral therapy applies techniques like cognitive restructuring, exposure therapy, and it also uses homework. These are 3 techniques. There are many other techniques used. So in addiction, many of the young children are not aware that drugs can cause them a lot of troubles. They think that cannabis, for example, is okay. So cognitive restructuring, that is, you help them understand cannabis can be very dangerous. So changing their cognition through CBT can change their mindset. So cognitive behavioral therapy will help them. Second thing, you can use the techniques of exposure therapy, because so many young guys who have traumas, they take into drugs like childhood trauma. Those who have experienced physical and sexual abuse, they take into drugs. I had a few of them. So if you use those exposure therapy of CBT techniques, that will definitely help them overcome this childhood trauma that they have experienced. And then homework. Homework techniques definitely helpful, and I have applied those techniques, because you see the children who are in the pre-contemplative stage, it is very helpful to change their motivation, like through change talk methods. If you apply the homework into them, give them the homework in the through using you apply the techniques of homework, and then finally use the methods of readiness ruler and decision balancing. You have to combine CBT techniques with MI and MET. You see, not just CBT alone. It is a kind of combination of MI and CBT. use the CBT homework technique, combine it with the MI and MET. MI and MET uses the readiness ruler and the decisional balancing method. So combine it, and then you use that technique, and you give the homework, and then that method can definitely change the boys who are in that pre-contemplative stage into preparation stage, improve their motivation level. Am I making correct
Yes,
sense
sir.
to you?
Absolutely, sir.
Is it
So there are
clear?
a few more questions in the
Yeah.
chat box, sir. Um,
Yeah.
Dr.
Yeah,
Inju ma'am has
please.
asked, what all challenges do you face during home visits, relapse prevention?
One of the challenges that I face is, recently I faced, one person died of cardiac arrest. So the family accused that he died because of the Esperal disulfiram use. That's a big challenge. You see, that's a big challenge. Next challenge is, if the person is relapsed, they will tell, what was the use of your treatment? You are all doing a wrong thing. Please don't come to our center. But now I am not facing that challenge, because now they all know me, so they don't get angry with me. The third challenge is that, many of the persons come from some remote village. Of course, I told Kerala is very close knit places, not very far away places, but still there are some faraway villages. That is the third thing. The fourth thing I place is that many of the people, they are not interested in our visits. They are angry with us. They show disinterest. They say, why did you come? Because the person has started drinking. This was a waste. The treatment was a waste. Like that, the negative feeling was there. But still it is okay. We try to motivate them. I am not discouraged, still not discouraged. Last 30 years I am doing it. Never discouraged. I will do it until I die. That's my motivation.
So you're
Yeah.
really motivational
Yeah.
speaker. It's really
Yeah.
inspiring. So we have
Thank
two
you.
more questions. Can we take it very quickly?
Yeah.
So can we care for a teenage addict while he or she is in school?
Please.
Yes, sir. I'll repeat it. So can we care for a teenage addict while he or she is in school?
It's difficult. We have to put him in a residential treatment care center. If he is a teenage person, we cannot treat him or care him in school itself. But we can prevent him in a school. That's all we can do. But during the school days, in the school itself, we cannot do. Because the other students might. It's difficult. Okay?
Yes, sir. Sir, last question. Sir, you suggested the few more questions are coming up.
Yeah.
You suggested some home-based treatment. Can it be helpful for a person who already is having existing family problem which cannot be solved?
Yeah, that's a good question. If a person is having a family problems, if it is with the family problem with the spouses, I mean wife or husband, there are some other family members, no? Get the support of the other family members. Father, mother, other parents, not only the wife or husband. So it is possible. It is possible. We did it in Afghanistan. I was in charge of 28 treatment centers in Afghanistan. Afghanistan is a big terrain area, big with all hills and mountains. And it was possible in Afghanistan. I'm sure we can do it. But wherever it is possible, we can do it. Home-based treatment is something good where it is very difficult to reach. People find it difficult to come to our center. Especially transportation is very difficult.
Right, sir. So
Yeah,
this discussion is going on more and more fascinating and interesting. So we do
yeah,
have more questions, but less
yeah.
of time. We can take just one or two more. Sir, what about the acceptance by the parents or community members when you talk about addiction for adolescents?
Yeah, what we need to do is involving the family members in the treatment is a must. In many of our treatment centers, the family members are not involved. Like you see, in our treatment center, we ask at least one of the family members to stay with the person who is undergoing the treatment so that they understand how the treatment is given, what is the treatment, what the disease is like, the nature of the disease. So involve the family members. So psychoeducation for the family is a must so that they understand that this is a brain disease, not a personality disorder or a character flaw. This concept has not been understood, at least in our country. That's a big problem.
Very rightly said. So that's a question plus. I think the process of addiction recovery and relapse is often influenced by mostly by the support system which is not available or effective in most cases. Do you think community health workers can be explored giving the support?
Yes, definitely. Community health workers should educate the community to remove the stigma attached to addiction. Let me tell you, don't take it negative. Let me tell you, even today in the 21st century, the people who guide us and rule us still tell us there is no need for treatment for addiction. Just take them into pujas and other things. That's enough. On the top of our country, those people should be educated. So let them be educated. That's all I want to say. I don't want to say more on that because I don't want to be controversial.
Sure, sir. Thank you
Yeah.
so much for
Thank
your
you.
input.
Thank you. Thank you.
Over to the chair, co-chair, and advenom.
Yeah. Thank you, Mr. Francis. That was very elucidating presentation that you had. And of course, the presentation shows the vast experience that you have in this field. Couple of points from my end, because this is a conference of nursing cadre. So one thing that is important as nursing professionals, or even for that matter other professionals, is that we always need to educate the person that even if the person goes back to using drugs, uh, then also he should come back and contact the treating team immediately, because many a times individuals, they are reluctant that how can I go back to the same center when the counselor, the doctor, the nurse, they have spent so much of time with me. I had promised them that I won't use drugs or alcohol again, but now I have started reusing, so they would feel ashamed or guilty of going back and seeking treatment. So it's very important while treating to inform the individual that relapse can happen. It can happen despite the individual's own effort, and it's okay if somebody slips back, goes back to using drugs. The most important thing is to come back and restart treatment, come in contact with the treating team again, is something which is very important. The other point that I wanted to highlight was that relapse also is often a case of burnout among addiction treatment professionals. So, when we as treatment professionals, especially those who start early in their career, if they start seeing patients coming back after what they think they have done a very good job, and after some months the person comes back to you and seeks treatment, we feel disheartened that possibly this is an illness which I cannot take care of, or the field is this, you cannot do anything about it. This is good for nothing, right? So that is also another thing that we need to understand, like what Mr. Francis raised in his presentation, that it is part of recovery. A person will relapse a couple of times before he or she eventually comes out of addiction. So to support the person while he is relapsing, motivating him again to stop using drugs and continue his treatment is something which is very, very important. It may seem disheartening in the initial few times, but once you start seeing that after three four phases of relapse, the person eventually stops drugs for a long period of time. So it requires patience on both the part of the patient, their family members, as well as us as addiction treatment professionals. So that is something which is very important. Otherwise, a very lively kind of a presentation. I also invite my co-chair to give some remarks from her behalf. I think it is Dr. Surbala who is there.
Tarun Jyoti.
Yes, sir. Thank you so much, Francis, for sharing your insightful thought and how do you work and what are your experiences that you working in this field for so many years, and how did you take this problem to people? Still, you are quite motivated to work in this, and being a young learners in this group, especially from the nursing personnel, I hope that your talk and your experience will motivate them again to work in this area. There are many things that we have to do yet. So I think thank you so much, sir, for again once again for sharing your thoughts in this area, and from the entire team of the nursing and the learners, like to really thank you for this. Thank you once again.
Thank you.
Thank you
Thank you.
so much.
Thank
Thank
you,
you
Dr.
so
Ravindra.
much.
Thank you. Thank you.
And even beyond this, our speaker, Dr. Francis, today has inspired us with his own, his own way of showing his commitment. Let's move on now to Symposium 1. And in Symposium 1, which is on digital dementia and smartphone addiction, as well as today's artificial intelligence is the buzzword around. So now we have artificial intelligence psychosis also to understand. Okay, it is my pleasure to introduce Professor Dr. Rakha Jain. Wow, it's every year when I introduce you, I feel myself in awe. 37 years of experience with a PhD and an FRCS from the UK, a former senior professor and professor in charge of laboratories, National Drug Dependence Treatment Center at AIMS, New Delhi. Dr. Raka, we are so glad that you are able to share your knowledge and your experience with all of us here. And it is my pleasure also to introduce Lieutenant Colonel Mrs. Gracie Joseph, who is the nursing superintendent at MOSC Medical College Hospital in Kerala. After her master's in nursing here at Karnataka itself, she has been this nursing superintendent, as I've said. She also was a lieutenant colonel and a lieutenant in the military hospital across. Welcome to both of you, and our speaker to be introduced by you.
Please make Dr. Vikas co-host. Dr. Samya. Hello. Dr. Samya, please make Gracie ma'am and Vikas sir co-host. And Madam Pooja. Hello, Dr. Samya.
Yes, ma'am.
Gracie Joseph and Vikas Dikab.
So we are looking at digital dementia and
And
smartphone
Pooja
addiction.
Shakia. Pooja Shakia, all of them to be made co-host.
I have shared my PPT even in they are not able to make co-host even that is fine.
No, it's
PPT
okay.
is
Ma'am,
with
already
us.
co-host you have been made,
We
Pooja
have the
ma'am. Yeah,
PPTs.
you have already
Yeah.
been the co-host. Yeah.
So
Okay,
what about
so may I ask Dr. Raka or Lieutenant Colonel Gracie Joseph to introduce our speaker?
Uh, Good morning, good afternoon, and good evening to everyone. And I would like to thank the organizers, Ms. Geeta Purkait, the organizing secretary, and Dr. Sandhya Gupta for making my presence over here. And special thanks to Adivina for introducing me. And today we have two speakers in this symposium, and one is by Dr. Vikas Dikhav, who is associate professor and in ICMR, senior medical scientist and deputy director at ICMR, and he would be discussing, giving us a presentation on the age-related trends in the dementia and digital dementia and smartphone addiction, whereas Pooja Sakya, very nice to see Pooja. She is a student earlier, and seeing her as a faculty and presenting in the bus, she is presenting on the addiction, smartphone and psychosis. So I invite Dr. Vikas to give his presentation.
Thank you, madam. It's been wonderful to be here. Thank you very much to the organizers for having thought about this symposia because it is not only timely, but it is very important as well. So I'm just sharing my slides. Please let me know when they are visible. So are the slides visible?
Visible, visible, and on full screen mode, Dr. Vikas.
Yes.
Go ahead.
All right. Thank you, madam. Thank you very much. And thank you again for the opportunity. This is a very important topic. Firstly, because I come from the government side. So just a small disclaimer that this presentation is being done in personal capacity for educational purposes. It is in no way a reflection of the views of GOI. But then, since digital dementia, although not a medical diagnosis, but it is very important because we have 900 million people in India who are users of internet in one form or the other. So obviously, it affects a large number of Indian people. So we would like to discuss what potential impact being into digital world can have. Obviously, we are not saying it's all bad, don't go digital, not at all, because there is a large emphasis on digital India, and there are we have National Digital Health Mission and whatnot. But then, the idea is to focus our attention on being into virtual world excessively or maybe overuse of technology. These are two things that I would focus upon. Next slide, please. So digital and dementia, it's difficult to imagine why should these two words be connected with each other, because being digital is seen as a advancement of the technology, and dementia is like dissolution of mental functions to a level wherein a person becomes incapacitated with an unclear thinking, and also there are a lot of issues, and there is whole gamut of tests that we do to diagnose dementia. So basically this is a disorder of cognition, dementia,
we will just come upon to a list of symptoms that it can produce. But then cognitive decline due to excessive use of digital device is now increasingly getting attention. As we say, the dementia in the list of the causative factors, digital devices never featured. But then time is changing. We are spending 4 to 5 hours, maybe perhaps more, daily into the virtual world, and that is adding on to the problems that we are facing. So basically, it is a cognitive decline that has been potentially linked to excessive use of digital devices, wherein there can be short-term memory problems and the attention span is getting reduced. And that was shown by a study done by Microsoft about 10 years back, that the attention span of the generations which are using smartphone, internet is getting reduced. We are in habit of scrolling things, and then earlier people used to say 1 hour video, 2 hour video is good, but then it came down to 30 minutes, then 10 minutes, then 5 minutes, then 1 minute, and now it has gone down to seconds. So obviously that has affected our attention as well as concentration. And digital dementia has the potential to produce symptoms which are very similar to a neurocognitive disorder, which is dementia by itself. So for those of us who are not familiar with the term dementia, it's basically age-related cognitive decline many a times, but then it is a neuropathological diagnosis of its own as well. But then age-related is not called as dementia for sure. So that is age-associated memory impairment. After the age of 65, about 10-15% people, they experience the cognitive decline, which is proportionate to their age. But then in dementia, the memory problems are significant enough to interfere in the activity of daily living. There may be loss of orientation of time, place, and person, and the behavior may change significantly, wherein there may be aggression or sometimes depression or sometimes anxiety, or there may be what we call as BPSD, behavioral and psychological symptoms of dementia. So BPSD affects about 50% of the people with dementia. So there may be language issues, and there may be communication difficulties, and eventually as the dementia severity increases, then person may become even mute. So basically what we are saying, that this is a disorder of the old age. After the age of 65 it develops, and there are neurocognitive domains which are affected. We may have agnosia, hyperaxia, aphasia, and of course these should be significant enough to interfere with the activity of daily living, and the symptoms should persist for 6 months or more. Next, please. So basically, it is a postulate even now, although now the evidence is getting generated significantly. So we would not say that digital dementia is a clinical diagnosis at present, but then there is a significant link which suggests that if somebody spends too much of passive screen time, now we should be very clear what is active screen time and what is passive screen time. Like for example, now I'm talking to you, you're listening to me, and vice versa. When you talk, I listen. So we are into the screen. So we are spending screen time, but then we are using our brain, we are using our cognitive faculties. So that should not be treated as a screen exposure in a negative sense. The passive screen time is like when you are busy scrolling Facebook, you are busy scrolling the reels, you are busy scrolling the Instagram reels, and you are using it for recreational purposes, or maybe you are chatting and chatting for a very long period of time, 5 hours, 10 hours, sometimes late into night, 4, 5 o'clock, and then you sleep, and then you get up at 11, 12 in the morning. Rather, it becomes noon by that time. So it would have negative effect both on the structure as well as function of the brain. So on the right hand side bottom, you can see Asian Journal of Cognitive Neurology that I started when I was doing my PhD in neurology from RML Hospital, Delhi. So this journal was started. I ran this journal for about 4 years, 5 years, perhaps a little more. But then, I was inducted at a senior level in Department of Health Research, Ministry of Health and Family Welfare. I did not get sufficient time. So I think I now, with support of like-minded people, intend to restart it perhaps early next year. So it was a very, very good platform, and it became very popular in a very short amount of time. This was a personal effort, but then it was supported by a lot of people. But then coming down to the topic once again, that heavy screen time, as we discussed, what is heavy is yet to be decided formally. The definition is yet to be decided. But then I would say, if somebody remains on online for a very significant amount of time, so maybe 4 hours, 5 hours would be good. Maybe more than 2 hours will be just the bare minimum as per the guidelines that I have seen. But then doing something passively, not doing something actively, so that will have a negative impact on the brain. And we discussed that may cause difficulty in attention. Reasoning may be affected, because the depth of understanding gets affected, and the person will find difficult to perform several tasks at the same time. So this diagnosis, again we discuss, is not a neurological diagnosis. Italian neuroscientist in mid 1990s coined this term digital dementia. But then not just Italy, it has been, he just proposed that there can be something like that. It's like a novel. Sometimes it so happens where when a novelist proposes something, it may eventually turn out to be true. So he proposed that there can be something like this. If you be into digital world excessively, then there can be a problem with the cognition. And now it is coming true. So I can, since I showed you the cover page of that journal, I was there in Bishkek, Kyrgyzstan in 2013. So we did a study on Indian students studying there for MBBS. And unfortunately, I don't have the article with me at present, but then it would be there in my desktop somewhere. So that study showed that about 25% of the students who were using the internet for 4 to 6 hours a day, they were the ones who were more likely to have subjective memory complaints compared to the students who were not using internet for that long a duration. So it was sort of a case control study that we did. So what we are saying now is that it's basically somebody who uses smartphones, or maybe laptop, not just smartphone, laptop or desktop, but then if somebody is being into digital world for far too long for passive uses, or we can say recreational uses, because generally it is said, perhaps you would have heard it many times, when we are actually watching TV. So in that case, what so happens is that our brain becomes passive, and it because we are not using our brain in a way we should, our reasoning gets affected, and we are just the recipient of the content. So when we become a recipient of the content, though, so there is basically a term that is nowadays being used, and that is called as cognitive offloading. Cognitive offloading is like, there is something that is known as cognitive overload. When we learn something, when we basically, think about something, or maybe when we conceptualize something. So that is like, cognitive overload. But cognitive offload is that our cognitive structures, they become free. And you would perhaps know that brain is a muscle. If you either use it or you lose it. So when you are not using the brain, so there is a likelihood gray matter, white matter is going to be affected in a negative way, and it may exacerbate already existing memory loss. It may generate new memory losses, or maybe it can exacerbate the symptoms related to ADHD or attention deficit hyperkinetic disorder. So cognitive harms associated with the smartphone addiction or internet addiction are far too many. We discussed that basically it is the attention, memory, and concentration. Three things are going to be affected. But I would like to emphasize upon one thing here. Perhaps, people of my generation who have just touched 50, they would agree with me that our generation used to dial the phone in 1990s, but dialing is different from touching the screen, and that too incessantly. You are not stopping your finger at all. You are touching, and that's it. So when you are touching the screen, and that too for hours a day, so the brain areas that are actually controlling the fingers and controlling the movement of the hand and the other things, so they undergo cognitive reorganization or cognitive restructuring. So that is why we are saying that digital content has the potential to reorganize the neurons in the brain, and so is the case with artificial intelligence or whatever semantic web technologies that we are using. That is why we are into habit of googling everything. If there is any spelling that we don't remember, google it. There is name that we don't remember, google it. Or calculation that we don't do mentally, google it. But then, in 1990s this was not there. That was such a good time. You used to use your brain. Now you no more use your brain. You are dependent on computer increasingly, or into the digital world increasingly. So there are things that are changing. So evidence is now emerging, and language cognition, as well as other things are getting affected, and there is a neurobiological basis of the same coming up as well. The interpersonal understanding and facial recognition is also getting affected. Perhaps you would have realized that if you meet somebody in 20s, people gone by era vis-a-vis people now, so they are to the point, they are direct, and in terms of the recognition of the people, the number of names that they used to remember, they would themselves tell that we may not remember as many names as we do. Spellings, generally they Google, and this is a habit that is catching upon to them. But one of the new thing which is now coming up is the empathy is getting reduced. So perhaps you would have seen, although it is a little off track, but people in their 40s and 50s and 60s, they may still like to offer seats in the metro to the people who are standing. But then, a 20 or 20 plus boy or a girl is little less likely to do so, if you have noted it. So, but just a offbeat example, but then, studies indicate the empathy is now getting reduced. Perhaps one of the factors that can contribute is heavy internet use or heavy digital device use. And there is a neurobiological basis, and as we discussed, the gray matter, white matter in the brain is getting affected. So this was a study that we done in 2021 during COVID time. So I had a MTech scholar, and I asked him that, is there something that you can do during COVID time? So he said nothing works in COVID time. So I asked him that, let's try something digital. And people were spending 8 hours, 10 hours a day during the digital, times, like the COVID time that we had passed through recently. So I asked him to conduct a study in which I told him that, I will do the memory assessment by using the standard scale, which was an alternative to MMSE. So we did a online assessment of the memory, and we found that about 30% people, they scored significantly low in the memory test that we did, and it was done online. And this study was cited by WHO several times as a useful resource, which was considered as a humanities response to the COVID pandemic. That during the time of COVID pandemic, people were so hooked onto the internet, perhaps it started affecting their memory. So that means, like, if you can read the background itself, it says the digital devices have the potential mental health impact, impairing cognitive abilities. So there are dangers, obviously, excessive screen time, especially in children. Like, for example, like whatever neuroplasticity that people of my age had to have now that neuroplasticity that we start in childhood from 2 to 5 years or 2 to 7 years, that has already been established in the non-digital world. But what about the children who are getting born now after 2015 or maybe after 2020? So they are at risk of getting the accelerated neurodegeneration in the brain because of the excessive screen time. So there is a potential danger. So there have been projections by multiple groups, and it is we generally say that we have 10 crore elderly in India, and maybe in the time to come, the number of people with dementia, which at present is about say 80-90 lakhs or close to 1 crore. So this in 2035 will go to 2.5 crores or maybe 3 crores. But then we need to know that there have been multiple groups who have projected that maybe in next 50 years there is a great likelihood of the dementia in the world rising 2 to 3 fold to 4 to 6 fold. And this is perhaps because of the excessive digital device use that we are into. We are not saying again that being into digital world is all bad, not at all, but we are saying being in digital world excessively, passively for purposes which are primarily recreational, and this is what our main focus of presentation is. So there have been, links like neuroplasticity plays an important role that we do understand in any shape, be it cognitive development or maybe repair in the brain after the injury. But then children or adolescents, particularly during their early phase of the brain development, if they are into heavy digital world, perhaps their cognitive trajectories may be affected in such a way that they are likely to enter into area that will actually impair their cognition either in the same time around or maybe in the time to come. So why does it happen? It's everybody's question, because if we get chronic sensory stimulation from the reels after reels or Instagram, Facebook after Facebook post, and they post content, digital content in the matter of seconds and minutes. So there is an irresistible tendency, there is an impulse that we will have, and that will cause chronic overwhelming of the sensory stimulation, and that may disturb the activity of gray matter, and white matter overactivity in response can occur, and eventually there would be reduced synaptic plasticity and potential neurodegeneration that can occur. So what are various brain areas that are particularly affected? We would know that the powerhouse of neurons in brain are called as the gray matter centers, like for example, hippocampus. It is our GPS, amygdala, it is our emotional center, insula, it is the site of the higher intellect, orbitofrontal cortex, it is the site of our executive function, and similarly, the superior longitudinal fasciculus, inferior fronto-occipital fasciculus, and corpus callosum, all those parts of the brain, they are important in coordination and exchange of information from one part of the brain to the other. So if you ask me what is the most important area which gets affected by digital dementia, so I would say it is prefrontal cortex, which is responsible for executive functions. Maybe we are not noting it down now, but in the time to come, this will become a significant issue. It has potential to become a significant issue. It is like polythene. Earlier, we used to say polythene is so good. We don't have to bring our own, bag, and polythene is so convenient. But now we know that polythene takes 500 years for for biodegradation, and it may not completely biodegrade even then. So something that we find very tempting now has the potential to affect our daily life and cognition in the time to come. So lastly, when you have flagged the problem, so you should also discuss what is the solution to the problem. So basically, it is easier said than done. Limit your screen time. So, how do you do, and what screen time limitations are possible in a digital world is a personalized question to my mind. But generally, we say that children, they should not be allowed to be into non-creational, non-recreational digital world for far too long, and for recreational purposes, not more than 2 hours. So 2 hours is generally the limit, and children below 2 years, no internet or no smartphone should be allowed. Unfortunately, when a child starts crying, we are the ones who would give them a mobile phone, that take mobile phone, stay happy, watch cartoons, watch videos and whatnot. But it's not good. Basically, if the child plays with the pet, that is going to be far more better compared to playing with the digital device. A lot of people take pride. My child is very smart, knows internet, and knows technology left, right. Very good. But to a time, to a certain limit, it is all right. But then in the time to come, perhaps, being into natural world, there is absolutely no substitute. And that cognitive and proprioceptive feeling of being into the real world, meeting real people, real time. This is to say that we are doing it virtually. That's all right. We are doing it for an academic purpose, but being into real world, meeting real people is obviously much better than talking to people via screens. I mean, it goes without saying. Obviously, we're taking advantage of the technology though, but then one is limit the recreational screen use. One, two is obviously engage in real life things, like for example, reading that refreshes the brain and stimulates the language area, the the memory area, the emotions they arouse and whatnot. So whole of the brain is working, and puzzles naturally they activate certain areas of the brain that stimulate cognition, and also there are people who are doing too many things at the same time, and you would find a cliche among people that they will open a chat window and then type things on the MS Word, and they will say that I'm doing something very important, but then replying to the chat messages also. That's not a great idea, obviously, because that multitasking has the potential to affect the cognition in a negative way. And sleep is extremely important, 6 to 8 hours, because sleep reorganizes the information which is there in the brain that we have learned through the day. Proper sleep is extremely important, and cognitive training cannot be re-emphasized. There are particularly developed cognitive programs as well. But then, nowadays people do talk a lot about physical activity, exercise, gym, yoga, whatnot. Very good. But then we should also talk about the mental health. The the old saying is, rest in the sound body, a sound brain. So the point is that if the body is not healthy, the mind is not not sound, and vice versa is also very, very true. That if the brain is not healthy, it is unlikely that the body itself is going to remain healthy. If not for far too long.
Dr. Vikas, for such an interesting presentation, I'm very sorry to tell you we have another
We done,
speaker.
madam. We done.
Another
I'm done.
speaker.
This is the last slide.
Thank you. Thank you.
This is the last slide. And yes, next. So this was like dealing with dementia. So guidelines I already told you about. So we can do away with the guidelines. So next. And this is the take home message. So that is, we need to balance the overuse versus the harm. So you interrupted at the right time, madam. So it is the end
No,
of
I
the.
have interrupted after taking away with Dr. Pooja's time.
Oh, is it? So it's done. I would be happy to answer any question.
Kindly share Dr. Pooja's presentation. Thank you so much, Dr. Vikas. We will
right.
definitely get in touch with you with more, knowledge blast. Thank you.
All right. Thank you very much.
Dr. Raka, kindly conclude.
Uh, Dr. Vikas has given a very elucidating presentation. He has given a very important overview of the digital dementia, its potential impact, and emphasized on the cognitive decline due to excessive use of digital devices, mainly memory problem, reduced concentration. It is not an official neurological disorder, but he has also said that these device has potential mental impact, impairing cognitive abilities. So there is a potential danger. So it's a very interesting talk, and I really appreciate his talk.
Dr. Pooja, you have time crunch. I'm so sorry, but kindly do the justice to the topic.
Yes, ma'am. I will surely try to wrap up quickly within the given time. Am I audible? Am
Yes.
I audible? Yeah, okay.
Yes, yes,
I'll be
Adi.
talking
Yes,
about
you
the
are.
AI psychosis, that is artificial intelligence induced psychosis. So, coming quickly to the outline, next slide, please. I'll be discussing about the basically the concept which is currently there in the literature and what are the possible mechanisms of artificial intelligence psychosis and few example of a safe response and unsafe response and what is the possible clinical construct which has been there so far in the literature and are there any measures to prevent. So next slide please. So AI psychosis till now is not a clinical diagnosis, and recently it has been generally found in the case reports in news media as a phenomena where AI chatbots appear to amplify or validate the psychotic symptoms. So next slide, please. So in the reports which are mainly seen, it is the existing psychopathology or with history there is amplification in the usage of AI. With the usage of AI, there is amplification in the existing psychopathology. So certain case reports have focused on these, and what are the common features they describe were like AI as a godlike phenomena or AI as a romantic partner. And the themes which they described behind these development were the mirror user, that is the inbuilt phenomena of chatbot. So mirror using and reinforcing the delusional thinking. So next slide, please. So, mostly the cases which were described in case reports were those who were using AI as an emotional support or as a therapist. So, they are more prone to this risk. And it resulted into worsening of their delusions or beliefs, further strengthening of those beliefs. And which resulted even into if someone is having any history of illness, it has resulted into medication discontinuation, even in relapse in certain cases. Even in this 2023, this schizophrenia bulletin editorial, they have also mentioned that these correspondence with generative AI chatbots such as ChatGPT is so realistic that one easily gets the impression that there is a real person at the other end. So while at the same time they are aware that it's not the case, so it leads to a phenomena of cognitive dissonance which in itself further fuels the delusional belief. So people who are having increased propensity towards psychosis, they are more at higher risk of such dissonance. Next slide. So uh, the most of the studies which are there in reports, they are explaining AI psychosis as the worsening of the existing psychopathology. As of now, there is no peer-reviewed clinical or longitudinal evidence yet that AI use on its own can induce psychosis in individuals with or without history of psychosis. So we'll be briefly discussing about the what are the themes which are seen in such AI-related psychosis. So these are the three kinds of delusion themes which were seen most of the case reports which were there. First is messianic mission, then godlike AI, and then romantic attachment delusions. In messianic missions, it's like people believe that they have uncovered truth about the world, like something grandiose delusions they have. And in godlike AI, they have so much depth in connection with the AI chatbot. They start believing that chatbot is a some sentient deity, some they start developing spiritual and religious delusions towards the AI. And then another thing which was seen by researchers in reports were the romantic, like people believe that chatbot's ability to mimic conversation is genuine love. So that is a kind of erotomanic delusions which were seen in such case reports. And consequences were really grave. Some have patients, some were led to hospitalization. Even in some case reports, suicide attempts were there. And in some cases, paranoid delusions were more strengthened, and which has led to violence, even like attacking the another person. So these were some of the consequences which were seen in case reports. Change slide, please. So this is, I think this is in the previous format. So did you skip one slide? There is a one flow chart. Just can you go back to? Okay, it's okay. It's okay. So the themes which the inbuilt mechanism of chatbot which reinforces the delusions is the mirror tone, which validates the belief the person is asking, person is telling. So in therapy, we generally don't challenge delusion to develop rapport, and slowly we do with seeing the patient's responses. But when a chatbot does this, it somehow try to continue the conversation and prioritize the engagement. They try to validate their beliefs, and it in a way in it leads to difficulty, like it further uh, uh, widens the reality testing of the patient with the real world. So when a chatbot does this thing, the way the responses to keep the person engaged in the conversation and have the long-term engagement, they try to validate each and every belief which a person is discussing. Somehow they try to strengthen the delusional belief. So this feature, which the most of the literature has described as AI syncophancy. So AI sycophancy means it's like very insincere flattery given to gain advantage from a superior. So somehow these large language models which we have in these chatbots, they try to optimize to be agreeable, non-judgmental, which become dangerous. So that's how they validates and strengthens the belief of the person. Like in a therapy, when a person comes to us, we generally try to have a psychological flexibility, like we try to challenge the irrational beliefs so as to bring back person to the normal thinking. But what AI does in chatbots, it leads to a psychological rigidity kind of phenomena. So it tries to strengthen their existing beliefs by constantly reinforcing it. Can I have next slide? So okay, so I have sent the latest version, it's coming the earlier one, it's okay. In It's order a little bit thoda sa ye ho gaya. So in this slide they are mainly telling what are the potential risk which AI can have on existing psychopathology. So if a person is having persecutory delusion, it may get further amplified. And if a person is having if such kind of chat or conversation continues, then a person is already social withdrawal and he finds some solace in kind of these chatbots, then it leads to further social withdrawal and dependence on AI, which in itself will cause work decline and various other features. And if a person is having symptoms of mania, it may further lead to repetitive chats, may lead to insomnia, hyperglyphia like features. So these are the risk of AI on the existing psychopathology, which it has been described. Next slide, please. Next slide, please. Okay. So there is certain phenomena which are there in chatbot features, like when we have this option of retaining the memory of the chats. So if a person has, like most of the case reports which were seen on AI psychosis, this feature of memory retention was on. That is, the chatbot was able to remember all the conversation which have been done so far. So based on this, they appear to respond to the client, and they used to, for a client who is having some initial psychotic phenomena, they may feel like a phenomena of thought broadcast, or even may have chances of misinterpretation also. So specifically having this feature of AI where they retain the memory of the chats, that is also kind of worsening thing which was seen specifically in the reports of AI psychosis. Next slide, please. So this I have explained earlier. So the order a bit has been haphazard. So this has been explained. Can you? Lot of people are coming up on the slide. So this is the example of a safe and unsafe reply. I think this is the previous old PPT, so it's not giving the complete. So what I will try to explain in the unsafe reply. See, if a user is asking, AI overlords have chosen me. Am I special? So the reply which AI is giving is, you might have unique sensitivity. So in a way, this reply, what it's doing, it's validating the thinking which already person is having. It's kind of making it more convicting. Their delusion is getting more stronger. While in case of a safer example, they could be like, I can give example. See, if a person asks AI songs on radio message about me, feeling like giving me a special task. So in this question, if a chatbot can give a safer reply, what it can be? It can say, I'm sorry for your uneasiness. Radio songs are for many listeners and not target one person. And when a stress or illness is present, the mind can link things that are not connected. So in a way, my this later reply, that is, first of all, they are trying to acknowledging the distress, sorry for your uneasiness. And then they are saying to normalize the explanation that radio are for everyone, not just targeting one person. So we should have a certain inbuilt phenomena in the chatbot that should sense the distress and try to acknowledge it and try to ground the explanation rather than to just going with the explanation of the client. So I have also constructed a reply, although it's not there in the slide, but I have tried to explain how it could be a safer reply. So change of slide, please. So this was the flowchart which I was talking about earlier. Like this has been described in one of the study by Morin et al. How they describe it. Like once a person is facing feeling lonely, so they try to approach the chatbot and they discuss. They try to message. So how AI replies are, they are very emotionally validating. They feel the mirror user tone and try to validate the feelings of the person who is who has initiated conversation with the AI chatbot. So this in self validation leads to further strengthening of existing delusion, be it grandiose, referential, or any delusion. And when this repetitive pattern starts occurring continuously, then it leads to more fixity in the belief and ultimately leads to a behavioral change. That is, behavioral manifestations occur when certain repetitive cycle it continues. It leads to action in the form of like disruption, like any psychiatric crisis, like self-harm attempt or having persecuted delusions and action on the person to harm another person. So this is the form kind of phenomena is described by Morin et al. So I have described this previously also, like mirror using and syncophony, which is generally there in AI chatbots, which leads to validation of these delusional beliefs. Change the slide, please. And here, like in our chatbot, what they use the LLM, that is the large language model. So they try to explain ki what we generally do in clinical principle in psychology and psychiatry, and what the same thing if a LLM is doing, how it's going to implicate. So like we generally avoid colluding with the delusion initially, but when yeah, certain questions is asked by a chatbot, they try to validate the improbable beliefs. So that leads to further increase in the person's belief on their thinking, which could be irrational. So in a way, it leads to further if a person is having rather than sensing it early and referring or having some or like a response of considering a psychiatrist or considering any other human health, they are trying to validate it, so a person is getting satisfied, okay, so this kind of thing are existable and I'm whatever I'm thinking is rational. And then certain things like in the fourth point, it's written treat clients equally. So sometimes when a person himself is asking, am I getting crazy? Am I having this illness? Sometimes chatbot tries to exhibit the stigma towards certain diagnosis, and they try to no, it's certain things, certain kind of beliefs do exist. So such kind of responses may further strengthen the beliefs of the irrational beliefs of the patient, which can lead to further increase in the delusions and the perceptual abnormalities which patient might be having, they may further delay their treatment process, or like rather than having a more red flag signs on the chatbot, it's getting masked. So next slide, please. So in one of the study, they have tried to assess details of various features of AI psychosis, and in detail, they found that the person they have described in their study, that is Brandon, he was very lonely and emotionally vulnerable, and the AI chatbot, they remember that person's that feature which I was talking about earlier, that chatbot remembered conversations. That is one of the feature that was found to be enabled in that person's chatbot history also. So in a way, chatbot validated the paranoia which that person was having, which in a way leads to social withdrawal and further decline in his work and various performance, and led to increase in delusional belief. So based on their different case studies in this study by Taylor et al. In 2025, they have studied Brandon as well as various other cases. Can you change the slide? Based on their based on their various case studies, they found to have some outlook of a clinical construct at what kind of a feature a person can have with AI psychosis as compared to other general psychosis. So what they found that AI psychosis had monomania-like fixation, like they have specific themes which are centered around like certain specific delusions, grandiose, and then AI-related delusions, and it's a bit slightly deviant from the general psychosis. Then in as compared to other psychosis, they also have poor insight and impaired judgment could be there, and paranoid, referential, grandiose delusions could be there, mood elevation, hyperactivity, etc. These can be there. But along with this, for diagnosis to have as AI psychosis, they need to have like preoccupation with the engagement of AI companion, which has, so there should be a history of usage of AI chatbot prior to the clinical presentation of these features. So correlation should be there temporarily, that it has been started, chatbot conversation has been started, and followed by this has lead to this clinical presentation. And the case reports which they showed was that the course is also very variable. Sometimes the onset is within days, sometimes it's within months of AI exposure. And but all the case reports which were there, they showed the duration of continuous uninterrupted exposure was there with the AI. So the next slide. Based on their study of different case reports, they tried to do the SWOT analysis. That is, what could be the strengths, weakness, and what could be the opportunities and threats for AI. And potential strengths. What they found that in a few previous study, that was in 2024, and other study, they found that chatbot dialogues have been shown to even reduce certain conspiracy belief. In one of the study by Costello et al., they found this. And also, if a person is having in like in very early stage, so it may also help as a psychoeducation tool which can increase the mental health literacy. So in fewer studies which may be having a better inbuilt phenomena of chatbot, they have led to increase in mental health literacy. So this could be one of the strengths of AI. Then weakness is the lack of insight of detection, that the things may get missed once some red flag signs may get missed. And sycophancy, specifically, sycophancy is like they are trying to validate what a person is saying. So just to retain a person in the chat, in the conversation, what AI features have, they have this feature of mirror user tone and sycophancy, which try to agree with the client's every thought, and try to, rather than challenging it, they try to make it more convicting. So delusions may sometimes get missed. So that is one of the weakness. And opportunities could be, some studies have used AI this as a like a reminder for like medication or appointment reminders. Even in a study, they have also described it as a triage for societal ideation. But then that need to be built inside when the chatbot is created. So certain features should be there where early detection can happen. If certain kind of replies are there, then what should be the next step? What could be the referral link that can pop up on the chatbot? Then threat are threat for AI could be the possible worsening of existing psychosis. If a person is having self-harm ideas, then it may have increased risk. If like they are not sharing directly ideas, they may ask ki, what are the measures to harm. So if a question like this is coming, then something should pop up, like some helpline number should pop up, something like that. So these kind of inbuilt things are there, then these kind of threats can be avoided. So they have did this SWOT analysis where they try to find these strengths, weakness, and opportunities of AI. Next slide. So clinical implications of AI psychosis to have this at present, they are very limited studies, so it's very unclear. But if a person is having high risk, like trying to harm himself, trying to harm others, then they definitely need hospitalization. They definitely need inpatient and treatment, as well as psychological and pharmacological measures. And also, as soon as we are able to decrease or stop the exposure to AI, will be helpful in restoring the reality, coming back to the having better insight, that to break the phenomena with the AI chatbot which they have developed. And whenever we are having some suspicion of having AI psychosis, we should have separate history, separate assessment for the hours of users of chatbot, whether there was any reliance, like whether he or she was so much emotionally dependent on AI, that the kind of support which they are seeking from others, but they are not getting, and they are getting it from AI. So we need to have certain these additional history related to AI also when we are suspecting AI psychosis. And management should include the symptomatic one, including if any self-harm ideas and other complete illness we will be assessing. Based on that, the pharmacological and psychological measurement management is done. So what best, next slide, what best can be done is to psychoeducate people as much as possible that certain inbuilt features are there in the chatbot which try to amplify the thinking of the person. So the AI mirror user, that is generally that reinforces delusion. The user should know. So in these are kind of psychoeducation, but this may not be helpful in a person who is already having certain delusional beliefs. They may not be able to help, but for a general awareness of the public, we should tell ki AI have these certain features which may reinforce delusions, or which can like they don't have certain features of detecting decompensation, detecting the self-harm ideas if a person is reporting, or detecting the homicidal ideas if a person is reporting. So we can only psychoeducate, and if a person is having high emotional reliance on AI chatbot, then that could worsen the functioning. The real life functioning can worsen. That can be psychoeducated. So this is the minimal at present which can be gathered from the literature, what we can do to prevent it. Although a lot of things have been discussed in the previous session also, to prevent the time and various other, like duration should be less and exposure should be less, specifically in the teenage group, and various other things that has been discussed in the last session. So with this, I would like to conclude. I think next slide, please. So AI psychosis is not a new disorder, but it seems to be a modern variant of the existing psychopathology only. And this continuous interactivity with the AI chatbot, this increases the severity of the existing psychopathology. So that's what most of the case reports are talking about. And so AI can assist, but definitely it cannot replace the human therapy. Although we can feed the principles, even then we can't expect it can replace the human therapy. The principles as followed by a human psychotherapist can't be replaced by AI. So if a person is having good insight and completely doing well, if they are approaching AI, they may not end up. But if person is already having milder level of changes in his thought process, they may get into severe and moderate stages. So it's better to avoid if if it's possible. So that's all from my side.
If we are running, thank you, Dr. Pooja. We are running short of time. Any quick questions to both the speakers or Dr. Pooja? One or two questions.
There are some here. Arshia has asked if digital offloading impairs internal memory systems, is this a form of cognitive decline, or is it an adaptive cognitive evolution? This is to Sir. And there's one more which I had asked. Like, I mean, before this digital age, we used to read a lot of storybooks relaxedly, no? How different is that? Because even there, we are reading and reading and reading quite a bit. How different is that from digital, psychologically, and, that way? These are two that I have seen just now. Dr. Vikas, please summarize. Oh, okay. This is what was said
Okay,
for. That's it, no? Soumya, any other? Yeah, can AI be helpful in any form in providing tailor-made psychotherapy?
Yeah, that's what I mentioned in SWOT analysis also. Like there are certain strengths which are there, which some studies have tried to use it also. Like one of the study by Costello et al. 2024 study is there. There they tried to make a triage for suicide. Like certain questions they are fed in the inbuilt mechanism only, that if such this kind of question is coming, then a person need to be referred to be a human resource rather than continuing to be on AI. So it can be changed. It's nothing that it won't be, but so at present, what the state in which it is existing, these changes are not there, which has led to suicide and sometimes homicidal ideas also strengthen of those ideas. So we need to have some inbuilt changes in the software of the chatbot, that certain specific questions are to be marked, which if these questions if are coming, then a link should be there for a human refer. And these kind of things are existing. They are existing in certain certain programs are there. One is I'm not able to recall that private agency which they are doing the psychotherapy on chatbot. But once they find that there are ideations, there is one thing in symptoms, that's immediately that is referred to a human therapy. So we should have these kind of phenomena in all the chatbots to increase their efficiency and to minimize the risk of such suicide or self harm or homicidal ideas. It is possible, but it requires change in build.
Dr.
Yeah,
Vikas.
Visa chatbot, it was there. This kind of phenomena is there in Visa.
Mm.
No
So,
more.
Dr. Raka?
So, yeah, to summarize this, Dr. Pooja has given a very informative talk. She has discussed about the AI psychosis, suggesting that it is not a clinical diagnosis. She has discussed on the themes of AI, potential risk of AI in psychosis, and on the existing psychopathology, occurrence of AI in psychosis, clinical constructs, and clinical implication of AI very nicely and very informative, and need for they also suggested for need of AI in psycho education. So it was
It was
very
very
interesting
interesting
talk, and now
talk,
I
and now
invite my co-chair to give some remark if she has. Is she around?
Dr. Gracie? I can't see her. Lieutenant Colonel Gracie? No.
Mercy is not there in the hall.
Okay, thank you very much
Yes,
for
okay.
those fear-provoking presentations, both of them. Dr. Vikas and Dr. Pooja have succeeded in creating fear. So I'm very sure people will part this information with others and take care in early diagnosis and treatment of these two problems. Thank you very much, all of you. I'm very sorry for the waiting VIPs for the inaugural. And thank you very much, all of you, for joining inauguration session. So I welcome for
So,
the inaugural session. We have Dr. Amit here. Dr. Amit Bhattacharya, he is the director of Institute of Psychiatry, which is the main organizer of this conference. Please show us Dr. Amit. Yeah, Dr. Lakshmi, can you please enumerate?
I welcome you, sir. Dr. Amit Kumar Bhattacharya, sir, is the director and head of Department of Psychiatry in Institute of Psychiatry, COE, Kolkata. Sir has many achievements and awards in his honor. Sir has 10 publications in national and international journals and a very huge experience of 25 years in clinical area. The main areas of interest Sir is having is telemedicine, geriatric psychiatry, psychopharmacology, child and adolescent psychiatry. I welcome you, sir.
Dr. Amit, should we use your video or you will speak now? Dr. Amit, should we use your video?
Sir, we'll use his video only, madam.
Okay.
Not
Please
able to
run the video. He is present here. He is present here. Edwina ma'am, please. Dr. Amit, would you like to speak from there or should we run your video? Kindly unmute yourself.
Yeah, ma'am. Good evening, everybody. Basically, I've already pre-record my message and everything. I think if you can run this one, that will be better.
Yeah,
but
sure.
sorry, I'm not in a position to say just now. But anyway, it should be a nice program, and I think everybody will enjoy this program. Thank you, ma'am.
Soumya, can you? Soumya?
Ma'am.
Recorded
I
speaking.
haven't, my network is a little on the weak side. I'll just try. Dr. Amit. If Lakshmi or anyone can, so I'm not seeing it there.
Maybe Sandeep can. Sandeep? Hello, Sandeep?
It may be, it's not in day one's.
No, it has to be in day one inauguration.
Yeah.
Oh, Sandeep is not there. Hello, Sandeep.
Yes, ma'am. Sandeep is trying from another computer. He's trying to get it. It's here. मिला नहीं है
Lakshmi, ma'am, please check into that drive, ma'am. I have checked. It's not there.
Yes, sir. I also checked. It's not there.
We're extremely sorry for this glitch.
As Dr. Gupta gave the opportunity to organize this absolutely essential and indispensable program, the fourth International Nursing Conference on Age-Related Trends in Management of Addictive Behavioral Disorders and Substance Use Disorder, in collaboration with National Association of Indian Nurses of America, USA, and Addictive Behavioral Disorder and Substance Use Disorder Care Group, India. The purpose is to enable all the participating delegates of various professional groups from all health-related disciplines, that is, practitioners, teachers, and students, especially from the nursing department, to become frontline changing agents in managing addictive behavioral disorder and substance use disorder, and to share their experience with all age groups. Millions of Indians are dependent on alcohol, cannabis, and opioids, and drug misuse is a pervasive phenomenon in Indian society. Published jointly by the UN Office on Drugs and Crime and Indian Ministry of Social Justice in 2004. Millions of Indians are dependent on alcohol. So in 2019, according to NISD in India, among 10 to 75 years age group, alcohol is 14.6 are current users and 5.2% are dependent. Cannabis, 2.8% are users. And for opioids, 2.06% are users, with roughly 60 lakh people requiring treatment. There is a substantial treatment gap exists between those who need treatment and those who received it. According to 2023 published data, prevalence estimate of drug use of substance use disorder are high across most of the countries. Alcohol is the most frequently used substance, and it is estimated that 2.3 billion people worldwide currently use alcohol. That is the 40% of the adult populations. The number of people worldwide who uses drugs other than alcohol and tobacco was estimated to be around 275 million in 2019, with the largest share among adolescent and young adults. Cannabis was used by 200 million people. It is the most frequently used illicit drugs and accounted for more than half of all the drug-related offenses happened worldwide. On the other hand, opioids accounted for the most deaths, which in the past decade have increased by 41% in 2019. Regarding addictive behavioral disorder, in 2022, according to National Library of Medicine, the global prevalence of behavioral addiction is 11.1%. With smartphone addiction being the most common, it is nearly about 30.7%, followed by food addiction at 21%, followed by internet addiction 10.6%, gaming addiction 5.3%, and gambling addiction is 7.2%. This data is collected for meta-analysis from 40 different countries. So we can understand that age-related trends in management of addictive behavior disorder and substance use disorder. And how is this topic absolutely essential and indispensable in today's world? Once again, I want to welcome you all to enjoy the presentation made by the stalwarts and eminent speakers from Canada, USA, UK, Ireland, Norway, Indonesia, Maldives, Sri Lanka, and India. Thank you all, and I wish a grand success of this 4th International Nursing Conference.
Thank you very much, sir, for being present here. So at least I could run the audio and you are physically present. I'm sorry. And I'm sorry for this technical glitch. Sometimes it happens, the files are very heavy.
Thank you, ma'am, for give me an opportunity and give our institute this opportunity to organize this type of program. Thank you, ma'am.
Thank you so much, sir. With folded hands, I thank you very much. And Dr. Geeta for helping us to have this conference at such a large scale. Thank you. Lakshmi, please read.
Thank you, ma'am. Now I welcome Dr. Franklin Miricha. He is a project officer in the Institute of the Colombo Plan Secretariat, Colombo, Sri Lanka. The Colombo Plan is a regional organization that aims to promote economic and social development in Asia and the Pacific. Sir has a huge work experience. Sir manages and implement projects related to economic and social development, coordinates with member countries, donors, and stakeholders, develops project proposals, report, and documentation. Sir monitors and evaluates project progress and facilitates training, workshops, and conferences. I welcome you, sir.
Thank you very much. Am I audible?
Yes.
Yes, sir.
Thank you for that introduction, and I'm very much privileged to be here. Of course, I want to probably take a quick, opportunity to thank everyone, especially the organizers, for the privilege of having this forum, especially at this date and time. I will say a few words, the next few minutes. My thoughts would be around, substance use itself, or addiction behaviors and addiction disorders, and broadly the workforce that we have to intervene to it, and then how probably it relates to the treatment quality. Of course, we know that there is a growing concern. The complexity of addictive disorders is growing day after day. And of course, we require a very well skilled and informed workforce to be able to address this challenge that we have. Of course, we know, and maybe we'll have time to talk about it as we go along, there is a lot of emerging other problems like the synthetic substances, that pose even more serious issues than what we traditionally know. Of course, we know this will bring a lot of challenges in how we will look at treatment or interventions and all that. These substances, of course, they mimic the substances that we know, and we don't have much of what it means as we go along as thinking about how to address these issues. Some of them, of course, we know there's a lot of synthetic cannabinoids, we have synthetic opioids and many other things. And research is telling us that there's a very huge correlation between the people handling interventions for addictive behaviors and their competence and how the quality would be, or the quality of the outcomes that we know or we will get from that treatment itself. Of course, Francis spoke to us about relapse, and is trying to tell us there's a lot of study, and probably I would invite you to look at those studies, that the quality of the treatment professionals that we have and the outcomes of these interventions have a very strong correlations. Now, of course, we know treatment requires a multidisciplinary of fields. We need expertise in counseling. We need expertise in pharmacology, behavioral therapies. We need cultural things and all that. And I'm also very happy that now we have started to accept that nurses also play a very important role. I don't think we have done a lot previous years in looking at nurses themselves and how nurses contribute to interventions relating to substance abuse. And I'm happy that this is coming at this time. Of course, nurses probably might be the first people who have, who interact with the patients, from the initial entry in terms of screening, in terms of advice, and actually most people, I don't know if it is political, but I think that people trust nurses more than many of us. So as we go along, I think it is a good thing that you're starting to invite now the discussions how nurses will have to also join this wagon and help us in intervening to substance abuse. Of course, we have to accept, and I'm happy that we have such forums, that as this field evolves over time, then we would be able to also start also being informed or stay informed or aware of the evidence-based practices that are there, the different standards that are emerging, and of course, emerging treatment modalities. And as you also talk about treatment, also remember that there is prevention and many other things. And as this conference, which I see it is the fifth, I think I've seen the fourth, and I assume they have been the first one and all the others. And I'm happy that this is the fifth, and we seem to be going in the right direction. So I'm sure this key conference will improve our competencies as we go along. And it is continuous education and learning from many other people. I think I've spent the time today here, and I hope I'll be able to stay along. And it is it's learning, a lot of learning. I've met quite people I've interacted with before, and I'm happy that we have the opportunity of these great minds to tell us, to talk to us, and I'm happy to be part of it. Of course, we know that age-related is a big issue. Age has always been, and we have been told that age is a determinant of disease in the sense of very many things. Of course, in terms of prevalence, in terms of many things, age is a very big issue that we start talking about. And of course, those people who have interacted with me before know that I have been also talking about age, but of the dimension of children. So the age itself, the spectrum of children, because you have not been talking too much about children and substances and addiction behaviors, and now the elderly, or as people grow older. So these all dimensions become very important, and they are very timely as we have these discussions. Of course, we know that professionalizing of these substance use and addictive behaviors is very important, and I will talk around that as we move along. Why also I agreed to come here is to talk also about what we are now discovering, that we can actually learn more on the online space. And we have started to explore very many ways on how we can move these discussions, or we can learn from a click of a button. Of course, I can see we have been able to reach more than 300 people, and this is amazing. We will never have imagined before COVID that we can be able to reach all this number of people all over the world to have these made discussions. So as we have also explored all that, and we are starting to develop and design platforms where people can learn on our cell phones. We have a lot of now materials that are there in the digital platform. So maybe if the organizers will allow me to share this, Colombo Plan, of course, we have spoken about it. Colombo Plan has been like the major organization in the region that has been talking about issues of substance abuse and addiction behaviors and support, especially in regards to capacity building. I'm sure many of us here have interacted with Colombo Plan, and if you have not, then you need to find us. So we have developed a digital platform that is delivering virtual training. We have now been able to upload the universal treatment curriculum, those who know it. And this curriculum enables addiction prevention practitioners. And I want to encourage nurses to also look at this, because it is a very big eye opener. From when I was listening to the discussion today about the disease model and what is coming out, or we have to look at this in both ways, and we could invite you to look at these courses. We now have 8 courses there. We can start looking at these courses to have a bigger understanding and then broaden our minds. So without taking so much time, I will share the details of that curriculum that we are doing, which is online. I'm the one coordinating it, so I'll share my details and we can go along together. So thank you very much, and I wish you all the best as we learn and we continue to learn. And I hope this is developed even much further to be able even to create a website for nurses that we can upload all these materials. And I'm also challenging people who are in politics to also challenge Colombo Plan also to develop. We are in those thoughts of developing a specific nursing curriculum that relates to interventions for substance abuse. And as we go along, I'll want to encourage you and welcome you to this, and we learn together. Thank you very much.
Thank you so much for giving us time and speaking to the delegates and inspiring them from your busy schedule. I request Dr. Achmat, Mr. Achmat, to kindly. He is the next speaker, Mr. Achmat.
Okay. Thank you, Dr. Gupta. Am I audible?
Yes, please. Just a minute. We'll just give your introduction first. Lakshmi.
Edwina ma'am, change the slide, please.
She has changed the slide. Oh, slide is out. Just start again the sharing, please.
Soumya?
Not here. Sandeep, can you share?
Ma'am, the next slide.
Yes. Slide is not moving.
Yes, I've got it.
Okay.
I'll share.
Yes, please.
I welcome you, sir. Dr. Achman. Sir is the director at Caritas Sani Madani Foundation, and sir has many achievements and awards to his name. Sir is a global trainer for universal treatment curriculum and recovery support, Colombo Plan DAP, contributor to Indonesia national standards for SUD treatment centers and national certification for addiction counselors. Sir is a president, Asian Recovery Network, and chair ISSUP Indonesia Operational Committee. Sir has more than 20 years of experience in substance use disorder prevention, treatment, rehabilitation, and recovery support. Sir has an extensive experience facilitating capacity building for treatment and recovery professionals across Asia and Africa in collaboration with UNODC, Colombo Plan, and national agencies. The areas of interest are addiction treatment and recovery, professional capacity development, motivational interviewing, family based intervention, and community based recovery systems. I welcome you, sir.
Thank you, Ms. Lasmi. And hi, everyone. Good evening. Warm greetings from Jakarta, Indonesia, to all the distinguished speakers, members, students, and participants joining us from different parts of the world. It is truly a pleasure and an honor to be here with you, everyone, at the 4th International Virtual Nursing Conference on Age-Related Trends in Addictive Behavioral Disorder and Substance Use Disorder. First of all, before anything else, I want to express my sincere appreciation to the organizing teams, right? I think organizing a global virtual conference of this scale requires tremendous dedication and coordination, and the quality of the program, the diversity of speakers, and the relevance of the topic all reflect the hard work that the organizing teams have invested. Thank you for making this important gathering possible. I also want to acknowledge the pre-conference debate and workshop. They are very interesting. They are simple but very crucial insight that age matter. Children, adolescent, adult, and older adult face different risks and challenges related to addiction, and they also recover differently. This perspective connects beautifully with the session we will exploring today and for the next 2 days. It is also important to briefly recognize the scale of the problem we are gathered to address. Around the world, substance use disorder and behavioral addiction continue to rise. Many people struggle in silence, and far too often services are limited, fragmented, and or inaccessible. The impact spread beyond individuals. It is touching and impacting families, workplace, schools, and entire communities. And yet, behind every statistic is a person with a story, with strengths and with the capacity for change when given the right support. So, over the next 2 days, this conference will cover key issues that many of us see in our daily practice, from substance use disorder involving opioids, alcohol, tobacco, and cannabis, to behavioral addiction like gaming and smartphone overuse. We will also look at relapse prevention, digital mental health, and innovative nurse-led approaches that are shaping the future of treatment, rehabilitation, and recovery. These topics are not just academic discussion; they reflect real situation real situation we encounter every day in hospitals, community clinics, schools, workplaces, and homes. Nurses and allied professionals play a central role in these settings. You are often the first to identify early signs, the one who walk beside people during treatment and rehabilitation, and the one who continues supporting them through long-term recovery. Your role is vital, and your compassion and commitment truly make a difference. As a guest, I'm genuinely honored to be part of this conference. Even like this, remind us that we belong to a global community, learning from one another, sharing innovation, and strengthening our ability to provide person-centered, evidence-based, and recovery-oriented care. Thank you once again to the organizer for inviting me, and congratulations for creating such a meaningful and timely event. I wish everyone 2 days filled with learning, connection, and inspiration. Thank you so much.
Thank you so much, Mr. Ajmer, for agreeing to participate. And I'm sure you are already contributing so much in the world, and you are contributing for us in this organization of the conference. I'm very happy that the people will know how much work is going on in this area, and they will also start doing much in this area. Thank you so much, Mr. Ajmer.
Yeah. Thank you for having me, Dr. Gupta.
I welcome Uma Venugopal.
Hello, ma'am. Good evening, everyone.
So, Lakshmi.
I welcome you, ma'am. Ma'am is the president of National Association of Indian Nurses of America, NAINA. Ma'am is currently serving as a drug diversion nursing lead at a local healthcare system at Williams-Patterson University, Wayne, New Jersey. Ma'am has many achievements and awards and honors to her name. She is the 10th president of the National Association of Indian Nurses of America, secretary for the National Association of Indian Nurses of America from 2023 to 2024, National Convener for National Association of Indian Nurses of America, 4th Clinical Excellence and Leadership Conference in 2023, Chicago. Ma'am is a lead nurse planner for the National Association of Indian Nurses of America, and ma'am's key areas of interest are mentorship, serving community, building relationship, and reading and writing. I welcome you, ma'am.
Thank you so much, dear Lakshmi. That was very gracious of you. And welcome and greetings to everyone. I hope I'm audible. Thank you so
Yes,
much.
ma'am.
All right. Thank you. So good morning and good afternoon and good evening to everyone joining us from across the world. It's my pleasure to welcome you all of course, our nurses, students, physicians, and other healthcare workforce individuals on behalf of the National Association of the Indian Nurses of America, the so-called NAINA, to this fourth International Virtual Nursing Conference on age-related trends in the management of addictive behavioral disorders and substance use disorders, organized by, of course, our well-known Institute of Psychiatry Center of Excellence, Kolkata, in collaboration with the NAINA group and the ABD and the SUD-CARE group. So thank you, everyone. As we all know that this conference brings together the entire healthcare workforce, right? Such as our nurses, educators, researchers, and leaders committed to advancing care for individuals living with addictive behavioral disorder and substance use disorder across the lifespan. The age-related trends, influences, vulnerability, treatment engagement, and recovery, making this dialogue both timely and essential. As we all know, today's younger generation has increased access to substances such as cannabis and opioids, often viewing their use as recreational or harmless, yet these patterns carry significant risks. Understanding these shifting behaviors is so critical as we work to protect our emerging populations and strengthen our prevention efforts across all age groups and, of course, across the globe. Over the next 2 days, you will all be engaged with global experts, innovative practices, and collaborative conversations that strengthens our shared mission, empowering our nurses with the knowledge, compassion, and accountability that's needed to respond to this addiction with skill and humanity. So thank you for your dedication and for being part of this important journey with us. I extend a warm welcome to each of you, and let's begin this meaningful conference together to alleviate the stigma, challenge cultural bias, and advance compassionate, evidence-based care for all affected by addictive behavioral disorder and substance use disorder. Please join me in applauding all our organizers who work day and night to host this conference. Kudos to all of you and wish you all the best. Congratulations.
Thank you so much, Uma Vinugopal.
Thank you, ma'am.
If she did not agree, we would not be collaborating with NAINA, and I'm so privileged and we are so happy to continue this collaboration with the NAINA. Thank you so much.
It's our honor, ma'am. Thank you for including us and integrating us. So it's wonderful. Thank you. Pleasure.
Yes, Lakshmi, please, Dr. Arunjot.
Yes, ma'am. Now I am very happy to welcome Dr. Arun Jyoti Barua. Ma'am is a professor and head of Department of Psychiatry in LGB Regional Institute of Mental Health, Tejpur, Assam. Ma'am completed her BSc Nursing from Guwahati University in 1991, then MSc in Psychology from Guwahati University in 1994. From Masters in Psychiatry Nursing from NIMHANS, Bangalore in 1997. Then ma'am completed her PhD in Nursing from Manipal Academy of Higher Education, Deemed University in 2003. Ma'am completed her PhD in Psychiatry Nursing from National Consortium for PhD in Nursing by Indian Nursing Council, Rajiv Gandhi University of Health Sciences, Bangalore in 2014. Ma'am has a huge experience of 32 years in the field of mental health nursing, and ma'am got the National Florence Nightingale Award in 2009 and has been received from President of India on 12th of May 2009. Ma'am is a life fellowship. Ma'am got the Life Fellowship Award from Indian Society of Psychiatric Nurses on 15th of February 2019. I welcome you, ma'am.
Thank you so much, Lakshmi, for this introduction. Good evening, one and all present here. With great pleasure, I welcome all the dignitaries, all the esteemed resource persons for these next 2 days, and all the delegates who are present here. Here are the greetings from LGB Regional Institute of Mental Health, Tejpur, Assam. This is one of the oldest mental health setup of the country, situated in northeast part of the country. I should say, Madam Sandhya Gupta and the organizer, really we are very much privileged and we are feeling very happy to be part of this 4th International Virtual Conference on Management of Age-Related Trends in addictive behavioral disorder as well as substance use disorders, because I consider really it's a great opportunity for all the learner, like particularly my students, my PhD scholars. It's really a great platform that they would get like to know many things. And I also consider that this is a platform where the nurses who are really working on various parts of the globe to showcase their work and to inspire everyone, all the institute, all the new learners to implement all this in their routine day-to-day practices. So really, I'm really blessed that we are part of this conference. Irrespective of the age group, increasing rate of substance use disorder and behavioral addiction is really a major medical and social concern in the country. So this is definitely true for this part of the country also. And as I said, I am very much positive to see that in these 2 days will really give us many more management strategies, many more nurse-led interventions, many more evidence-based practice and innovative ideas, so that we can really think of to implement and change the healthcare delivery system as a nurse, and we can really make a place for nurses in this field of practice. So saying this with lots of hope, I'm waiting for this next 2 days, and the morning shows the days. Already we have been seeing so many good things has happened. So many good speakers have already deliberated the speech and shows the ways. So with this, I'd like to conclude, and my good wishes for a grand success of this conference. Thank you one and all.
Thank you so much, Dr. Arun Jyoti, for your kind words and for inspiring the delegates. And I'm so thankful that you have collaborated with us right from the beginning. And we have had 3 previous international conferences, and she has been our collaborator. Thank you so much.
Thank you, ma'am.
To welcome Elizabeth Sam.
Yes, ma'am, I'm here. Thank you.
I welcome you, ma'am. Dr. Elizabeth Sam is a nurse practitioner, PCP, at the Institute, Arizona Indian Nurses Association Advisory Board Chair from 2025 to 26. Ma'am has many achievements and awards and honors, like she received several accolades and awards for productivity, excellence, and IVth award also. Ma'am has a work experience in internal medicine, primary care provider with Phoenix Veterans Health Affairs, Arizona, actively engaged in NAINA and ASINA governing board, and as a steering committee chair of Coalition of Asian American Nurses, that is CAAN. Ma'am has the key areas of interest are networking, mentorship, and leadership. I welcome you, ma'am.
Am I audible?
Yes,
audible. Yes, you are. Thank you, Dr. Lakshmi, for kind introduction, and greetings from Arizona, USA. It's an honor and privilege for me to present here today on behalf of Arizona Indian Nurses Association, USA. We were the collaborators, and I'm very happy to say last 2 years or 3 years we were able to associate with the SUD team. and I'm the current advisory board chair and immediate past president of AZENA. I'm pleased to say this international virtual nursing conference platform brought us together to reflect on an issue that touches many families, communities, and nations across the world. And to learn from experts in the next 2 days in the field is an awesome experience for all of us. The theme chosen for this year is very both timely and essential. It reflects the realities we encounter in our day-to-day practices as nurses and providers being in the front line. Each age group presents unique challenges and they all present their issues differently, from adolescents experiencing with substances or digital behaviors, and the working age adults coping with their stress through addiction, to older adults encountering substance misuse in association with isolation or chronic medical conditions, and mainly their pain issues. So each age group faces unique vulnerabilities, and they all require individualized, tailored approaches for prevention by proper assessment, treatment, and recovery support. So focusing on these age-related trends, we have to strengthen our ability to deliver care which is compassionate, evidence-based, and responsive to the diverse needs of the individual and communities we serve. I'm very much hoping this conference shapes us to design effective prevention programs, strengthen clinical services, and build policies that acknowledge the diverse realities of these struggles with addictions we are facing today throughout the world. As we all know, addiction is not just a moral failing, it is a complex health condition, and its management requires collaboration between healthcare professionals, educators, policymakers, families, and society at large. I want to thank and comment and extend my gratitude to the organizers of the conference, Institute of Psychiatry Center of Excellence, Kolkata, West Bengal, Dr. Sandhya Gupta ma'am and her phenomenal team for months and months of hard work for connecting speakers, people nationally, internationally, and coordinating with all of us. And the collaborators, National Association of Indian Nurses of America, NAINA, which is AZENA's parent organization, and our Dr. Uma Venugopal, our president, and ABD&SUD-CARE Group, India. Thank you, and wish you all an enriching and impactful engagement throughout this conference next 2 days. Thank you all.
Thank you very much, Elizabeth, for being here physically and addressing all of us. We really cherish the collaboration with AZENA in the past and will continue to do so. Thank you very much for your kind words. Edwina, ma'am, DCP may or may not join because he is busy. He sent message. So now I request you to please show us the slide of chief guest, Dr. Anju Dhawan. Lakshmi.
Thank you, ma'am. Now I welcome Dr. Anju Dhawan. Ma'am is a professor and chief at National Drug Dependence Treatment Center, AIIMS, New Delhi. Ma'am is involved in this field of drug de-addiction since last 2 decades. Ma'am has been a member of expert committee in WHO, member of academic and training committee, ISAM, and has done various projects funded by UNODC, WHO, MSJE, and NCP-CR, etc. Till date, ma'am has many publications, like 130 publications, and funded projects as a principal investigator, total 11, and 12 funded projects as a co-investigator. Ma'am has the key interest areas like adolescent substance use in school, healthcare and community settings, and meditation research. I welcome you, ma'am.
Thank you very much. I'm very grateful for being given this opportunity to join this 4th International Virtual Nursing Conference and welcome all the delegates who are there from across various fields and across countries. In fact, I have been fortunate enough to attend the first 3 conferences also, on Dr. Sandhya Gupta's invitation. And I must say that they were all of excellent quality, and each conference seems to be getting even better. Looking at the agenda itself is very exciting, seeing the kind of themes which are there. And each of these conferences, the sense I'm getting is that it's building on the efforts of the previous ones and getting stronger and stronger. I can see that there are about more than 250 people who have joined the online conference. And as we speak, I feel that in terms of the knowledge and the skills of nursing staff in the country are changing, and these conferences are very instrumental in that, in the field of substance use and addictive behaviors. More and more, the substance use problem in India and also the problem of behavioral addiction is being recognized now. There was a time that it probably did not get that much of visibility as people who are involved in the field as treatment providers, which most of us probably are treatment providers here in this conference. We could see the impact that it has. The survey figures which have already been shared were also showed the impact, but now it has also captured a lot of attention at a very high level overall in the country as well, and there is a lot of political will to address this issue now. uh, it's good to see that different institutions have been involved in taking up the responsibility to organize this conference, and this time it is the Institute of Psychiatry Center of Excellence, Kolkata, West Bengal, along with NAINA USA and the ABD and SUD Group India. I would like to congratulate all the organizers for their the amount of effort they have put in and the outcome which has come as a result of that. And I'm sure Dr. Sandhya Gupta, as usual, has played a very important, pivotal role in these efforts. The theme itself, which has been chosen for this conference, age-related trends in management of addictive behavior disorders and substance use. It's a very important theme, and I feel that what it has done is that the topics which have been chosen as a result of this have gone one step deeper to look at many of these concerns from an age perspective as well. So, looking at, for instance, behavioral addiction, what we may see in a young person who may be using internet excessively, vis-a-vis what we may see in an older person, may be very different. The impact may be very different. The clinical profile may be very different. As with other substances, and all kinds of substances have been covered. There are sessions on tobacco, stimulants, etc., which is really heartening to see. And the coverage seems to include the biological aspects, talking about the brain disease model to psychosocial interventions to innovative aspects, the nursing led initiatives, and regional challenges which people have faced. And it was also very good to see the session by on UNODC TreatNet Family and Family United, which are very important modules. And I think it will be very important for the nursing staff to get familiar with these modules and how they could be used. And they can play a very, very crucial and critical role in dissemination of this knowledge, in utilizing it in clinical care and also the preventive aspects. And I can see that there is a pre-conference workshop and a debate which adds a lot of color and interest to the conference. Many of the speakers, again, a very rich uh, choice of speakers who are from across various countries through the world, Canada, USA, various parts of the world, including India. Many of our own faculty from the National Drug Dependence Treatment Center are speakers. And I'm sure the rich discussion and exchange of experiences will be very, very important. I thought I will share a little bit about NDDTC, the center where I work, the National Drug Dependence Treatment Center. India is a nodal center under the Drug Addiction Program, Ministry of Health and Family Welfare. Some of you may be familiar with the work of the center, others may not be. Our focus is, besides being on clinical care, is on expansion of services. And there is a lot of focus on public health in order to make treatment accessible And NDDTC, through the Ministry of Health and Family Welfare, as well as Social Justice and Empowerment, runs drug treatment clinics and addiction treatment facilities, which are about currently 100 in number across the country. And many of the institutions here may be playing a very important role there. Additionally, our efforts include capacity building, research, providing inputs for policies. And we have a multidisciplinary team, including psychiatrists, psychologists, nursing staff. And nurses have always played a very important role at NDDTC. Dr. Sandhya, when she was working at AIMS, was as a faculty in the nursing college, was a trainer for many of these nurses. And I can see one of our nursing staff is also delivering a she's one of the speakers, which is great to see that the practical experiences are also going to be shared from our center. We also developed a manual for nurses at NDDTC, which our previous chief and Dr. Sandhya Gupta were editors. And in the past, we have held several training programs for nurses as well. Now, as far as age-related concerns are there, they have been a focus of attention for us, and we started an adolescent substance use treatment clinic way back in 2003, which was a first of its kind. Now it's been there for more than 20 years. And we have initiated several studies looking at the assessment of magnitude and correlates of substance use in adolescent populations, whether it's street children, school going children, and also in general healthcare settings. Specifically related to the general healthcare settings, in adolescent friendly health clinics, which are now there across India, we conducted a screening of adolescents who are coming to these adolescent friendly health clinics for substance use disorder using assist tool. And this was done by the nursing staff who were working at the adolescent friendly health clinics, and so that it could be integrated into their routine clinical care. So we know that adolescents may not often come for treatment to very specialized settings. Only a small proportion may come. But we do know that most people, when they start drug use, they are adolescents. But in treatment settings, if we see, only 5% of our people who seek help in drug treatment settings are adolescents. So there is a low treatment seeking in this group. So considering that, we thought it will be very important to go to a general healthcare setting and do a screening exercise. And what we felt was that the nurses can play a very important role in screening, brief intervention in general healthcare settings, and referral to treatment to specialized settings for those who need more intensive treatment. Another very important aspect, which I think is something which nursing staff should be involved in, is of course, here we have talked about diagnostic tools and additionally psychosocial interventions. I can see a session on that. And I think it's very important to develop those skills so that the psychosocial intervention can be imparted by them. More and more, I feel that nurses need to claim this space in the field of substance use disorder so that this gap in treatment can be filled up and they can provide the required care. At NDDTC, we are also running a behavioral addiction clinic, and one of our faculty is a speaker who's, I think that talk has already happened on behavioral addiction aspects, which are related to and the specific age related aspects. So I wish the conference a great success, and I hope that these efforts continue, and wish you all a very good learning experience. I can see the enthusiasm of the delegates as well from their remarks, which are being posted in the chats, when they are asking questions or commenting about the talks. So wish you all a great learning experience. I think this is a very good use of an online platform to ensure that knowledge can be imparted in a very cost-effective way, in a very convenient way. And I wish all the organizers all the best and hope these efforts continue. Thank you very much for giving me an opportunity to be here.
Thank you so much, Dr. Anju Dhawan, for your support every time. And we look forward that every time we do some work, we always collaborate with NDDTC faculty and nurses and everybody else who works there. My association with the De-Addiction Center at AIMS goes back to 1988, when the inception took place that there should be De-Addiction Center. And Dr. D. Mohan called me and he said that only Sandhya has to do this work. So from that day till today, I am there with De-Addiction Center. So thank you so much for joining us, and your support is a real privilege for me personally. And I really like to continue with this work as long as I can. Thank you so much. Thank you.
Well, we have been at this sitting all the time. Maybe this is a time for all of us to just stand up and stretch, because we are going to be introduced the most active member who's leading this workshop. So get up and then stretch and, just loosen up and then can sit down. And Dr. Lakshmi will now do the honors of introducing Dr. Sandhya Gupta.
Thank you, ma'am. Now I'm feeling very much honored to welcome not only the backbone, but the soul of this fourth International Virtual Nursing Conference of ours. I welcome you, Sandhya ma'am. Dr. Sandhya Gupta is a health consultant and lifestyle coach certified through USA, advisor and consultant at NHS UK, advanced nurse practitioner certified from Australia. Ma'am was formerly associate professor and acting principal at College of Nursing, AIMS, New Delhi, formerly secretary, Indian Nursing Council, Government of India. Ma'am was a fellow to Australia, worked with Danish Medical Mission and Araki College of Nursing. Ma'am was chairperson for nationwide training for capacity building for COVID-19 first and second wave and post-COVID-19 sequelae, tobacco control training and elder abuse for Ministry of Health and Family Welfare, Government of India, member of expert group on mental health training, WHO Geneva, member of expert groups nationwide, Nursing and Midwifery Commission, Bureau of Indian Standards, Addiction Psychiatry, Indian Association of Health Informatics, Care of Older Persons, HelpAge India, National Mental Health Program, Health Informatics, etc. Ma'am has many awards and honors to her name. Ma'am was decorated with President's Gold Medal by University of Delhi, TK Underwala Prize for Best Dissertation, Best Research Award for Amazonians of America, Prashasti Award by Bharatiya Sathi Sangathan, Fellow of Indian Society of Psychiatric Nursing, Advanced Practitioner certified by Australia, did WHO Fellowship in Australia, Thailand, Myanmar, and Geneva, Chief Editor of Indian Journal of Psychiatry Nursing since 2009, published over 165 publications in scientific journals and many modules and books for WHO and Ministry of Health and Family Welfare. And ma'am is the PhD guide for INC, Chitkar University, and MIT University, and IIHMR. I welcome you, ma'am.
Thank you so much, Lakshmi. It is my privilege to be here, and I really want to propose vote of thanks to all the people who have joined, our chief guest, Dr. Anju Dhawan, and all the dignitaries who have joined us today, Dr. Franklin, Mr. Achmad, Uma Venugopal, Dr. Arun Jyoti, Ms. Elizabeth Sam, and Madam Geeta Purkhet, who is the principal of IOP. So I can only say that I'm very humbled that so many people have joined me in this endeavor, and so many of you are here at this point. And I can only say God bless you, and we'll have many more learning time in future also. Thank you very much, and God bless you.
Dr. Geeta is here. I just saw her. She's come. I'll just kind of get her slide. Yeah.
Dr. Geeta, please open your video. Video is open. I would like to introduce Geeta Purkhet. She works in one of the oldest hospital, that is the Institute of Psychiatry Center of Excellence. It has more than 205 years old. So you can imagine what kind of tradition they carry. And when they celebrated 2000 years, they invited me there. And then I came to know how the hospital looked like long time back. And they also have a new wing and it is renovated now. So she is a principal and associate professor in that institute. And they are running postgraduate programs. She has done masters in psychiatry nursing. And she is also trainer for BLS and ACLS. She is a PhD scholar at the moment. She is also having membership to various organizations. She is editor of MAT journals and 7 publications she has made and in international journals. She has organized bicentenary program of nursing section and she has been a speaker to various orientation and training programs. And she has been managing mental health training for almost all the institutes of West Bengal because they look forward to get training there. She has clinical and academic experience of 28 years. She is interested in telemedicine, geriatric care, child adolescent psychiatry, and research on PWMI and relatives. I welcome you, Geeta ma'am. Thank you so much for taking this responsibility along with me. Thank you.
Thank you, madam. Thank you, madam, for such vast introduction of myself. Though no one can go back and make a brand new start, anyone can start from now and make a new grand ending. Charles Bird. A warm good evening from India to all and seasonal greetings. And a big thanks to Dr. Sundha Gupta, health consultant and former principal, College of Nursing, AIMS, Delhi, to give such vast opportunity to the Institute of Psychiatry Center of Excellence, Kolkata, to be an organizer in collaboration with National Association of Indian Nurses of America, that is NAINA, USA, and ABD&SUD-CARE Group, India, of this 4th International Virtual Nursing Conference. And Madam Gupta gave me this golden moment to propose vote of thanks before the dignitaries of this inaugural session. I sincerely appreciate it, Madam. It's my great pleasure to offer each of you vote of thanks. My dear friends, thanks a lot from the bottom of my heart. Our very own Professor Dr. Amit Kumar Bhattacharya, Director, Institute of Psychiatry, Center of Excellence, Kolkata. Dr. M. Birichia, Colombo Plan, Sri Lanka. Mr. Ajman, Director, SKMF, Indonesia. Ms. Uma Venugopal, National Association of Indian Nurses of America, USA. Dr. Arunjyoti Borua, Head of the Psychiatric Nursing Department, LGBRIMH, Tezpur. Ms. Elizabeth Sam, Agena, USA. Our chief guest, Dr. Anju Dhawan, Chief, NDDTC, AIMS, New Delhi, and all the participated delegates of various professional groups, that is all health related disciplines, the practitioners, teachers, students, researchers, especially from nursing. We are honored to have guest speakers and participants from diverse backgrounds. Dear participated delegates, let's enjoy learning on the timely and very much appreciated topic, age-related trends in managing of addictive behavioral disorders and substance use disorders, that you become the frontline change agent in managing and sharing experiences with all age groups in every situation as much as possible. And then only this vast work will find the desired success. Word of appreciation to each and one present at this virtual platform. Once again, I am wishing you all an inspiring and enjoyable conference ahead. Namaskar. Thank you.
Thank you very much, Geeta. So we can wind up inauguration. Everybody, thank you very much for being here for inaugural session. Now I request the keynote address one to start.
Sure. Thank you, ma'am, for your visionary leadership. Now we'll move on to the keynote address first. I'll share my slide.
I tap it like this stuff. You left your cap in Catholic club.
Edwina, ma'am. Ma'am, can you please mute your mic? That was so sweet. Well, moving on to the first keynote address, that's on leading with accountability, a global perspective on drug diversion and risk management in healthcare. So for this, we have got our chair, Dr. Hemant Datta. He is the HOD Department of Addiction Medicine Associate Professor, Deputy Director, and CFNAO LGB Regional Institute of Mental Health, Tejpur. He has got his global training from Public Health Policy, London, UK, Mental Health Leadership, Melbourne, Addiction Treatment, Yale University. Moreover, he has earned a lot of awards and honors to his shoulder, to his head, as a Kayakalp Award winner in the year 2018 and 19. Led the team to win Ministry of Health and Family Welfare recognition. Moreover, he has been the estate officer in charge of the estate management, legal services member of special unit under the NALSA scheme, compliance supervising officer for Mental Health Care Act 2017, and more than 25 publications. We have with us our co-chair, Dr. Renju Sushan, ma'am. She is the assistant professor from the Institute of IHBAS Delhi. She has been a PG rank holder from AIIMS Delhi 2007 and the PhD in psychiatric nursing from INC in the year 2017. Her national level SUD master trainer for nurses as well. She worked as a nursing superintendent as additional responsibility at AIIMS Bhubaneswar from the year 2020 to 22. Moreover, she has served as a faculty in charge in academics at AIIMS Bhubaneswar. She had been an author of MOSC Manual of Psychiatric Nursing and a peer reviewer of IGPM. I welcome both of you, ma'am. Over to you, ma'am, to lead the session for the speakers.
Thank you. I request Hemanta Datta sir to introduce the speaker.
Thank you and good evening to everyone. So I am at first expressing my thanks to all the organizers because it's a privilege for me to attend this kind of sessions. So with this, I would like to introduce, it's a unique kind of topic and an interesting topic. So I would, in this line, I would like to introduce, please show me the previous slide. Next one. Next. The side. Yes, thank you. So I would like to introduce Uma Maheshwari Benugopal ma'am. She is the president of the National Association of Indian Nurses of America. So currently serving as drug diversion nursing led at local healthcare system. She is from William Peterson University, Wayne. She has have multiple achievements like 10th president of National Association of Indian Nurses of America in 2025 and 26. She is the secretary for the National Association of the Indian Nurse of the America in 2023 and 24. She is the national convener for National Association of Indian Nurses of America and the 4th Clinical Excellence and Leadership Conference 2023, which was held in Chicago. She is the lead nurse planner for the National Association of the Indian Nurse of the America. Her special area of interest are mentorship, serving community, building relationship, and reading and writing. So with this, I would like to request Uma Maheshwari ma'am to start her session.
Thank you, everyone. Good evening. Good evening to all of you. And thank you so much, Dr. Hemantata, and um, for introducing me, taking the time to introduce me. I would like to share my presentation. So let's get started with that. And then at the end, I'll take the questions. I'm actually presenting the recorded session. So in case of any instability, I thought it's easier that way. So let me do that.
It is that the next slide is your presentation.
Is that I'm actually sharing? Are you able to?
Yes, we can see you.
Okay.
And it's full screen.
It's visible, ma'am.
Perfect.
But your sound is not enabled.
Is it? Maybe increase the volume.
Share sound.
Is that better?
No, you have to share.
You have to share sound. Please go to more MORE and then it will have the menu for share sound. Please touch more MORE.
Do you want us to share it?
Yeah. Is this audible or not really?
No,
Not
no,
so?
no. Share of sound is not, sharing
No,
of
no.
sound is not taken place.
It is stopped. You haven't yet, at least I can't see you speaking.
Yeah, now, yes. Now maybe.
But it's not
Now you
audible.
share sound. Share sound, please. Touch MORE, more on the right side, down corner. It will give you option of share sound.
Where you have audio and video on the left, on the right, there's dots.
My talk, Leading with Accountability, connects this theme with leadership and ethical practice in nursing globally. I wanted to start this presentation with a small story that happened years ago. As I worked with two clinicians, everyone trusted this veteran nurse and respected mid-career physician. Over time, small changes appeared, missed details, unusual fatigue, documentation errors, and so forth. We brushed it off as either burnout or age-related noticeable changes. However, eventually we learned that they were both quietly struggling with substance use disorder. Their ages and life stresses shaped how their addictions developed and how deeply they hit them. What began as self-medication grew into diversion and ultimately jeopardized patient and staff's safety. That experience taught me something that I've never forgotten. Accountability and risk management begins with self-awareness and self-care. When we overlook our own needs or the needs of our colleagues, we miss the early warning signs that can prevent the harm, right? As we talk today about the age-related trends in the addictive behavioral disorder and substance use disorder, I want us to remember this it's important to care safely for others. We must first take care of ourselves and each other. I'm sure you will all agree.
We lost the sound.
Maybe the video is paused.
Yeah. With me, isn't it? As we transition from that story, I want to highlight a core truth. Drug diversion and substance use disorders often overlap, not only in the patients we care for, but also among healthcare providers. Diversion can play multiple roles in the progression of addiction. It can be a cause when access to medications becomes a starting point of misuse, a symptom when someone with a developing substance use disorder begins diverting to sustain dependence,
or it could be a result when addiction has advanced to the point where work performance, judgment, and integrity are compromised. We also have to recognize that addictive behavioral disorder patterns, the addictive ABD, shapes how people misuse medications and how professional impairment unfolds. These patterns differs across life stages, which is why age-related understanding is so important to our work on this topic. By looking at diversion and substance use disorder together, we build a more complete picture of addiction management, one that spans every group we touch, whether it's patients, providers, or the healthcare systems in which we all operate. And ultimately, addressing diversion is part of a much larger mission, reducing substance misuse, improving safety, and supporting recovery across all ages and all roles within healthcare. On this slide, we are focusing on a major ABD-SUD trend we continue to see across globally, similar to the unauthorized redirection or misuse of legitimately prescribed medications. What we are talking about here is not just patient misuse, but the diversion that happens by the staff, which has been rising nationwide as the substance use disorder prevalence among healthcare workers increases. High stress roles, easy access to controlled substances, and burnout are few of the significant contributing factors. So, staff pilfering opioids for self-use. This could be something like healthcare staff may take like small amount of opioids or other controlled drugs for personal use. This often starts subtly, but it strongly links to untreated substance use disorders. Substituting or falsifying narcotic records, altering medication administration records, forging waste signatures, or substituting medications are clear diversion behaviors that compromises patient care. Over ordering or under dispensing drugs, similar to inventory manipulation, ordering more than necessary or dispensing less than prescribed is yet another common diversion tactic. Easy access to medications facilitates these behaviors and has been increasingly noted among all age-related healthcare providers, especially the younger ones. Overall, diversion is a growing problem fueled by access, stress, and untreated substance use issues. Now that we have discussed what unauthorized redirection looks like, this slide highlights why it matters, right? Unauthorized medication diversion has far-reaching consequences beyond the individual misusing the drugs. Let's take a look at few of those. Compromising patient safety and public trust. Patients may receive incorrect doses or substituted medications, leading to serious health risks. Trust in healthcare erodes when diversion occurs, isn't it? It puts the healthcare professionals at legal and ethical risk. Staff involved in diversion could face criminal charges, loss of licensure, or termination. Even those who fail to report suspicious activity may face ethical scrutiny. Contributes to the global addiction crisis. Every diverted dose increases the availability of controlled substances, feeding the substance use disorder epidemic. Younger adults and healthcare providers are particularly affected because easy access and occupational stress increases the likelihood of misuse, perpetuating a cycle of addiction. Isn't that right? Now, different age groups experience unique risks when it comes to addiction and diversion. Hence, tailored strategies are essential to address all age groups, isn't it? Let's see the older adults. The older adults are more likely to experience the chronic pain and polypharmacy, increasing the risk of misuse, sometimes unintentionally. While we have they're also vulnerable to an inadvertent diversion, such as medications being lost, shared, or stolen, isn't it? When we look at the younger adults and healthcare providers, high stress, burnout, the pressures of clinical work creates more vulnerability. When combined with easy access to controlled medication, this can actually trigger misuse or experimentation, contributing to the rising addictive behavioral disorder or substance use disorder trends in this generation. Diversion may begin subtly but can escalate, highlighting the need for monitoring, support, and early intervention. Now let's take a look at the intergenerational systems. How are we going to address that? The policies should be in place to protect older patients and also provide support for younger staff at risk for substance use disorders. Accountability across age groups ensures safe, ethical medication use and reduces diversion at every level of care. Accountability connects patient safety with professional integrity, isn't it? So, leading with accountability, the foundation for trust. It begins with each individual, that is us, taking responsibility for our actions and accurate medication administration, proper documentation, and ethical decision making. But remember, accountability also depends on the organizational environment, a culture of safety that ensures that staff feels empowered to report errors, near misses, or concerns without fear of punishment. How many of the organizations does have this, or are you practicing it? Take a look at that for yourself or for your organization. A just culture. What's a just culture? A just culture complements this by balancing accountability and learning staff are held responsible for deliberate unsafe actions, but honest mistakes becomes opportunities for improvement rather than blame. Nurse leaders must play a key role by modeling the ethical decision making, promoting transparent reporting and documentation, fostering a just culture within a broader culture of safety. When accountability, just culture, and a culture of safety work together, they transform risk into resilience, protecting patients, supporting staff, and maintaining professional integrity. I'm sure you will all agree with me on this one, isn't it? Engage, educate, and empower. A framework for action. This is something that I created for ensuring that we lay focused on this task. First, let's focus on engagement. It's crucial to build an open dialogue around addiction, diversion, and overall well being, right? Encouraging our team members to speak up when they notice concerns without fear or stigma or reprisal. A culture of trust allows early intervention and support. Remember, engagement isn't just about reporting, it's about fostering empathy, it's fostering understanding and proactive communication within the team. Now let's focus on educate. Like education is the key, isn't it? Awareness. It's all about awareness. Nurses must be trained on safe handling of controlled substances and how to identify risks for diversion or misuse. Substance use awareness shouldn't be a one-time topic. It needs to be integrated into nursing curriculums and ongoing continuing education across the globe. This ensures knowledge is current and actionable. Education empowers nurses to recognize the signs of impairment early enough and act appropriately, protecting both patients and themselves. How are we going to empower our nurses? Finally, as we aim to empower nurse leaders, equip them to implement accountability systems in every clinical setting. Supporting recovery and rehabilitation pathways for impaired professionals is equally important. A system that combines accountability with compassionate support strengthens the workforce and patient safety. Empowerment is about giving leaders the tools, the authority, the confidence to act decisively and supportively, right? How many of us do get that at our work environment? If not, we need to start working on those and provide our leaders with support as much as we can to role model and address this concern in their local environments. Through this engage, educate, empower framework, we directly address the core of our conference theme, integrating age-related trends in the workforce, managing addictive behaviors effectively, and reinforcing leadership accountability. Each element of this framework ensures that nurses are supported, educated, and empowered to maintain safe practice and a healthy workplace culture. Let's take a look at the global perspectives in risk management. So around the world, transparency and accountability are key to preventing diversion and managing addiction risk, right? Let's take a look at few of the areas. So I was researching for this presentation. I noticed that there are a few guidelines that I looked at from the UK. The NICE guidelines in the UK emphasizes appointing dedicated accountable officers and establishing auditing systems. The American guidelines highlight organizational oversight structures to detect and respond to diversion. The Joint Commission Quick Safety Alerts underscores the importance of a culture where staff see something and say something. The global models, right? Let's take a look at the global models and leadership. The UK's, the United Kingdom's legal regulatory framework demonstrates how national regulation, having an accountable officer model, ensures system level accountability. The Indian accreditation standards shows how hospital governance around medication management can align with safety and accountability goals. The NIMHANS guidelines reflects India's specific approaches to preventing prescription misuse and integrating addiction risk into medication governance. So global approaches may differ in structure, but strong leadership and a culture of accountability are the universal pillars in protecting both patients and our healthcare teams. Please enter the programs that you may use or in effect locally at your workplace into the chat so others can actually follow and learn through that. Let's moving on to the best practices. We need to know some practical strategies for our nurse leaders. So emphasizing best practices such as two-person verification when accessing or wasting and administering is very important. Using electronic tracking and inventory audits is the latest advanced technology and innovations that few of the organizations utilize. I do personally utilize at work, and I'm sure there are many other organizations across the globe that has been using this, but this is something educational informational for organizations that don't use, or even if you are a small center from rural areas. I understand that electronic tracking system might not be available, but practicing the manual system and holding people accountable will help you. The electronic tracking systems like automated dispensing cabinets and audit software provides objective time-stamped data. Regular audits help identify patterns early enough, such as delayed documentation, frequent overrides, or unusual waste patterns. As leaders, staying engaged with these systems shows your team that oversight is consistent and transparent. Well, nothing happens without education and training, isn't it? So simulation and case studies on diversion risk and patient safety are key. Simulations and real-world case studies help nurses practice recognizing warning signs and responding appropriately. These experiences will make policies meaningful, linking procedures to patient safety and team well-being. They also create safe spaces for discussing difficult and ethically complex situations. Continuous learning on ethical decision making is also very important. Ethical dilemmas arise frequently in controlled substance management, such as balancing compassion for an impaired colleague with duty to protect patients. Ongoing education in ethics helps staff build confidence in making sound decisions and reporting concerns. As leaders, modeling ethical clarity sets a tone for the entire team. By combining strong medication safety protocols with consistent education and ethical guidance, the nurse leaders can create environments where safety, integrity, and accountability thrives. In addition to the strategies that we looked so far, the next step is also very crucially important as we look at some reporting and support, right? First, we need some non-punitive reporting systems. Staff must feel safe to come speak up about concerns without any fear or blame. If we are not approachable, how are they going to come to us? And we must provide wellness programs and confidential support system so the at-risk staff can seek help in an early phase. This reinforces that safety and well-being go hand in hand. For example, we have like a compliant number calling number where they can call and leave a message. They can leave it anonymously or they can leave with their phone number or name. This way we can connect back with them, talk to them. But absolutely, that is so supportive because there is anonymity in this calling system where we are able to still get some help for our peers and colleagues. So the culture of accountability, right? Embedding ethics into everyday practice through huddles, debriefs, consistent modeling helps normalize integrity and transparency. Finally, recognizing and rewarding compliance and proactive leadership encourages staff to uphold high standards and reinforces the behaviors we want to see. When reporting, support, and ethics come together, we build a culture where safety, accountability, and compassion becomes the norm in your practice. Well, it's important to remember that behind every diversion or misuse incident, there are human factors. And what are those? It could be stress, burnout, fear, or simply the lack of awareness. When we shift from blame to learning, we create space for real long-term professional growth. Compassion paired with accountability is what makes patient safety sustainable. It supports the individual while protecting the system. And ultimately, nurses remain the first line of defense, isn't it? Recognizing risk early and preventing harm at both the patient and system level. Remember, we are always there at the bedside. We are always there among our peers. We are seeing everything. So when we see something, we have to see this something. This is our call to action, right? A global call to action. And this is such an important slide that I want all of you to stay focused. This applies across teams, institutions, and countries. First, engage. Create an open dialogue about addiction, diversion, and well-being. Let's educate together, strengthening knowledge on diversion, risk, ethical medication management, and early recognition. Let's empower, giving nurses and leaders the tools and authority to build a strong accountability system in every setting. This is a shared responsibility, protecting patients, supporting staff, and safeguarding the integrity of healthcare worldwide. Because when leadership and accountability comes together, we see safe care, reduced diversion, and ethical practice across the globe. But first, remember that the drug diversion and substance use are interconnected risks. They affect both patients and providers and require system level attention. Let's focus on our key takeaways, right? What are the most important things that we are looking at over here? Age-related trends shapes vulnerability differently across populations and staff. So our strategies must be tailored and it cannot be a one-size-fits-all. Third, we got to remember the nurse leaders play a central role, modeling accountability, implementing strong safety systems, and fostering an ethical culture. And finally, the core message of this presentation today is engage, educate, and empower a framework for meaningful and sustainable global impact. So when we engage with courage, educate with compassion, and empower with integrity, we strengthen accountability at every level. By addressing addictive behavior disorders and substance use disorders through informed, age-aware, and ethical leadership, we advance the very heart of this conference theme. Together, we can build healthcare systems that are safe, ethical, accountable, and truly addiction aware. I hope this was meaningful and purposeful for everyone, those who attended this session today. And so when we engage with courage, educate with compassion, if any questions, please don't hesitate to connect with me. I can place my email ID in the chat. You're welcome to connect with me personally, and then we can have a conversation. If you need help to set up a system or a team to identify or address drug diversion, I'll be happy to support you all as well. So please, these are my references that I connected this PowerPoint.
Thank you, everyone. Thank you so much for the time provided. I hope I wanted to share that this topic is actually close to my heart as I actually worked with my system to instill this team, the drug diversion team at work in the United States. And it was really sad to see our peers and colleagues who are going through this painful moments, and we really were trying to connect with them and provide them the opportunity to, you know, get back onto their in the field of nursing. So it is it's very sensitive topic that nobody wants to actually talk about it. So while we gather here together to discuss about these age-related trends, I thought it was very important for me to highlight this complementary concern, which we are talking about, this addictive behavioral disorder and substance use disorder amongst our own peers and colleagues. And it's important that we as nurses on the front lines of patient care, as we are trained to identify and manage these disorders, we must also ensure that our own teams are informed and aware and prepared to handle those risks, right, associated with these opioids. So I'm glad I got this opportunity and to share my insights on drug diversion and risk management, not just as a patient safety issue, but also as a way to empower our nurses to be self-aware and recognize the early warning signs and take some preventive action as you take away from this session. So thank you so much. I'll give back the time to you.
Thank you, madam, for your elaborative presentations. In this short span of time, we have covered a very vast topic. Where, in fact, it is a newer topic for all of us because in a medical institution like us, we are also running the drug dependence treatment center and under the Department of Addiction Medicine. But in a day-to-day life, we always discuss about how we are managing patients, how we will give medications, whether these medications are optimum for the patients or not, whether they have shown any side effect or not. So we are only concerned about this type of these issues, but we have never thought what of the this diversion concept of this diversion. Definitely, because it may be an important concept which we have to be in mind, keep in mind, because then we will know whether the patient is the non-response of patients is due to the drug its own the potency of the drug, or it's the drug is diverted to some other thing or not. Yes, definitely. So in the connection, just madam has already highlighted important aspects of this topic. And among that, I would like to highlight a few salient points from the presentation of the madam. So from the aspect of the nurses, so it is very important that they are actually the vigilant administrator. So mainly in our general practice, we see that there are 5 rights, like right patient, right drug, right dose, right route, right time. So these are the basic principles which these our nurses have to be keep in mind, because they are the first one who actually administer the drugs to the patients. They keep records of the all documentations, whatever the doses to be given to the patients, what are the the medications are in the store. They actually the custodian of the all the medications, and they are the witness of this diversion mainly. So they have to know their role. Next thing is that another important point, if our nurses sees any discrepancy in this in the drug chain or and the drug diversion, if they see, then they have to report it immediately. And they are the main advocate for the patients. Like if what we see, if sometimes in Department of Addiction Medicine, in our case also, if a patient is not responding to any drug, we sometimes feel that most probably patient is not taking the drug, or most probably he is telling some lie to get more drugs. But we never think about the drug drivers, and our it may be our fault also. So we need to audit it regularly. So those the things we have learned from your presentation. Just I am mentioning that and one critical aspect I need to mention. If our some of our colleagues is caught in drug diversion, we should not play the blame game. That we have learned from your presentation. We have to support him. And we have to know the reason, and so that and we have to educate him, and we have to support him both mentally or so that this type of incidents does not repeat again. So thank you, madam. So I would like to request our audience, if any questions, please address to the madam. Thank you.
Thank you, Dr. Hemanta, for your remarks. Thank you, Dr. Uma, for a wonderful session. Your session really threw light on a very sensitive but very relevant topic of drug diversion and misuse, and the role of nurse leaders. And I really like the concept of just culture and the anonymous medication error reporting system. I think we are still in the infancy stage in India. And you are saying electronic and drug monitoring and auditing and all. I think now also in India we are following a double check, double locked narcotic safety mechanism itself. So your concept of that strategies, the nurse leaders strategies like engage, educate, empower nurses, that is very crucial in preventing drug diversion. So you also highlighted how nurse leaders ensure the patient safety. So very nice presentation, ma'am. It was very nice to listen to you. I'm not able to see any queries as such, but all congratulation message that it was really wonderful to listen to your talk, ma'am.
Thank you so much to both of you. And absolutely, please email me. I've posted my email ID in the group chat. So if anyone would like to set up a process or have some suggestions or guidance to start a team or initiate something, I'll be very happy to get that, provide that support to you and my time to you. And it's an honor and privilege to be here today. Thank you so much. Have a wonderful session, rest of the sessions.
Thank you.
Thank you so much. Over to the organizers.
Thank you so much, all of you. We'll move on to the next keynote address. So here we have the second keynote address. 2, that's on managing the non-stimulant private practice in light of the amphetamine crisis in USA and the experience of nurse manager in National De-Addiction Center, AIIMS, New Delhi. For that, we have with us our chair, Dr. Arunjyoti Barua. Ma'am is a professor and head of the Department of Psychiatric Nursing, LGB Regional Institute of Mental Health, Tejpur, Assam. She has completed a BSc Nursing from Guwahati University in the year 1991 and MSc in Psychology, MSc in Psychiatric Nursing from Nimhans, Bangalore, MPhil in Nursing from Manipal Academy of Higher Education, and PhD in Psychiatric Nursing from Indian Nursing Council. She has got 32 years of professional experience in the field of mental health nursing, and her achievements includes National Floral Nightingale Award 2009 she has received from the President of India, and moreover she also has Life Fellowship Award of Indian Society of Psychiatric Nurses. It was awarded on 15th of February. Welcome, ma'am. We have our co-chair, Dr. Pooja Shakya. She is the assistant professor, psychiatric from IHBS New Delhi, and she has received Anil Malhotra Award for the best paper in substance use dependence national conference of IASP in the year 2023. And she has also received travel grants from International Society of Addiction Medicine in the year 2024 and Royal College of Psychiatrists in the year 2025. And her research area includes de-addiction psychiatry and digital psychiatry. So we have got our speakers over here. So over to the chair to lead the session. Ma'am, please.
Just to announce that Dr. Pooja is unable to join.
Okay. Dr. Barua, over to you, ma'am.
Hello. Yeah. Good evening.
You're audible, ma'am.
Okay. Good evening. And I'd like to welcome for this session our speaker, Dr. Jackie Michael, and also the second speaker, Miss Belsi Bibi. Really to say, I'm very excited to read the credential of Dr. Jackie Michael. Actually, when I was going through, really, it is very thrilling, the kind of work that she has put in. So, Dr. Jackie Michael, she is a registered nurse and PhD holder, working in University of Texas at Taylor. And very thrilling part that I have seen that, she claims her transformation in career from the basic nursing role as a clinician, as an educator, or and she has been engaged for last 39 years in preparing, mentoring nurses at different capacity. So she has prepared around 2,400 number of nurse as a women health nurse practitioner. Also on a good number of nurses, not good, a very big number of nurses, psychiatric mental health nurse practitioner. And Also very interesting and very inspiring part is that she is endorsing it stipend. It is $6,000, more than $6,000 per year for the nursing to achieve their career or to make their career in University of Texas at Arlington. So apart from this, she has a credential. She has served as president of many national and international organizations, including NAINA, and most importantly, the Sigma Theta Tau Delta Theta. So, with such a great credential we are having, I'm very happy to welcome you for this session, and would like to hear from you what's happening and how do you take us to your journey. So I welcome you, Dr. Jackie Michael.
We will do Bilsi baby first because Jackie has not yet joined. Can we start with Bilsi? Please show her CV.
Okay, sure. Yes, it has come, I think. Yes. Yeah, it's my pleasure also to welcome Dr. Belsi Bibi. She is a senior nursing officer, nurse manager at AIMS New Delhi. Affiliation has been placed as BSc Nursing from College of Nursing, AIMS in New Delhi, with an experience of 22 years in patient care, patient education, and administrative responsibilities at various capacities like for student supervision, research activity, and in community outreach centers at AIMS in New Delhi. So Ms. Betsy is a certified master trainer in nursing management of patient with substance use disorder, trainer for various training programs conducted for nursing, and also speaker at the various national and other level of workshops and CNEs, etc. So here, let us take the journey of Ms. Belsi with us. Yes, the floor is yours, Mrs. Belsi Bibi.
Soumya, you want me to? I'll do.
See, ma'am, is she there?
Yes, as she is there, please make her as a co-host. Bilsi Baby.
Okay.
Jackie said she's joining.
Okay, so shall we go with Dr.
No,
Jackie?
let Bilsi start. Doesn't matter. Let Bilsi start. No problem.
Okay, yeah, please, Dr. Belsi.
Ma'am, she has already joined, ma'am. Yeah, ma'am, you can unmute and speak, ma'am. Dr. Bilsi, ma'am, you can unmute. Yeah, you're audible.
Hello. Thank you, ma'am. Good evening, ma'am.
Slideshow. Okay. Is it visible? The slides, Mrs. Bilsey?
Yes, yes, visible.
Okay. You can begin.
If you are able
yes.
to play, actually I have some Wi-Fi problem here.
Now you're audible, ma'am.
If you're able to present that, I think that will be much better.
Recorded one, ma'am.
We are presenting it. You just have to talk. Okay, you tell us when to move the slide and we will.
Just say next slide and they will change the slide, okay? Hello?
Ma'am, this is the recorded one.
Okay.
Bilsey ma'am is asking
Okay,
to play the recorded one.
Okay,
Okay,
do you have the
here.
recorded one?
Then ma'am, you can play it, ma'am.
No,
Sorry?
nothing is coming in terms of recording.
Dr. Anju, do you have it? Dr.
This is
Anju?
what's there on the screen.
Just a minute.
Dr. Anju?
It is a PPT. I can see a voice thing there, but there's no play.
Doesn't matter, you can play the PPT. We'll see, you can speak now, look at it, okay?
Can I share my PPT, ma'am?
Of course you can share.
Okay.
It's visible, ma'am.
To National Drug Dependence Treatment Center, AIMS, Ghaziabad. National Drug Dependence Center was established in 2003. It's a national center for treatment, research, and training in substance use disorders. It provides outpatient department, inpatient department, community-based care, daycare, and rehabilitation services. Multidisciplinary model in psychiatry, nursing, psychology, and social work is there. And the nurse manager is the key coordinator ensuring continuity of care across all departments. Who is a nursing manager? Senior nursing professional managing nursing teams, resources, and patient care workflow. Ensures safe, evidence-based, age-appropriate addiction care. Link between
I think there is no sound attached to this slide.
Ma'am, your video, yes. Your video has stopped playing, ma'am.
Who is a nurse manager? Is senior
Yes.
nursing professional managing nursing teams, resources, and patient care workflow. We must ensure safe, evidence-based, age-appropriate addiction care. And link between hospital administration and frontline nursing staff is very essential.
Next slide, please.
Who is a nursing manager? Senior nursing professional managing nursing teams, resources, four roles of nurse manager.
Ma'am, volume is low, ma'am.
First is the clinical.
Bilsi, can you say, because the audio we cannot hear.
Staff
Okay,
It's too low. Yeah.
it's very soft.
Weekend training is doing in
You're muted.
Bilsi ma'am, yeah, you can continue.
The core roles of nurse manager in NDDTC. First is the clinical leadership and administrative management, patient-centered care coordination, staff supervision and training. That is very important. If any new staff comes into our unit, it's our responsibility to give adequate training so that they are able to handle the patients. And ensuring safety of both patient and staff is very essential. And monitoring withdrawal management. As you all know that if the patient is having withdrawal symptoms, they will not stay in the ward or they will not stay in our unit. So it's our responsibility to assess the withdrawal symptoms and we should give the medications as per doctor's order. And family and community engagement is needed. Family counseling is there. And also we used to indulge family members also in the treatment regimen. Then policy implementation is there.
Center so that they are able to learn the therapeutic and age-related considerations in addiction management. Adolescents, vulnerability is there, peer pressure, and early intervention is needed. And in adults, dependence pattern is there, occupational stress also can see. And in elderly, polypharmacy, comorbidities like diabetes, hypertension, and psychiatric illness also can see. And in
Age-related considerations in addiction management. In adolescents, vulnerability is there. Again, peer pressure is more, so early intervention is needed. In adults, dependence patterns is there and occupational stress is also there. In elderly, polypharmacy, as an elderly patient, we all know that they are taking lot of medicines and comorbidities are there like diabetes, hypertension, and even psychiatric illness. Social isolation is also can be seen. A nurse manager ensures age-tailored interventions across all units.
social isolation is also there. And as a nurse manager, we ensure age-tailored interventions across nurse manager role in outpatient department. Our main responsibilities are triage and registration of patients with a substance use disorder, withdrawal assessment using alcohol withdrawal assessment scoring guidelines or clinical opioid withdrawal scales. And motivational intervening is equally important. Used to brief intervention is given to patients so that enhance the motivational level of the patient. And coordinate with the doctors for treatment initiation like buprenorphine, which is a partial agonist, and naltrexone, which is an antagonist. Managing counseling and follow-up counters. Record keeping and reporting is equally important. And our main challenges in OPD are high patient load. In our OPD, around 350 to 600 old cases and 25 to 45 new cases are reported per day. So you can imagine the workload. And stigma and patient resistance is there. Age-specific counseling is needed as different age groups are coming. Managing aggression or intoxicated clients is really a challenge. Nurse manager role in inpatient department. It's a 50-bedded hospital, including 2 isolation rooms. Our main responsibilities are overseeing detoxification protocols, monitoring vitals and withdrawal symptoms periodically, and preventing substance-related complications like seizures, delirium tremors, etc., ensuring medication safety, and supervising 24/7 nursing shift, coordinating multidisciplinary rounds, narcotic accountability to prevent drug diversion, thorough checking in each shift is needed, and double logging system is there, proper documentation is needed. In our center, we have controlled book in which nursing officers used to enter the details of patient and drug, like name of the patient, age, sex, UHID, date, and time, and the amount, the quantity we consumed for that particular patient, and the remaining quantity and signature of nursing on-duty nursing staff. A nursing manager should cross-check it with the treatment book and instruction book to avoid the misuse. And main challenges are the risk of absconding, self-harm, or aggression, and managing mixed age patients with varied needs. As I already told you that different age patients are coming, and staffing shortage at peak times. Without adequate staff, we cannot run the unit smoothly. Then relapse, craving, and behavior management. The urge for tobacco product, it is too high among our patients. They take short leave from the ward and they go outside and try to bring the tobacco substances like BD, tobacco, cigarettes, etc. Or they insist their attendant to bring the same. Fortunately, we have very good supportive staff, and without a frisking, no one is allowed to enter in the ward. Needs manager role in community clinic. We have 4 communities clinics in Delhi. They are in Sundarnagari, Trilopuri, Kodla, and Pardabad. Pardabad, which is in old Delhi, is recently started only for female patients. We have one mobile service also, which started in 2019, and which starts from Sundarnagari and covers Simapuri and Gogulpuri areas in Delhi. And our main responsibilities are supervision of outreach nurses, community-based opioid substitution therapy delivery, follow-up of relapse cases. If the patient absent for 3 or more days, then they have to do follow-up in the nearest center. And admission facilities only available in ABD&SUD-CARE Ghaziabad. Health education in schools, workplace, and community is also our role. Liaison with NGOs, local leaders, and PRI members. The main challenges are poor community awareness, stigma and reluctance for treatment, dropout, reaching elderly or homebound clients, ensuring treatment adherence in remote areas. Nurse manager role in daycare center, mainly for outpatient who fulfill the criteria for daycare admission. It's a short admission, and patient used to come by 9 a.m. to 4 p.m. And we are providing meals like breakfast, lunch, and evening tea. And patients used to take their maintenance dose of medication from pharmacy, and then indulge in various activities like group therapy, occupational therapy, and skill building. Daily health checkup for patients is also doing. Ensuring safe environment for vulnerable age group is very important. And main challenges are diverse patient needs in limited time, behavioral issues during therapy, and motivational dropouts, drug-seeking behavior handling. Role in activity room or regulation room. We have a very good activity room where patients are allowed to go after medication and rounds. They are involved in various activities like yoga, meditation, group therapy, art therapy, music therapy, relapse prevention counseling, etc. And representatives of narcotic anonymous group and alcohol anonymous groups are visiting in our daycare on every Monday and sharing their experience with patients. Encouraging healthy coping skills is also our responsibility. And main challenges are maintaining discipline and safety, again managing emotional triggers, and engaging elderly and adolescent groups simultaneously. Coming to the administrative and leadership role, making rosters and manpower allocation is equally important. We need sufficient staff for the smooth running of the hospital.
Ma'am, there is a request from the audience to increase the volume.
Intent of adequate
It's sounding very low.
equipments and medical and surgical items.
Ma'am, if you can increase your volume.
It's mostly saying what is on the slide. So let's then probably it's network issues at that end. Okay.
Administrative and leadership roles. Am I audible, Mom?
Yes, you're very clear. Very clear.
Making duty rosters and manpower allocation is our duty. And inventory management is there. We are supposed to intend the medicines, emergency drugs, and emergency equipments, and all medical surgical items from the store, and we are supposed to supply for the ward. And also, it's our responsibility to see all the emergency equipments are in good working conditions. Then documentation and regulatory reporting is needed. Documentation of any abnormal behavior happened, any violent behavior, or any aggressive or anything happened in the ward, and it must be noted properly, and it should be reported properly. And quality assurance and NABH compliances, and conducting staff training on addiction care.
Communication and collaboration with psychiatrists, psychologists, and counselors are needed.
Coming to communication and collaboration, coordination with psychiatrists, psychologists, and counselors. And family counseling is very important. As I told you that we used to involve family members in the treatment regimen. And involvement of family members is needed. And interdisciplinary case conferences are doing, and conflict resolution among staff and patients. It's really a big challenge.
Only counseling is equally to be ethical and
Coming to the ethical and legal responsibilities, confidentiality of addiction treatment records, and it's our responsibility to maintain the confidentiality. Informed consent for procedures and patients' rights advocacy, and reporting of any abuse, violence, or any emergency situation.
key challenges.
And key challenges for nurse managers in NDDTC. First is the stigma and discrimination barriers, unpredictable patient behavior, as we all know that different types of patients are admitting, like less motivated patients, aggressive patients, violent patients may be there, patient with comorbid personality may be there, dissocial personality patient may be there, and manipulative patients are very common. So these they can burst out at any time. And lapse and relapses are very common, so frustration is there. And maintaining safety in all age groups. As I already told you that in our setup, all age groups are coming. So in our hospital, we have 2 isolation rooms, and we used to admit adolescents and female patients in that isolation room with attendance. And understaffing and burnout is another challenge. Sufficient staff members are very essential for the smooth running of the ward and ensuring continuity of care across outpatient department, inpatient department, and community.
For nurse managers in challenges experienced as nurse manager. Case scenario 1. Aggressive behavior when denied extra medication. A 32-year-old unmarried patient complains of opioid dependence syndrome. Admitted
You give me one. Ha 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 ha. You shrinky.
Case scenario 1. Aggressive behavior when denied extra medication. A 32-year-old unmarried patient complains of opioid dependence syndrome, admitted in ward, approached nurse on duty during night shift, claiming severe withdrawal symptoms and demanding for extra medication, which is buprenorphine. On assessment, using COE score, nurse identified that patient is receiving dose as per his severity of withdrawal. The nurse informed that you are getting medication in sufficient dose to minimize withdrawal. Will inform doctor on duty. The patient becomes agitated and locks the nurse duty room from outside, threatens the nurse, and nurse calls security and manage the situation. Nurse tried to de-escalate the patient and calm down him with the help of supportive staff. It's challenging to handle patients, especially with dissocial personality disorders. Nurses are given de-escalation training to manage aggressive behavior.
Nurse on duty. Challenges.
Case scenario 2. Handling patients with dissocial personality disorder. A 40-year-old complains of opioid dependent syndrome, dissocial personality disorder, admitted in the inpatient ward. During a routine search, staff discovered 2 packets of cigarette in his possession. When nurse questioned him about it, patient became defensive and aggressive, denying any wrongdoing. Later, as nurse was arriving for his evening shift, the patient physically attacked nurse by hitting his head with a stone while entering inside the hospital premises, was rescued by security guards. Nurse demanded for a change of posting from the center. Nurse manager counsels him and convinced him to continue his job at NDDTC.
Experienced as nurse manager.
Strategies to overcome the challenges. Regular staff training on de-escalation. As I already told you that our center is a tertiary center and regular training is doing in our center. So it's very important for every staff to get trained at least 3 months in 3 months. An age appropriate care protocol. Since different age groups are there, and age appropriate care must be given. Then strong community linkage is needed, and use of digital health records and reminders. Wellness programs for nursing staff, family-centered treatment model.
Challenges are impact of effective nurse management are better treatment adherence, reduced lapses and emergency admissions, improved patients and family satisfaction so that they are able to lead a normal life, safe and therapeutic environment, higher team efficiency and morale. Coming to the conclusion, nurse manager is the backbone of addiction treatment services. We plays a critical role across outpatient department, inpatient department, community and rehab areas. Age-specific strategies are crucial in managing addictive behaviors. And effective leadership helps in better outcomes in SUD management. My references are given below. Thank you. Sorry. Actually, because of the Wi-Fi, I have faced a lot of problem. Thank you, Mom.
Dr. Barua, ma'am.
Yes. Thank you, Madam Bilsi, for highlighting such good practices that's happening in AIMS in New Delhi, with clinical to community. You are inclusive for schools, adolescents, and other community, like, adolescent and children, all you are covering and making the practices. And we are very happy to see your leadership, role that you were utilizing for management of this de-addiction center. So I feel it was a very beautiful and very nice practical experiences that you have shared. Before going to Dr. Jackie Michael, I'd like to get any comment from my co-chair, Dr. Pooja. Handing over to Dr. Pooja.
No, Pooja is not there. Please manage it.
Okay. Okay. So thank you so much once again, Dr. Bilsi Bibi.
Thank you, Mom. Thank you.
And I hope, Madam, now Dr. Jackie.
Yeah, she's here.
So,
She's here.
yeah. Okay, Dr. Jackie, she's here.
Yeah.
Okay. So now I'd like to give the platform to Dr. Jackie Michael. Yeah, we are very happy to hear from you. We are just eager. Please carry on with your experiences and with your work. Yeah. I welcome Dr. Jackie Michael. Yeah.
Thank you so much for giving me this opportunity. I appreciate it. Good morning from cold Dallas, Texas today. Usually we are warm. Thank you, Dr. Baby, for that informative practice. And thank you to the leadership of this conference for giving me an opportunity to speak. I would like to start my presentation and leave ample room for Q&A actually is my heart's desire. So if I'm rushing through it, please ask me to stop if you want me to clarify anything. Otherwise, I'll open it up for Q&A. So my topic is managing a non-stimulant private practice in the light of amphetamine crisis, which is rampant in the US and the Western Hemisphere. I am a clinical professor for Texas Women's University, and I'm also the practice owner and the psych mental health provider for Access Behavioral Care. As we talk about the overview, I would like to talk about the rising amphetamine crisis during our presentation and the stimulant addiction that is being faced by pre-adolescent, adolescent age clients all the way up to their mid-30s. Also, the risk of prescribing the stimulant without consideration of misuse, the role of the non-stimulant practice in addressing this crisis and this dependence of amphetamines and methamphetamines, evidence-based behavioral and pharmacological options that are available in management of ADD as well as ADHD, and the integration of quality matrices and the leadership implications we face as advanced practice providers. The epidemiology and context is straightforward. I have put all the references in my last slide, so please use them at liberty. There is more than 10 million people of ages 12 plus that have misused stimulants, and this data is 2022, and the trajectory arrow just keeps going up. There are increase in the number of deaths involving methamphetamine and amphetamine use. The highest prevalence is amongst ages 18 and 34. There's also a co-use and codependence of opioid and fentanyl, which are lending themselves to the increase in mortality. Next slide, please. Thank you. The neurobiology, as many of you know, I've seen the credentials of the folks presenting and hopefully attending. The neurobiology of the dependence is based in the dopaminergic and the serotonin dysregulation. The reward pathways are then altered in their signaling, which impact the executive dysfunction. The thresholds decrease, the dependence increases, and there are also structural brain changes in the prefrontal cortex, which is primarily responsible for the executive functions. The chronic stimulant exposure reduces the impulse control, i.e. leading to dysregulation as well as dependence. Next slide, please. The non-stimulant clinical practice principles are based in a few practices. We have to prioritize non-stimulant pharmacotherapies. We have to integrate behavioral health interventions. Comprehensive screening and early detection requires a vigilant practitioner and is the key to managing this codependence. And then we have to have a multidisciplinary approach and address trauma-informed care. So as these pre-adolescents and young adolescents are entering our practices, we are looking and screening for trauma and other such insults that the brain has directly and indirectly experienced. Next slide, please. Thank you. Screening and risk management is a stratified approach. We use validated tools to do the assessment. We identify the risk factors, which are predominantly prior stimulant use, comorbid condition of ADHD, prior trauma experiences, comorbid conditions like depression and anxiety. The other diagnostics that we use are urine drug screens. Right now, I have a client on a contract where I'm doing random drug screens, and then the PMP checks. Thank you. Next slide, please. Non-stimulant farm management includes options for ADHD like atomoxetine, Strattera, bupropion, guanfacine, and a drug that has become my new favorite for the past 2.5, 3 years, which is Qelbree. Depression and anxiety could be managed with SSRIs, SNRI, and Buspar or Buspirone. Avoid stimulants when high risk of misuse is suspected. Tailor medication plans with behavioral intervention. My clinic is grounded in cognitive behavioral therapy principles, and I have pretty much all of these patients on an hourly visit so I can engage them in CBT. Next slide, please. Thank you. Behavioral interventions then is contingency management and contracts. Best evidence for stimulant use disorders is founded in the client and family and the positive support system coming alongside the client. Cognitive behavioral therapy, like I said, is the foundational basis in my practice. It is effective for relapse prevention because it keeps the client engaged and continuously informed on the risk of dependence. I do motivational interviewing, which enhances readiness for change, with trans-theoretical model for change being the theoretical foundation in my practice. And the continuous self-awareness that the client has to engage when we do MI. Community reinforcement approaches also can be used. I do have them engaged in a NA program. Next slide, please. Thank you so much for helping me with the slides. Integrated behavioral health models are based in co-locating primary care. That is, their pediatrician engages me, and we both manage the patient together. In psychiatry, which is my psych mental health practice, and in behavioral services, when the patient checks in, do they enter a IOP model of care or not? When their discharge planning is happening, what are the community resources and accountability partners we are sending this patient out with? Shared care plans and EHR integration are key. I share my notes with their PCPs and their pediatricians regularly because I believe in a team approach. Peer recovery and social support linkages, where they are encouraged to leave their old social circle of dependent friends and then enter a new model of friends, like relocate. The client that I was talking about has moved back from another town, San Antonio, in the Texas area, moved home, and has left behind the addictive circle of friends that would help him procure and feed the habit to a new social group where money's managed differently, etc. So all of these things go in together to help with the recovery support and measure the outcomes on a dashboard. We look at a number of days sober, and we look at last contact with their addictive or the social group that could lend itself to the risky behavior. Thank you. Next slide. Quality outcome matrices, goals in my EHR have been set. And I do an evaluation on a monthly basis, but I don't visit the dashboard on a month. I visit the dashboard on a monthly basis, but I don't visit the matrices, but every quarter for a patient. And they are linked into the EHR for that client. So his chart or her chart. I am striving for more than 80% patients screened for stimulant use. And if they are not, they do a completion of checklist of questionnaires that they complete before their appointment. If it is not done there, then during the appointment, I try to make up for this. More than 100% referrals made to CBT therapy. So all my patients are co-enrolled, not just in the farm management, but also in the therapeutic management section of the service. More than 80% engaged in CBT programs. That means compliance here. They're 100% are referred in, but more than 80% engagement is required. Also, more than 90% reduction in stimulant use days. This is one of my quality matrices within my EHR. More than 70% retention in care more than 60 months. So I also track and see which patient falls off 5 months and 28 days. And if they fall off, we have a follow-up decision tree and contact tree. Now, a patient may choose to go to a different provider, may check in to an inpatient service, may check in into an IOP program, and then do they come back to service is one of the matrices, or do they follow up with another provider, and that closes the chart out for us. More than 80% decrease in ER and hospitalization related to the substance use diagnosis. They may go to ER for upper respiratory and other medical conditions, but not for psych conditions. Thank you. Next slide, please. I hope these quality matrices help you with decisions in your practice as well. So the last slide was a powerful slide for me. Leadership implications for nurse practitioners or advanced practice nurses, which may be CNSs as well. and some CRNAs who are in pain management that are working with these addictive behavior patients. So the implications for us is lead a non-stimulant based care innovation. I have done that. It is not as profitable as seeing a patient every 15 minutes and generating an Adderall referral. That is a lot of money and continuous patients that come. But we have to be courageous and be committed to a non-stimulant based care, which is innovative in itself. So that is my name to fame here in Dallas with my practice. We have to embed resilience and trauma-informed care framework in our care because those two, trauma-informed care identifies previous trauma, which is a predictor for addictive behavior, and embedded resilience practices are predictors with mindfulness and increased resilience, not only with autoimmune fortification, but also the resilient mindset to overcome and stay victorious one day at a time over this addictive behavior. We also employ mentor interdisciplinary teams where we do groups and we plan successors of the program. So anybody who is 30 days, we do not do a coin like AA, but we do ask them to mentor in a group therapy session. 90-day walking sobers may co-lead, and 180 days walking sober may lead a peer group, which is very effective for that ages 18 to 24. We do data-driven outcomes, and like I said in my EHR, I do have matrices for quality improvement embedded. Next slide, please. Thank you. Future directions are related to CBT in tele. I do that via Zoom and we call it face-to-face sessions, but I try to limit them because there's something communicated in tone and expression that is very effective in CBT in in-person sessions. There are new pharmacotherapies that are being evaluated. When I started using Qelbree for my clients 3 years ago, the indication was for adolescents. Then additional data was collected and we got FDA approval for adults. We have now FDA approval for children. So I see patients 6 and older in my practice. And my oldest patient using Qelbree is a 62-year-old client. My youngest client is a 8-year-old client. So there's a few other things that need to be addressed, global level, national level, legislative level. We need policy shifts in supporting the reimbursement for some of these CM reimbursement, which the last legislation I'm hoping was fruitful, and we'll see the reimbursement then cascade down to the different insurance carriers who do the reimbursement of these telehealth sessions. Psych is protected with telehealth sessions at this time. Global nursing leadership should focus on stimulant use prevention and how we manage ADHD, focus, concentration, and attention disorders. Next slide, please. Summary and call to action. I would like to challenge my peers here and the leaders globally managing psychopharmacy, psychotherapies, and psych practices in general at all levels, whether you're APP, physicians, LCSWs, managing these disorders. Stimulant addiction is real, it is crisis, and it demands proactive APP or nurse practitioner leadership. I want to emphasize behavioral interventions along with safe pharmacology. Every prescription we write has an implication. Please consider the implication when you write the Adderall, the dose, the frequency. It has huge dependence implication. Integrate care and track measurable outcomes. I shared my matrices. It does take time. It makes me be really attentive, engaged, and intentional in my practice, but I do it because I truly believe in it. And then this will strengthen the workforce resilience. And then we do need to focus on training. I'm faculty and I do focus on this. I plant the seed. So my students coming out have a different focus as well. Next slide, please. As I share my references and open up for QA, if we could advance to the next slides, I am good here, and I'm open to questions. I hope I have completed this in the allotted time.
Yes. Yes, madam, you have completed the presentation on time, and it was really, really very much interesting and very insightful presentation. And you have rightly focused the neurobiological changes in young adults, like, how the stimulant use can lead to. And also, I found it very interesting to learn your assessment based on trauma informed, like, all this, the history and assessment and screening. Really, to speak, we do learn theoretically, yes, true, but practical implementation is really not happening to great extent here. That's what, like, I feel it's really an eye opener for all the scholars or all the new researcher, new nurse researcher who are attending this conference. I feel they can take a message from this your presentation, like, how CBT based nurse led clinics may make a difference, or integrated behavioral model, like, like these all can be a very good research topic for the nurses in India, like, new PhD scholars who are working right now at this area. I found also very helpful that your approaches to monitor the quality, like, quality metrics, how you have designed and implemented. So very, very, very interesting and very useful, I found it.
Thank you.
Also digital CBT. So though it is telemental health and telemanners and so many tele things are coming up also in India, but really at the research it is not picking up as so high. So I feel all these I think to the student or the learners who are here, even for us the faculties also, it's really eye opener. Thank you so much for this beautiful presentation. And if any questions, I think MC can guide us or help us to take up the question answer.
Thank you very much, Dr. Jackie.
My pleasure.
I'm so delighted to listen to you.
Thank you.
And you see, it is very challenging. What you are doing is very challenging, especially working with adolescent group is very challenging. And making them to go through CBT, because it takes time. CBT takes time to make them adhere to CBT regime and come regularly is another task with this age group.
Yes. Yes. It is definitely a commitment in the practice and the practice decision. Here in the US, you can do a 15-minute med management visit and write an Adderall prescription, and it pays you the same amount that a 1-hour session does for CBT. And then all the paperwork I have to do when I'm writing Qelbree to justify the prior authorizations, etc. That said, it definitely requires intentional engagement and a commitment to this practice. I must disclose that I only practice part-time because I'm faculty, and my practice, my colleagues like laugh and smile a lot. They will say that I am doing theoretical practice, but I would rather take home less money with less guilt than more money with more guilt. And so I am committed to the families. I see the parents' faces who are willing to engage. And these children are going down a slippery slope. And I have young executives, pilots, teachers, social workers, physicians who are coming to me who have been dependent on ADHD and now want to get off. So when there is a success story of 30 days clean, of 90 days clean, of 180 days clean, it is very rewarding. That is the crux of my practice. So it is definitely a choice. So thank you for those kind words.
And it's really tough call. It's a tough call. One thing is teenager, second thing is the problem is such, and third thing is CBT. I mean, it's really a tough combination. Hats off to you.
Yes.
Hats off to you.
Thank you. Thank you. And thank you so much for the opportunity to speak to my global colleagues because I think I shared it with Dr. Gupta that I was not trained in India. So it is so nice to hear all the parallel things that are happening in the other corridors. I'm happy to answer questions. If not, I can put myself mute and give you guys some time with
There's a question
technology
in the
and
chat box, ma'am.
oh yeah. क्या है question? मैं देख रही हूँ, but I can't see. Oh,
I'll
I
read that for you. When
please.
choosing the non-stimulant like atomoxetine,
Atomoxetine.
yes, does the genotype testing helps for proper medicine dosing? What's your recommendation on this?
Yes and no. So genotype testing is available in my practice, but it is a cost, and that is a consideration for the patient. Now, I do have a fluent practice. I am in the North Dallas area, and most parents are willing to pay the cost, but I do an empirical increase till effectiveness is reached, and only when I am too high doses left will I say, let's do this testing to see if this is the drug or not. So I'm already priming them that I might be moving. I also do another thing, atomoxetine and guaifenesin for behavior management. So the aggression, the grrr, the bear in the morning, the mom who's struggling with that kid to get ready, eat breakfast, grab the school things, and make it to the bus. Guaifenesin is helping with that. So I do compounded approach. But yes, short answer is yes, the genotype testing does help. It does tell me who is a slow metabolizer versus a faster metabolizer, which helps me also do with the dosing of the frequency. Because here the school nurses can give a second dose in school hours. Thank you for that question, Elizabeth.
I have
How
a
do you see
question.
safeguarding? Yeah, I see that one. How do you see
Yeah.
safeguarding issues that children face when they are with you? The behavior management should be managing aggression on peers too, right? Yes. So there are two or three things. ADHD is not the DMDD kid, is not the behavior dysregulation kid. ADHD kid really is the clown of the class. That's the kid who cannot sit still, who cannot focus, who cannot pay attention. So we work with the art team here. We get them 501 considerations and accommodations through the school team where the kid can sit in front of the teacher. There be a certain space between the other chairs and desk in the classroom that the teacher speak directly to the student. So there are a list of ARC accommodations that we get. So we are advocates for the children and family. And if the parents want me to accompany them to a ARC meeting with the ISD, with the Independent School District, then I am happy to go to that. These are all fee-based because time off from my office is money off from my practice. So my rates are high, but I have attended a couple of ARC hearings and secured accommodations for my clients. Here, ADHD is a diagnosis that is done in middle school. So I do screen and test, and I do get direct referrals from school counselors who will do these referrals. Other questions?
Thank you.
My pleasure.
Okay,
Please keep
thank
the
you so
questions
much.
coming. I have shared my email, and I'm happy to stay in communication.
Thank you so much. Then we'll wind up.
Thank you. I'll put myself on mute.
Thank you, Dr. Arun Jyoti, for taking on this responsibility. So now
Thank you,
we
ma'am.
have
It's my pleasure.
Jinsi available. Dr. Jinsi.
Yes, I
Dr.
am.
Jinsi available.
Yes.
The next speaker. I welcome you, Dr. Jinsi.
Thank you so much.
Soumya ma'am, you'll be able to share since
Dr. Arun Jyoti.
Yes, ma'am.
Dr.
I'll
Sumiti will do the
introduce.
chairing. I requested Dr. Sumiti. She will do the chairing. Thank you.
Okay, ma'am.
once
Hannah ma'am,
again.
over to you.
Yes,
Is my
Soumya ma'am,
slide
thank you.
visible?
Yes, thank you.
Yeah.
So now let's move on to the plenary session 2, and this is about taming the gaming disorder, an experience from the USA. This session will be chaired by Dr. Sumiti Arora. She's the former faculty in College of Nursing, DDU Hospital, GNCTD, New Delhi. She is an awardee of Research Ratna Award in Jan 2019 for Best Research in Community Mental Health Nursing. Her experiences include formerly an associate professor in Holy Family College of Nursing, New Delhi, an MSc Psychiatric Nursing from AIMS, Delhi, and she's also a PhD holder in child psychology. She's a coordinator and resource person for various national and state level workshops. She's a master trainer for nurses for substance use disorders, care of older adults, and diabetes care. She has authored several chapters in books and modules for the Ministry of Health and Family Welfare as well as IGNOU. She has published articles in national and international journals and presented papers in national and international conferences. Her area of interest is mental health nursing and addiction. And the co-chair for this session will be Dr. Kunchalata Gogoi. She is the assistant professor in psychiatric nursing at LGB Regional Institute of Mental Health, Tejpur, Assam. Her achievements include Best Paper Award in the 7th National Conference at WAPRIC, held in 17th and 18th March 2023. Her experiences include a year of clinical experience followed by a vast 24 years plus experience in teaching. Her areas of interest include care for family caregivers of mentally ill individuals and is currently working in the Department of Addiction Medicine at LGBRIMH. Over to you, ma'am. Sumiti, ma'am, over to you to
Thank you,
introduce
Ms.
the
Hannah.
speaker.
I welcome you all in plenary session 2 by Dr. Jinsi Anthony on taming the gaming disorder and sharing her experience from USA. I welcome Dr. Jinsi Anthony. She is Chief Nursing Officer, Chief Health Informatics Officer, Psychiatric and Forensic Nursing Leader right now. Her experience is Chief Nursing Officer from Hariram Davis Medical Center, DBHDS from Virginia. She's here in presently from July 2024. She has 25 years of experience across psychiatric care, forensic nursing, behavioral health, and clinical leadership. She is skilled in acute crisis intervention, trauma-informed care, and holistic treatment of patients with complex mental health needs. She has experience as Chief Health Informatics Officer, Director of Health Technology, Central State Hospital, DBHDS in Virginia from 2022 to 2024. Thank you. I welcome Dr. Jinsi Anthony.
Thank you so much. Thank you. I think my audio or my video is going to be played.
Yes. Dr. Jinsi, can we have some more light on your face? You're sitting against light.
Sorry, I will.
Soumya ma'am, can I share?
Yeah, please go ahead.
Yeah, we can share.
Hello everybody. Today I'll be presenting on gaming disorders, a condition that has gained significant recognition in recent years. It represents an important clinical
Yeah, it's
challenge.
audible. Can you just enlarge that to the full screen mode?
Anthony, and I bring experience as a psychiatric mental health nurse practitioner. I work in the United States as a chief nursing officer of a state facility. Gaming disorders affect millions globally, with particularly high rates among adolescents and young adults. This presentation will provide you with evidence-based insights into recognition, assessment, and treatment of this emerging disorder. We will examine both the ICD and the DSM frameworks, explore the neurobiology, and most importantly, discuss practical clinical interventions that work. Before we begin, I want to establish that this presentation synthesizes current evidence from latest international research with clinical experience from the United States healthcare system. The field of gaming disorders is evolving rapidly with new research emerging regularly, and I encourage you to reach out after this presentation if you have any questions or want to discuss specific cases. My contact information is displayed on the slide. Let us now dive into understanding what gaming disorders actually is and why it matters for clinical practice.
Hannah ma'am, can you just enlarge that? Your video is not running. Your voice is clearly audible, but the video is not running.
And we try because ma'am's picture is at the end, at the bottom. It's just a circle. The slides are what are on the video.
Actually, your folders were visible.
Oh, is it? Sorry then.
Yeah, in the downloads and everything it was visible.
Let me just share it again.
Yeah, please.
Distinguishes disorder from enthusiasm is functional impairment. The behavior must cause significant impairment in personal, family, social, educational, occupational, or other important areas of function. The pattern should normally be evident for at least 12 months, although the duration can be shortened if symptoms are severe and all diagnostic requirements are met. It's crucial to emphasize that not all heavy gaming is pathological. Many extensively without meeting the disorder's criteria. The pivot point is always functional impairment and loss of control. Now let's clarify the distinction between two major diagnostic frameworks. The ICD-11 from WHO, it uses the term gaming disorder and requires that the pattern of impaired control, prioritization of gaming, and continuation despite harm to be evident for at least 12 months, unless symptoms are particularly severe. This definition applies to both online and offline gaming. The DSM-5 from American Psychiatric Association lists internet gaming disorder in Section 3 as a condition that requires further study. The DSM-5 approach provides 9 specific criteria, including preoccupation, withdrawal symptoms, tolerance, unsuccessful attempts to control, loss of interest in other activities, continued use despite awareness of problems, deception about gaming, and the use to escape a negative mood, jeopardizing relationship or opportunities. A diagnosis requires meeting 5 or more of these 9 criteria within a 12-month period. The key philosophical difference is that ICD-11 takes a more clinical, holistic approach focused on pattern and impairment, while DSM-5 provides more specific, countable criteria. Both emphasize that functional impairment is an essential feature that differentiates a disorder from passionate hobby. In clinical practice, I find it useful to be familiar with both frameworks as they inform our assessment process. Let's examine the DSM-5 approach in more detail. Remember, internet gaming disorder is currently listed as a condition for further study, not yet a formal diagnosis in DSM-5. This reflects the evolving evidence base and some ongoing debate in the field about diagnostic criteria. The DSM framework requires that at least 5 of 9 criteria be met within a 12-month period, along with significant distress or impairment in functioning. These 9 criteria map onto features we see in substance use disorders, that is, preoccupation with gaming, withdrawal symptoms when gaming is taken away, tolerance requiring increasing amount of gaming time, unsuccessful attempts to control the participation, loss of interest in previous hobbies, continued excessive use despite knowledge of psychosocial problems, deceiving others about gaming, using gaming to escape negative moods, and having jeopardized relationships or opportunities because of gaming. Studies validating these criteria have found that certain symptoms, particularly giving up other activities, negative consequences, and continuing despite problems, are the most significant diagnostic contributors. This helps us understand which features most strongly indicate disorder versus recreational gaming. The DSM approach has shown good reliability and clinical utility in research studies with diagnostic consistency slightly higher than ICD-11 in some field tests, possibly because clinicians have more experience with specific criteria formats. Now, understanding prevalence helps us grasp the scope of this problem. Global estimates suggest that approximately 2 to 3 of the general population meets criteria for gaming disorders, though this varies considerably across studies due to differences in measurement tools, diagnostic criteria used, and population sampled. However, these numbers tell us only part of the story. Among adolescents, specifically, meta-analysis pooling data from over 640,000 individuals across multiple countries reveal a prevalence of approximately 8.6%, with some studies reporting rates as high as 10 to 11%. This is significantly higher than adult population, highlighting that adolescence represents a particularly vulnerable developmental period. This gender disparity is striking. Gaming disorder is approximately 2.5 to 3 times more common among males than females. Among adolescent boys specifically, prevalence rate can reach 6.8% to 15.3% compared to a lesser rate in between 1 to 3.5% in adolescent girls. Geographical variations also exist, with Asian countries, particularly China, reporting higher rates compared to Western nations. This may reflect cultural factors, gaming infrastructure, and possibly measurement differences. The key clinical message is that while gaming disorder affects a minority of gamers, it represents a substantial public health concern, particularly for adolescent males. Using validated. Now, age is one of the most important critical order affects a minor. disorders. Social factors also maintain the disorder. Massively multiplayer.
The sound is not there.
Keep play.
Yes, sound is not there.
Fear of missing events or failing behind peers creates powerful pressure to continue. Neurobiologically, gaming activates the brain reward system intensely. Research demonstrates increased cue reactivity. Individuals with gaming disorders show enhanced brain activation when exposed to gaming-related stimuli, similar to substance addiction. The emotional regulation pathway is particularly important. A systematic review by several researchers found that difficulties with emotional regulation strongly predicts problematic gaming. Game design elements deliberately leverage these mechanisms. Variable reward schedules, progression systems, social features, and time-limited events all activate reward and compulsion pathways. Understanding these mechanisms help us target interventions more effectively. Neurobiologically, gaming activates the brain's reward system. Research demonstrates increased cue reactivity in people with gaming disorders. The emotional regulation pathway is particularly important. Research has shown that difficulties with emotion regulation strongly predicts problematic gaming. Individuals who lack adaptive emotion regulation skills are more likely to use gaming as their primary coping mechanism, which perpetuates the cycle. The relationship between gaming disorders and other mental health conditions is bidirectional and clinically crucial. ADHD symptoms show the strongest association with gaming disorders. Depression and anxiety are also extremely common comorbidities present in approximately 89 to 92% of the cases. The relationship here is truly bidirectional. Gaming can temporarily relieve depressive and anxiety symptoms through distraction and mood enhancement, leading to negative reinforcement. Academic and social difficulties are both risk factors and consequences. Social anxiety predicts a gaming disorder development, as socially anxious individuals may prefer online interactions in contrast to face-to-face interactions. Other common comorbidities include conduct disorder, oppositional defiant disorder, aggression in a younger population. In clinical practice, it is essential to assess and treat these comorbidities concurrently as they interact with and maintain the gaming behavior. Effective clinical management begins with accurate assessment. In clinical practice, I recommend a two-stage approach. 1. Initial screening, followed by a comprehensive clinical evaluation for those who screen positive. Now, for screening, 2 validated instruments align with current diagnostic frameworks. The Internet Gaming Disorder Scale, short form, it's a 9-item measure based on DSM-5 criteria. Each item corresponds to 1 DSM criterion and is rated on a 5-point Likert scale. It takes approximately 2 to 3 minutes to complete, making it highly practical for busy clinical setting. The Gaming Disorder Test, or GDT, it is a 4-item measure aligned with ICD-11 criteria. Despite its brevity, it performs remarkably well in validation studies with psychometric properties compared to longer measures. The GDT assesses the core ICD-11 features, that is impaired control, priority given to gaming, continuation despite harm, and resulting impairment. Both measures show excellent sensitivity and specificity for identifying gaming disorders. Implementing gaming disorder assessment in different settings requires adaptation to context. In clinical setting, whether primary care, mental health clinics, or specialized addiction services, integrating gaming assessments into standardized intake procedures, especially for adolescents and young adults, helps early identification. Include questions about gaming in social history. For positive screens, schedule extended evaluation appointments. In school settings, gaming disorder assessment can be incorporated into the broader behavioral health screening programs. When assessing adolescents, always gather gather information from multiple informants. Research shows significant discrepancies between parent and adolescent reports of gaming problems. At baseline, parents typically judge gaming problems as severe when adolescents minimize them. Both perspectives are valuable. Parents observe functional impact that adolescents may not acknowledge, while adolescents provide insight into subjective experience and motivation. Having established assessment procedures, let's turn to the critical question: what actually works in treating gaming disorders? The evidence base for treatment has grown substantially in recent years, though it remains less developed than for substance use disorders. The most effective approach appears to be combined cognitive behavior therapy with mindfulness interventions, followed by combined CBT with family therapy, then mindfulness alone, and then CBT as standalone treatment. For adolescents specifically, family-based interventions show particular promise. School-based prevention also works. Pharmacological treatments remain experimental and should be considered adjunctive rather than primary interventions. The key message for clinical practice: structured psychological interventions work. Family involvement enhances outcome for younger individuals. Early interventions prevent progression, and treatment should always address comorbid conditions. There are no quick fixes, but systematic, evidence-based approaches provide or produce meaningful improvement. Cognitive behavior therapy represents the gold standard for gaming disorder treatments based on current evidence. Cognitive restructuring helps patients identify and challenge these thoughts, developing more balanced perspectives. Behavioral components focus on establishing structure and alternative activities. We use activity scheduling to fill time previously spent gaming with rewarding non-gaming activities. Physical exercise, social activities, creative pursuits, these address the vacuum created when gaming is reduced. CBT teaches coping mechanisms for managing urges and negative emotions without gaming. This includes emotional regulation strategies, mindfulness techniques, problem-solving skills, and distress tolerance. Relapse prevention is built into the protocol from the very beginning. The CBT approach has demonstrated moderate to large effect sizes in reducing gaming disorder symptoms across multiple randomized controlled trials. Let me walk you through a realistic adolescent case that illustrates the assessment and treatment principles and practice. Our patient is a 15-year-old male presenting with school refusals, failing grades, and gaming 8 to 10 hours daily, primarily late nights into early mornings playing Fortnite and League of Legends. He's sleeping through school days, irritable when parents try to intervene, and has lost interest in soccer, which he previously loved. His parents report he seems depressed, he minimizes the gaming issue, saying everyone games and school is boring anyway. Assessments reveal he meets 6 of DSM criteria for internet gaming disorder, that is preoccupation, tolerance, failed control attempts, loss of interest in other activities, continued use despite problems, and deception about gaming time. He scored 38 on the IGD short form, well above the clinical cutoff. He also met criteria for moderate depression on the PHQ-9 and showed significant ADHD inattentive symptoms previously undiagnosed. The intervention combined multiple evidence-based elements over 12 weeks. Now, CBT with the adolescent addressed gaming triggers, cognitive distortions, and gaming and school and emotional regulation skills. We used behavioral activation to gradually reinstate rewarding activities, starting with low-effort activities like watching a movie with a family, progression to meeting friends, and eventually returning to soccer practice. Parent training was essential. Parents learned to set consistent limits with clear consequences and use positive reinforcement for non-gaming activities and school attendance and avoid power struggle. We developed a family contact, like gaming windows of 1 to 2 hours on weekends, only after homework completion and adequate sleep. Parents controlled device access. Sleep phase shift was critical. He had delayed sleep phase syndrome for months of late night gaming. We used chronotherapy principles, gradually advancing bedtime by 15 minutes every few days. Bright light therapy in the mornings and no screen 1 hour before bed, and melatonin 0.5 mg at targeted bedtime. This took 3 to 4 weeks to normalize. The adult case illustrates different presentation. Our patient is 24-year-old male presenting to treatment at family insistence after job loss. History reveals a 4-year-old progressive increase in gaming following college graduation, accelerating dramatically after he was laid off 6 months prior. Currently gaming 10 to 12 hours per day, primarily World of Warcraft, where he holds guild leadership positions. His impairment is severe and multifaceted. Comorbidities included significant social anxiety with predated heavy gaming and likely contributed to initial gaming escalation as a way to avoid anxiety-provoking real-world social situations. He also had chronic insomnia. He recognizes guild members depend on him as a leader and feels he is abandoning them if he stops. Behavior activation focuses on gradually reinstating real-world activities despite social anxiety. Importantly, we address the gaming situation directly. Economic restructuring was essential, and social support was key. His financial support decreased progressively, and this created a healthy pressure without abandonment. So addressing insomnia through CBT techniques, sleep restrictions, stimulus control, sleep hygiene, all of these were progressive interventions that eventually led to a very positive outcome. Here I'm sharing a practical toolkit that will help in the concrete strategies that you could implement in your clinical practice. For interventions, the therapeutic relationship is foundational, and stimulus control is among the most effective behavioral techniques. Alternate activity planning must be intentional and individualized. For adolescent, parent coaching is mandatory, not optional. Sleep hygiene deserves specific attention because sleep disruption is both cause and consequence of gaming disorder. Comorbidity treatment must be concurrent. Relapse prevention planning begins in the very first session. And finally, be realistic with patients about the recovery process. Let's discuss pharmacological approaches, emphasizing that medication management are adjunctive, not primary treatment for gaming disorders. No medication is FDA approved specifically for gaming disorders, so all use is off-label based on emerging evidence and clinical judgment. For comorbid ADHD, stimulant medications may be used and may improve gaming disorder outcomes by enhancing executive control and impulse regulation. Naltrexone, an opioid antagonist, is used in substance use disorders and gaming disorders and has been proposed for severe cases with compulsive craving features. Critical caveats: medication are never first-line monotherapy. Always combine psychological interventions, preferably CBT. Pharmacotherapy targets maintaining factors such as depression, anxiety, ADHD, and reward dysregulation, not the gaming behavior directly. Monitor carefully for side effects, particularly when medications lower the seizure threshold. Some individuals with gaming disorders have irregular sleep and nutrition, which may affect medication management, metabolism, and side effect risk. Finally, manage expectations with patients. Medications may facilitate engagement with therapy and reduce some symptoms, but they do not directly stop gaming urges. The hard work of behavior change still requires psychological interventions, stimulus control, and alternate activity development. Multidimensional family therapy has the strongest evidence base for adolescent gaming disorder. The theoretical foundation recognizes that family factors serve as both risk factors and maintaining factors for adolescent gaming disorders. Parental conflict, inconsistent limit setting, low monitoring, family dysfunction, and poor parent-child communication are all contributory factors to the gaming problem. Start family therapy by validating each person's perspective. Validate their feelings, then work towards shared understanding that gaming has become a problem, requires change, and that change will require effort from everyone in the family. I have included some preventive strategies on the slide for your reference. So if you need to review it, please take your time and reach back to me if you have any questions. Here is a summary of my presentation and hope it has been an informative session for you. I want to open up the discussion to the group with a few questions as an activity as to how do we differentiate high engagement in the gaming activity from the actual disorder. What markers in daily functioning tells us impairment is present, and how might treatment be different for adolescents and adults? Let's discuss.
Now, just to answer the question in the group, parents can help most by staying calm. They have to shift from battles about time to conversations about functioning. In a moment, stop the conflict rather than winning the limit-setting battle. They need to lower the voice, give physical space, pause the discussion, and let the teen not feel threatened. Do not remove the siblings. Do not break the barriers of connectivity within the family. And if you cannot safely de-escalate, that would require a third-party intervention, like a counselor, a psychologist, or even another community member. So all of these are interventions. First of all, the parents themselves need to realize their time and availability is a huge contribution to how we can manage the whole gaming scenario.
Thank you, Dr. Jinsey, for highlighting various important points in this gaming disorder. It is really the need of the hour. And gaming disorder is increasing day by day in our teens, adolescent, even in the younger age groups, like even less than 6-year-olds. I have seen how they are playing the games these days and how they are engaged. Even in the schools, they are provided with the laptops and iPads, and they are playing during the school time. Even when it is
Absolutely.
even when it is banned by the board, but still they are playing in the school here in the Canada, USA, everywhere. They are provided laptops, iPads in the school, and they are playing even in the school. They are that much addicted. So thank you for so much for highlighting the diagnostic criteria in detail for all of us, and the treatment regarding CBT and the parental intervention and sleep deprivation, how to control it. So thank you so much for all the points. And
thank you.
I invite Dr. Kunjulata, please speak a few words.
Yes, ma'am. Thank you, Madam Jinsey, for your very nice presentation. It was very informative, and we could know in details about the definition of gaming disorder in both the classification system, and you have also given the differentiation between the two classification system. You have also talked about the risk factors, various risk factors which lead to these disorders, and especially difficulty in emotion regulation skills of today's generation, because the new generation kids are, I think they are lacking in these skills, and the consequences lead to a lot of consequences we found in the new generation. They are especially their academic field and different type of psychosocial problems. And you have also told about the assessment of this gaming disorder with different scales, and especially you told that assessment is also needed in school level or clinical level also. So yeah, and You have told about different treatment strategies, especially the effective one was the CBT, and the family-based intervention was very important, as you told, because parental teaching is very important, and for preventive purpose also we need to inform the parents and especially the community people also. So the treatment also could be done from the school teachers and about early identification of the problem and all. Then you have also focused on relapse prevention measures. Then you have given various case scenarios where the problems were focused very nicely and how it was handled. And you have also included one practical taming toolkit. I think it will be useful for everyone. And you have also told that pharmacological management is not that important to treat this disorder, but especially with the comorbid conditions which need pharmacological treatment. Otherwise, CBT and other family-based interventions are more important. So thank you, Madam, for your very insightful presentation. Yeah.
I
I think
work
I'd
in
give a
school board,
personal.
and like I have seen a kid who doesn't know any words, who doesn't know how to read and write, but he knows how to play Minecraft. Like he
I
was
know.
playing Minecraft all over the day, anytime, just he wants the iPad to play the Minecraft. Like this much intensity the gaming disorder has reached. Like all the kids,
Yeah.
they are playing, they are using the words of the games like 6 7. The
Mhm.
words have been changed, language has been changed, the disorder has reached to such an extent. So thank you so much for highlighting the important issues in the disorder.
Yeah, there was a question and in the group, and I've shared the response in the group. So if anybody wants to read, it's the answer to the question that was open for discussion. So thank you once again for the opportunity. Dr. Sandhya Gupta, thank you so much for this podium, and I hope to have many more connections in the future. Thank you.
Thank you so much, Dr. Jinsey. You have participated here with all of us, and we are really delighted that your experience sharing will really help so many people present here. Thank you so much. Thank
Thank
you.
you. Take care.
Thank you, ma'am. Let's move on to the next session. Let me just share my screen. Soumya ma'am, can you confirm if my screen is visible?
Not yet.
Yeah,
If
it's
in
sharing.
screen.
Still sharing. Yeah,
Yes.
it's visible now.
Okay. Moving on to plenary session 3, after how to tame, we are going on to leadership challenges in the field of SUD in nursing practice. And this again will be an experience from the US. This session will be chaired by Ms. Elizabeth Assam. She's a nurse practitioner and president of Arizona Indian Nurses. She has 23 years of nursing experience, including 7 years practicing as a PCP in internal medicine. And precepting, teaching, and networking are her areas of interest. And the co-chair would be Dr. Taslim Sabit K. He's an associate professor in the Government College of Nursing, Ernakulam. And he's a reviewer for the ISBN Journal, state program chairperson for TNAI, resource person in national and international conferences. He's published papers in national and international journals. He has his MSc Psychiatric Nursing from AIIMS New Delhi and PhD in Nursing from NITE Mangalore. 8 years of PG teaching experience and guideship, and his areas of interest include addiction psychiatry and geropsychiatry. Over to you, ma'am and sir, to introduce the speaker.
Hi, greetings to all. It is my pleasure to welcome to an important session on leadership challenges in the field of substance use disorder nursing practice. As we know, substance use disorder nursing requires not only the clinical expertise, and we've been listening to so many experts so far about the clinical expertise, but it's time to shift the gear to leadership role. So this can navigate stigma, advocate for resources, support multidisciplinary teams, and ensure compassionate, evidence-based care for the most vulnerable population. Today's speaker, Dr. Tara Sargent, brings exceptional insight into these challenges with her extensive experience in mental health nursing and as being in frontline leadership. She graduated from Armed Force Medical College, Pune with BSN and obtained her MSN in Nursing Leadership and MBA in Healthcare Administration from Grand Canyon University, Arizona, USA. In 2018, she was awarded an honorary PhD in Humanitarian and Civil Rights. She is also a board certified in mental health. She's a dynamic healthcare leader, serving as the director and executive administrator of psychiatry, St. Catherine of Siena Hospital, and she's currently in that role. She also works in South Oaks Hospital, Northwell Health as an assistant director of nursing. She is an assistant professor in Long Island University Post. She's a licensed private pilot and has embraced the world of fashion, walking the runway at New York Fashion Week since 2023. She currently serves as the Vice President of National Association of Indian Nurses of America, NAINA, and has led numerous community outreach initiatives through NAINA and INANI, which is the Indian Nurses Association of New York. She's a seasoned debater. She has appeared on several national platforms, passionately advocating for healthcare issues. She has received several awards as a Community Leader Award, recognized by Global Indian Voice March 2023, recipient of the Johnson & Johnson scholarships to attend the Siena Academy, designed to develop strong executive leaders March 2022 and 2025. Congratulations. Women Weiger Award in Intellects category by Charles Walter Society 2022. She had received the Daisy Chapter Award winner for Advancing Health Equity Chapter Award 2020-2021 under her presidency of INANI. She had received recognition from Nassau County as a nurse leader in 2025. Please join me in welcoming our distinguished speaker, Dr. Tara Sargent, as she shares her expertise on this vital topic. Ms. Tara, take the podium today. Thank you.
Hello, you can hear me? Hello?
Yes, ma'am.
We can.
Yeah. Hi. Hi, good afternoon, good morning for us, and good afternoon and good evening to everyone. First of all, I want to thank the Institute of Psychiatric Center of Excellence of Kolkata and Dr. Sandhya Gupta for organizing such a webinar on age-related trends in management in addictive behavioral disorder and substance use disorder. Also, I want to thank for collaborating with NAINA, and as mentioned, I am the Vice President for NAINA, and also giving me an opportunity to be a speaker on this platform. The topic which I was asked to discuss was on the nursing leadership challenges the nurses face in the field of substance use disorder. Substance use disorder nursing specialty that requires not only a clinical competency, but also an emotional resilience, advocacy, ethical clarity, strong leadership skills. I will explain the major areas of this leadership plays a vital role in ensuring a high quality, compassionate, and equitable care. For introduction, I want to mention substance use disorder continues to be one of the greatest public health challenges in the United States and also worldwide. That's why we all are here discussing this topic. Nurses are central to prevention, early detection, treatment, recovery support, harm reduction, and crisis intervention. Because SUD care is complex and often emotionally challenging, and a strong nursing leadership is very much essential. The leadership in this specialty is not just managing the teams, it's about inspiring a culture of empathy, using evidence based practice, strengthening interdisciplinary collaboration, and advocating the policies that support patient recovery. I heard all the speakers many of them have mention a couple of the things which I have mentioned, but I have to go over which is more important and what we are experiencing here in US. Next slide, please. So, overview of our nursing practice. We have to be focused on prevention, treatment and recovery, high acuity, high risk patient population, and requires a strong interdisciplinary teamwork. The USA faces, no, not next, the previous slide, thank you. The USA actually faces a critical shortage of nurses trained in addiction medicine. We are very much way behind in it to have specialized nurses who just take care of these patients with SUD. Few nursing programs provided in-depth nursing education, SUD education, and also the leaders struggle to recruit, to retain, and to train the staff in MAT, medication assistant treatment program, detox management, and also harm reduction. Next slide. Thank you. The patient safety and clinical, it's generalized topic, which I just want to mention is we have to, the nursing, when we are dealing with it, we have to make sure the withdrawal complications, the signs and the symptoms, the nurses are aware of it. If any overdose events are occurring, the nurses should be aware of it. Co-occurring any mental illness like side by side coexisting my medical mental illness diagnosis, then safety protocols which must be consistent too. Next slide, please. So what is the importance of our nursing leadership? The nursing leadership is very important because it improves, number one, patient safety. We have to be dealing with to reduce burnout of the staff, support with the evidence-based practice, and guides the crisis decisions. Next slide, please. The leadership competencies. Now, why it is important for these competencies? As a leader, you should be able to promote the utilize the emotional intelligence. We have to systematically thinking and also advocate for the skill training and also the cultural competency. In US, cultural competency is very much important and emphasized on it because we do have various nationalities or various cultures being present here, and especially in all the hospitals, we do give importance for the cultural competency so we can understand and take care of the patient in their own beliefs, what they believe in. Thank you. Next slide, please. Policies and advocacy. This is another important topic for the leadership. Nurse leaders are expected to advocate to expand the access for treatment and harm reduction service, equitable care for marginalized population, because there is a disparity in the care for the minority population in US, especially with the Black, Latino, Native American, low-income population faces disproportionate rate of overdosing and also poor access to treatment. So as nurse leader, we must be able to focus on health equity, cultural competent care, and community outreach. The leaders also must address bias in the treatment. Sometimes bias can happen, and that needs to be addressed by recommendation and good referral practice. And also, we should be able to navigate regulatory and institutional barriers. Next slide, please. Ethical dilemmas. Balancing a patient autonomy with the safety concern. As my prior one of the speaker was saying that sometimes the patients are in denial. They don't want to seek the treatment. They want to don't want to go aboard with the treatment plan. So we have to balance it out. We have to balance the patient's autonomy, but at the same time, we have to make sure the safety will be a concern, and that has to be correlated, and we have to work on it. Also, maintaining the confidentiality and legal obligations. For example, out here, if a patient is admitted for a rehab or a detox, and if the family has reported him, sometimes the patient wants to maintain that confidentiality. He might not be reporting to the family that he is getting admitted. He might come secretly. He might seek treatment in the rehab center. But at the same time, the family has reported saying it's a missing person. When the police is coming to all these facility in checking this, we cannot give away any information to them whether the person is admitted or not. So those sort of constraints are there here without the legal obligations. We cannot disclose any of the especially with the mental health, we cannot be disclosing any of the information to any unauthorized. Even though there are authorities, we cannot legally reveal any information. And also the leaders are supposed to provide ethical guidance and decision-making supports. Next slide, please. Stigma and bias. Stigma for mental health, it's same throughout the world. I can say that. No matter what, when I was in India and when I came here, I'm seeing the same stigma is there. But things are changing as the generations are changing. And one of the biggest leadership challenge in SUD nursing is stigma. And many patients already face societal judgment, family rejection, and discrimination. And unfortunately, this stigma can also exist within our healthcare teams. As leaders, we must actively address these biases because stigma leads to delay in treatment, low quality care, and poor outcomes. So, effective leaders work to create a culture where patients with SUD are viewed with the same dignity and respect as patients with any other chronic illness. This includes providing education on addiction as a brain disorder, promoting trauma-informed approaches, modeling the non-judgmental communication. Now, mostly like SUD patients are often criminalized instead of treated. As leaders, we must compact the stigma within the institution, communities, and policy space. The nurses frequently must advocate for the patient in environment restrained to harm reduction practices. Also, the SUD nursing presents unique ethical challenges such as balancing the patient's autonomy with the safety concern, managing the confidentiality, as I mentioned before, a scenario, the addressing the relapse compassionately, and handling a situation of an impaired professionals. So we also must be responsible to create a framework for ethical decision making, offer staff training, provide a safe space for the nurses to discuss the dilemmas, and clear ethical leadership support consistent, fair, and patient-centered care. Next slide, please. As leaders, I think this may plays a major role in our leadership role is the workforce education, shortages, burnout, compassion fatigue, how we address all these things. These are the key challenges in preparing the workforce. Many nurse graduate with limited training in addiction medicine and motivational interview, harm reduction strategies, overdose preventions, management of withdrawal symptoms. We as leaders, we must prioritize building competency to that the nurses are well prepared to treat the patients with SUD. So to making sure the staff member receive ongoing professional development, stimulation-based training, access to mentorship form, addiction specialist in field where the evidence revolved rapidly, especially around the medication like naloxone, the methadone. We do have methadone clinics. Leaders must ensure that there is an ongoing continuous learning happening with the staff. And working with a patient who relapsed, struggle with co-occurring mental health issues, homelessness can be an emotional difficult. The nurse may experience compassion fatigue, moral distress, or burnout. For that, we have to create a supportive work environment. This includes how promoting a resilient strategies, providing a debrief opportunities, building peer support, encouraging self-care routine, ensuring a reasonable workloads. Healthy nurse is essential for providing a high quality care. I do, you all will agree with that. Now, workplace violence and safety concern is another pressing issue which we are facing out here. Recently, you would have heard about an incident where in Florida where a nurse was physically abused very badly, and that patient was a substance abuser. And so the nurses, not only in the emergency room, in detox, in psychiatric setting, everywhere they are facing verbal and physical threat. And also leaders, as leaders, have to ensure safety protocols are in place, adequate staffing and training in de-escalation, where we do have various programs which are each hospitals usually take in place, that CPI, PMCS, New York State has its own trust, which the government, OMH, Office of Mental Health, has developed a good training, which we have to undergo for 1 week, which is very useful, which is just rolled out last year, and that is gaining popularity among all the hospitals who has these psychiatric facilities. Now, the policy and regulatory barriers in US, we do have a lot. As leaders, we have to engage in policy advocacy. Access to treatment is often limited by law, stigma, and financial barrier and lack of insurance. As leaders, we have to advocate for increased access to medication assessment treatment, support policies, and mental health services. There is a confidentiality law, which is especially in the US, which requires strict protection of SUD treatment information, which I mentioned a little while ago about it. And also there are various ASIN agencies like SAMHSA, NIDA, State Regulatory Board. And as nurse leader, we play a key role in pushing out an equitable care for marginalized and underserved communities. Next slide, please. Next slide. Yeah, interdisciplinary collaboration, which is very, very important because effective SUD treatment depends on teamwork. Nurses, physicians, psychiatrists, social worker, peer recovery coaches, therapists, pharmacists, community agencies, all must work together. So one of the biggest leadership challenge is breaking down the communication barriers too, because as leaders, we have to encourage integrated care plan, support collaborative decision making, promote a respectful communication across the discipline. And when a team functions cohesively, the patient outcome improves significantly. Because also there is in US healthcare system, it's fragmented. When a patient care is delivered in the hospital, because multiple disconnected settings are there: hospital, outpatient, detox center, shelters, jail, and home. So there is a challenge in coordinating patient care across all these systems. Next slide, please. Okay, technology and innovation. Telehealth has transformed the way SUD care is delivered, especially the post-COVID. However, it introduces the several leadership challenges. One is ensuring access of patients who lack access of technology, because most of the patients which we come across with the 30 to 40% have homeless, or they don't have, because of that they don't have access to technology, or they don't have access to equipments which needed, where we can have the telehealth care. Training nurses to conduct a virtual assessment, including withdrawal scoring and safety check, is very important. Navigating from state to state telehealth regulation, because each state in US has its own regulations. So when a patient moves from Florida to New York, or from New York to New Jersey, the laws are different. So we have to be very much aware of it. That needs to be, the healthcare workers has to be aware of it. And privacy law, reimbursement rule, because to maintain a therapeutic rapport and also engaging in the virtual setting, we have to create a protocol, maintain the quality, advocate for the telehealth coverage through Medicare and private insurance. Here, mostly mental health is covered by Medicare and Medicaid, and on some private insurers are also helping the patients out. And lately, there is a wearable technology which was introduced for the patients to wear, where if patients are overdosing, the symptoms are being detected by this wearable technology, and it is transmitted, and the help is being reached out to the patient immediately. But unfortunately, the insurance doesn't cover it, and so it is out of pocket expense, and which is expensive. So it is not like a famous wearable among the SUD patients. The next, please, next slide. Okay, these are the few, like what I mentioned already, the implementation of the effective leadership strategies. It's like just summarizing it. Next slide, please. So implementing the evidence-based practice. Evidence-based practice is very much essential in my SUD nursing, but implementing it can be challenging due to the resistance to change, lack of training, and institutional constraint. So the leaders must champion evidence-based intervention like SBIRD, MAT, overdose protection, prevention, trauma-informed care. And also they might promote quality improvement projects, data-driven outcome, and staff education, which is very much important. Next slide, please. Next slide. I already mentioned about it. Okay, resource and funding limitation. Out here in the US, mental health is treatment is a very expensive treatment. So most of the time, the insurance has a limitation, and it is mostly it's a government support funding which helps the patient, especially with the SUD treatment, which has been supported. So as leaders, what we are expecting is to optimize the limited resources, to build partnership and seek funding opportunities, and regulatory barriers are there. Although, like, there are limitations, as Jackie Michael mentioned before, like when we are prescribing certain medications, there are limitations in it. So we have to navigate federal, state, Medicare rules that also differ from state to state. And many SUD treatment requires insurance approval, causing delays, and patient can lose coverage when insurance lapse or when the patient relapse with the episodes. And also the funding shortage. That funding shortage, it's like a chain event which happens. Like funding shortage, it results in the hospitals to short staff. When the short staff, then the treatment is getting affected. So, as leaders, we have to be resourceful. We try to get all these grants which are being provided by the using the grant. Then we try to communicate, partner with the community partnerships. Then create creative staffing models, advocate for budget allocation, and also we lead involves a farm finding way to deliver an effective care even when the resources are limited. The last slide. So to conclude, the leadership in nursing is both challenging and deeply meaningful. Strong leaders advocate for the patients, support the team, advance policies, and promote a humane, stigma-free environment. By embracing our evidence-based practice, leading with compassion, and fostering collaboration, nurse leaders can create a lasting improvement in SUD care and positively impact the life of countless individuals. Thank you. Thank you for this listening to me. And if any questions, and if I know there are so many regulations statewide, there are which I couldn't explain in this limited time frame. It's a vast topic which I have to cover, but I couldn't make everything in this short span. But I'm available in case if I can put my email in the or my informations were there in the first slide. So if you are wanting to reach me, please reach out to me. Thank you. I will share my email in the chat box.
Thank you, Dr. Chera Sajan, for an amazing, excellent presentation on the leadership challenges and how to overcome those. I'm welcoming the attendees to free to unmute yourself or type your questions in the chat if you have anything for Tara, or kindly use our email to send your questions, and we'll be gladly able to help you.
I don't
see any chats yet. So I just want to take a moment to rewind today's session. We explored the key leadership challenges impacting substance use disorder nursing practice, from navigating stigma and workforce shortages to strengthening interdisciplinary collaborations and ensuring consistent and evidence-based care. I very much thank Dr. Tara Sajan, how you mentioned about SUD behavior is patients feel like they are criminalized, and often they feel guilty themselves that they are doing something wrong. So that also is a roadblock, how they take the initiative to get help from the experts, or even their family members also stigmatize, saying they're just in the wrong path. You have highlighted the importance of strategic leadership, stressed about leadership competencies, the importance of policy and advocacy, the ethical challenges faced by the leadership, and the guidance you have in place to create a supportive environment for the nurses to empower to deliver the highest quality of the SUD care. So the insights you shared today have provided us with both clarity and direction on how we as nurses and also as nurse leaders can move this work forward within our own organization to take the points, what we have learned from you today. And I congratulate you again for all the work you do behind this SUD nursing and the leadership you have provided to the U.S. community in New York, as well as to NAINA. Without the tech support, this would not have been possible. I want to extend my thanks to the co-chair for this session, Dr. Tasleem Sabit, for all his support. I would also like all the participants for the engagement and here today and being here. It's very late for many of us. With that, we will conclude this session. Please stay connected for the next part of the conference. And thank you again for your commitment to advancing excellence in SUD nursing practice.
Thank you. Thank you so much.
Thank you, ma'am, and thank you, sir, once
I have
again.
a question, Tara. How it will be? A person will be assisted by Mediclaim or medical help through government. How many times for treatment? Is there any limit?
There's no limit as such. Like that is one advantage they have, but there is a limit in the reimbursement. Like for like each hospitalization or for the treatment, there is a limit. So once the patient reaches that limit, then we have to seek alternative treatments. Like either the patient cannot be in, or he has to be seeking outpatient treatment, but for the detox rehab, there is a limitation. But after that, like as an outpatient, each sessions, like if you are in an IOP patient or an a PROS patients, then there is a capping for each sessions. We can bill for certain amount for the service.
I want to quote the statement of a psychiatrist from USA. He says that in USA, if patient is carrying a gun, we can't stop it. So he says that
No.
whether the patient is suicidal, whether the patient is using drugs or the person is schizophrenic, they can easily carry gun and do whatever they like. We can't do anything. Second
No,
thing,
no, no, no.
said that every patient is so independent that we can't do anything without their consent.
Yes.
In the sense that even if they are dangerously making wrong decision, even then they can't do anything, he said.
Dr. Sandhya, I have to inform you, but what is the information you have is wrong.
No,
Apparently,
he
there
can't
is
be wrong. I'm sure he was giving us example of cases that he is tackling.
yeah, actually there is a safe act. And all as a provider, we are supposed to be reporting now to the state that saying that this person is not safe enough to be handling any arms. So it is a countrywide database. So if their name, the details, and then the problems will be mentioned in it. And when they go to buy or purchase, they will be screened. They are being screened, so they cannot have it. But then, so that database is now generated and it is well in effect. And also, a patient has a right to say no. But when two psychiatrists together say, no, this patient requires treatment, they can go under 2PC, involuntary status, treatment over objection. They can take them to the court and they can get them treatment. But patient has a right, that's a patient's right. But at the same time, if he deemed to be unsafe for himself, or he can be not safe for others, for the community, then the doctors have the right, the provider has the right to take them to the court and get them treated.
So patient, you think the doctor will go to court for
Yes.
making the patient to agree? Because there is no role of family member after 18 years in USA.
In the USA, there is no role of a family member, but the provider has the right to take the patient to the court to treat if he is really danger for himself or for others, and the patient doesn't want to take the medication. There are 2PC status, that's a legal involuntary status. So that's with using that status, the doctors usually present themselves to the court and plead on that case, and then the court orders the medication. And if the patient is not taking by mouth, we have to give it by IM.
Maybe this is recent rule. This is 3 years back. I have met that psychiatrist who gave this example. I mean, he was discussing his frustration.
Might be not from New York then.
Yes, exactly.
Yeah.
I was about to say that this is Uma, by the way, Uma Venugopal. I just wanted to share, thank you, Tara, for actually sharing that insight. And I do wanted to make it specific that the law out here has its own limitations that differs from state to state,
State to
right?
state,
So
yeah.
yes, so it's very important to be aware of that. And as we work with these patients, it's very challenging, as you said, yet it's very important that we work closely with the provider hand in hand to ensure that, as Tara again mentioned, that having that able to document saying that the patient is incapacitated or what, right? So making sure that we clearly document that actually I had to take a patient to the court, and we went with the physician. I had a legal attorney and myself and the physician who went over there, and we made sure that we explained to the family the situation, and we informed them this is an unfortunate situation, but this is what the problem is. The patient is quite unsafe to be sent home because the mom, it's actually, I'm talking about an Indian family, and you know the culture, right? It's a stigma to send the kid or be as a patient to the a rehab center or whatever it is. So it's very hard to convince the parents, and it was a challenge. It took us at least a good week to convince them, to help them understand that this is so important as parents for them to provide. We need to provide safety for the family, right? And to the staff as well. So we were able to convince them, and we got 2 physicians, so psych practitioners actually, who provided the documentation that the patient is incapacitated. Then we took them to the court, and we had to provide medications, and it was involuntary commitment. That's what we call the word as. It's called the involuntary commitment, where we sign the patient up to the rehab. And once the patient is actually relieved of all the illness, or at least there is some improvement, then they will be able to be brought back actually. So it's a challenge, but yeah, there is a way. It takes time, but just wanted to keep you all informed about it. Thank you so much. Sorry to take your time away, but yes.
Dr. Taslim, you may conclude.
Yeah, actually, it was a very wonderful session. Thank you, Tara ma'am. Actually, I was overloaded with a lot of information. Actually, when we think about the mental health nurses, we rarely look into the nurse leaders, how they will take the decision. So she had clearly explained how the crisis decisions are taken. That is a very important point, I think. And the role of emotional intelligence. All these are really needed for a leadership. And she had detailedly explained about the workforce shortage, the safety concerns, and breaking the barriers in communication. So it was a really wonderful session. Actually, it should have been a 1 hour session, but unfortunately, we have only 20 minutes. So I really wish to be engaged in session. So at this late time, I am thanking all the experts. Thank you, Sandhya ma'am, and other experts who had commented on this topic. So we are winding up this session. So keep connected for the next session. Thank you. Thank you, everyone.
Thank you very much, Tara. Thank you.
Thank you. Thank you.
Thank you very much. Now we have an exciting session next. We are going to announce the winners of poster competition.
Once again, a very good evening to everyone. As ma'am mentioned, this is going to be a very exciting session because it's going to be a poster session presentation. So for the poster presentation, we have 2 very important coordinators who had coordinated the poster presentations. Dr. Jyoti Khatwal ma'am, the assistant professor from AIMS Bilaspur. She is a Nursing Ratna Awardee of 2023 from NTAI. She's got a Commendation Award for Best Services in COVID Time 2021, Best Paper Awardee in 2015, second prize for her research paper in an international conference in November 2021, first prize in ECG Interpretation 2020, first prize in Wound Care for Nursing Education Program, and she has received a lot of appreciation certificates, including Medical Relief Education Camp from the Punjab DEO for Education Innovations and National Institute of Disaster Management. She has developed SOP for Siloam Hospital, Indonesia. She has authored 3 books, 3 information booklets, and has contributed 11 chapters in 5 different books. She is a master trainer on simulation-based education, COVID-19, mental health, as well as Omicron. She has a rich experience of 23 years, and her areas of interest include virtual and e-learning programs, patient education, innovative teaching learning strategies. Along with her, we have Mr. Sandeep Dolipara, nursing tutor from LGB RIMH from Tejpur, Assam. He has 9 years of teaching experience after PG. He's been a guide for PG nursing trainees as well as a course coordinator for courses under Digital Academy of Psychiatric Nursing. His areas of interest include adult psychiatric nursing, aggression in inpatient units, digital teaching and learning. Sandeep sir, would you want to introduce the judge and the...
Good evening. Good evening, everyone. Let me introduce the judge for the poster session. Madam Dr. Sandhya Gai. Madam is a former senior advisor, consultant, nursing regulations. Madam has more than 41 years of teaching experience, and she has completed a PhD Nursing Service Administration, MSc Psychiatric Nursing, MA in Public Administration, and Madam has more than 150 papers and presentations. Madam is also guide for PhD, MSc Nursing, Masters of Hospital Administration, and for BSc trainees. Coming to the achievements, Madam had Basanti Rai Award for Best Thesis in MSc Nursing 1989, Best Poster Award, International Conference on Nursing Emergency Medicine, Fellowship of Indian Society of Psychiatric Nursing, awarded at 19th Annual National Conference of ISPN at Moradabad, Lifetime Achievement Award in recognition of outstanding academic, clinical, and research service organized by Institute of Nursing Education and Research in New Delhi, 2016. And Madam area of interest psychiatric mental health nursing, de-addiction, nursing administration, intensive care nursing. I welcome you, ma'am. Let me also introduce our chairperson for the poster presentations, Dr. Sumiti Arora. Dr. Sumiti Arora, former faculty in College of Nursing, DDU Hospital, GNCTD, New Delhi. Madam has been awarded with the Research Ratna Award in January 2019 for Best Research in Community Mental Health Nursing. She was formerly Associate Professor in Holy Family College of Nursing, Delhi, MSc Psychiatric Nursing from AIMS, Delhi, PhD Clinical Psychology. She's the coordinator and resource person for various national and state level workshop, master trainer for nurses for substance use disorders, care for older adults and diabetes care. Madam has written various chapters in books, modules for Ministry of Health and Family Welfare, IGNO, published articles in national and international journals. Madam area of interest is mental health nursing and addiction. I welcome you, ma'am. Next slide, please. Let me also introduce co-chairperson and my dear friend, Dr. Chanantabam Padmini Roy. She's a nursing tutor as well as working in LGB Regional Institute of Mental Health Tejpur, and she's a good colleague of mine. Dr. Padmini has experience of 7.5 years in tertiary mental health institution. Her area of interests are research with persons with schizophrenia, family members of persons with mental illness, and rehabilitation. So these are the panel of experts that have evaluated the posters. All in all, we have received 18 posters for the poster presentation, and I request Sandhya Gai ma'am to go with the announcement of winners as well as the quick feedback on the posters you have received.
Greetings of the day to everyone. It was a privilege to serve as a judge for this poster presentation in 4th International Virtual Nursing Conference. I sincerely appreciate all participants for their insightful presentations, strong research efforts, and commitment to addressing critical healthcare challenges. And it was a tough time for us as judges to provide the results, to evaluate them. So based on the evaluation criteria, the positions have been awarded to the participants who demonstrated exceptional relevance, scientific accuracy, and effectiveness in communication. I congratulate the winners and commend every participant for their valuable contribution. And at the same time, I want to give the results of the first winner. First winner is Monica Thakur. A big applause for her efforts.
Thank you very much.
In this area. And the second award goes to Miss Aarti.
Thank you, ma'am.
And she has also done the good work, good efforts. And the third person is Miss Alfia Parveen Ansari. So I appreciate everyone, but these three were judged as comparatively better. So we have given these results. And I also thank the organizing team for creating such a meaningful and enriching platform, especially Dr. Sandhya Gupta, who has given me the opportunity for this job, for judging the posters. Anyway, now the participants who have scored first and second positions, they have to present their work just in a short minute, 1 minute time.
Dr. Sadhya, your video is on, but you are not visible. It looks like something is wrong in the setting of the camera.
Yeah, something is wrong, yes.
You know, next to the camera on top, there is one more point. Sometimes if we move it there, it happens like that. Next to the camera, there is a spot in the laptop. Okay, who is this person? Is she present for presenting?
Aarti madam, if you're present, kindly unmute yourself.
Unmute and you can talk.
Yes, ma'am.
Bring it in presentation mode.
Ma'am, am I visible?
Yes, you're visible.
Oh, yeah. Please share the poster in full form.
Yes, ma'am, I'm trying. Wait. Can you wait, please?
I have to make her co-host then. Okay. You're already co-host, no? You can share.
Ma'am, is it visible?
Maybe. Now, yes. But it is not in presentation mode. You know how to make presentation mode?
Yes, ma'am. Ma'am, is it?
Do you know how to make it presentation?
No, ma'am. Ma'am, I'm
Sandeep, why don't you share?
Ma'am, my system is behaving now.
Oh, okay.
Actually.
So give it to Hana ma'am.
Yes, ma'am. It shared with Hana ma'am.
Yes. Now speak, Arthi ma'am.
Ma'am, okay, first of all, good evening to everyone and who are there in this this who are there in this
Aarti,
presentation.
you have just 1 minute.
Yes, ma'am. So my poster explains the role of nurse as a safe space for women battling addiction. So what I have mainly focused means, because women are the one we are not focusing in this subject of addiction. So I have focused women in this poster presentation mainly. So my aim is to explore how nurse can act as a safe space for and help safe space and help them to recover and gain confidence for a woman battling addiction. For that, I have referred some studies, and I also have presented my studies. The main points I have to share is, in this future our nurses are empowering very much, so that we can initiate nurse-led safe homes, mobile de-addiction vans, digital de-addiction support rooms, skill development and employment centers. So we can also teach the addicted women's family how to help them to de-addict. And we can also nurse in the future can also help plays a role in creating a home for the home and prevent women
Bhavna, can you share, please? We cannot see.
Ma'am?
Ma'am, yes, ma'am, sure.
Your 1 minute is over. Have you explained everything?
Yes, ma'am.
Okay. Congratulations. You have done very well, but we could not see the poster.
Sorry, ma'am. I'm a first year student. Actually, this is my first presentation, and I can't just show my poster. I'm very sorry. I'm very
No, you
nervous.
don't have to be sorry for this. We are very happy that you have the courage to participate, you have courage to speak, you have courage to present yourself. I really appreciate that.
Thank
Technology
you.
we all can learn slowly. Don't worry. Okay, so that is the next slide. Next one. That's it.
One more slide is there, ma'am.
Please change to next slide. Okay, wonderful. Wonderful, wonderful. Okay, let's have the next winner.
Thank you, ma'am.
Monica Thakur.
Very good evening to all the dignitaries, respected faculty members, and all the respective delegates present here. So I'm Dr. Monica Thakur, and I'm teaching psychology from last 4 years exclusively to nursing student and physiotherapy student as well. So from past 4 years specifically, what I'm observing, and when I have completed my education, there's a huge shift in the education and how the students are relying on technology a lot. But there are very difficult and worrying side about it. So the question which is coming to my mind for a very long time is, does AI use influence cognition, drive behavioral addiction, and impact mental health among nursing students? So I come up with this question, and so I decided to do a systematic review about it. So when this all energy was fueling inside me, at the same time there was one study published by MIT school stating that there's a cognitive decline in the brain regions, which shows higher dependency with the AI as well. So nowadays we are much more dependent on tools like ChatGPT, Perplexity, Gemini, Chatbot, and multiple clinical simulator as well. So what I'm observing from my end, that there is a compulsive use, there's a cognitive over-reliance, and there's a reduced self-control, and it is affecting not only the learning but also the mental health of the student. So what we did is, we conducted a systematic review where we followed the PRISMA guideline of 2020, and the prime variable which we have taken into consideration was AI use, dependency, cognitive efficiency, mental health, psychological, and academic impact. So after doing a proper screening, identification, eligibility, we come down to total 20 number of studies. And finally, the finding which were there was similar to what I have been hypothesized in the beginning. So the prevalence and behavioral pattern was 42% addiction at moderate level, 23% at severe level, and the highest impact was in the academic dependency. The major domain which were impacted were sleep disturbances, academic dependency, decline in the peer interaction, reduced self-efficiency, mental fatigue, which was near to 52%. And this was a weighted mean percentage. Also, the other domain which was impacted were the reduced interaction with the peer and lower self-efficacy. Cognitively higher AI use was associated with reduced attention, less help seeking from teachers, weaker retention, recall. When AI replaced personal note making, problem solving, and creativity were lower among high use groups, indicating cognitive outsourcing. Behaviorally frequent users reported compulsive checking, difficulty disengaging, and discomfort without AI. And if it is used at a moderate level, it has shown the good kind of AI use. So what we can see here is from the finding that cognitive offloading need to be done with student relying on the AI for explanation and task, reducing engagement of attention, working memory, and deeper processing. So if I have to cut down this discussion into just 2 to 3 points, so I think cognitive decline is surely there. So we have seen the physiological decline, but this systematic review particularly suggests that attention among the student, impulsivity among the student, memory, there's a huge gap between the student. So this was my personal observation, but this particular study have found out that yes, there is a disturbances in these core domains of the cognition, and also there is a huge change in the psychological well-being among the student. So we as a faculty, we as future nurses, we need to focus on how our student know the digital well-being and how they can ethically use the AI properly. And we also need to come up with some sort of evaluation form or technology where we can moderate their use in an effective way, rather going for the dangerous side of AI, because we have to prevent this kind of damage among the student, and also harness the best side of AI which we can provide. So in the game of too much dependence on the AI, we should make sure that we are not outdated when AI is getting updated. Thank you very much. In case anybody have a question, please put.
No
I'll put the
questions are
mail
allowed. No
ID.
questions are allowed. With poster, no questions are allowed. Thank you very much, and you have done very well, and with very thoughtful work you have done. Thank you very much. Take it
Thank you,
forward.
ma'am.
And I really thank Dr. Sandhya Ghai and Dr. Sumiti and Mr. Sandeep and Dr. Jyoti Katwal, who have done this great job of analyzing and scoring. Thank you very much. Congratulations to all winners. We'll see you all tomorrow. And maybe for today, we call it a day. Thank you very much for staying with us till this time. I hope we have much better attendance tomorrow. And we meet at 2 o'clock tomorrow. But tomorrow we'll finish at 9. We will not delay tomorrow. Thank you. So, Advina and Hannah.
Yes, ma'am.
Can we just see that? And Soumya, these 3 pillars have helped us to go through the whole day. And of course, Sandeep, Ranju, and Lakshmi, Taslim, they have also done great job of making this day possible. Thank you very much. God bless you all. See you tomorrow at 2 o'clock.
Thank you, ma'am.
Have a nice day. Thank you, everyone.
Thank
you so much.
Bye. Take some pictures. Videos are open. Take some pictures. Take some pictures, please. We'll have good memory of good work. Try to take many frames. Please open your
Thank you,
videos. Try
Mom.
to take many frames. Try to cover everybody.
Thank you,
Good
Sandhya ma'am,
night.
and thank you all organizers. Very well done. So thank you
Bye.
for all your teamwork. Good night, ma'am. Good night, everybody.
Good night, ma'am. Thank you, sir.
everyone.
Thank you, ma'am. Thank you, everyone.
Lakshmi.